Dr. Gunjan, can you just call up Dr. Madhu ma'am?
Yes, ma'am.
You can keep yourself muted.
Ma'am, you are live now. Ma'am, you are live now.
Yeah. Good morning, everybody. On behalf of the Gujarat chapter of the Women Ophthalmologists Society, I welcome you all to this WAS Gujarat chapter resident competitive program, which is the third in the series. The first one happened in January by the MP chapter, and the second one happened just recently in February by the UP chapter. And today we are the third in the series in Vibrant Gujarat. WAS has always believed in supporting, uplifting, motivating, encouraging, mentoring, and helping the women ophthalmologists to step out of their comfort zone with confidence. In spite of us being primarily a society for women ophthalmologists, we are not a gender divide platform, which needs to be kept in mind, because we believe that each individual, irrespective of the profession and the gender and the age, does need support and mentoring. And that is why we have been having in our team and all our activities, men and women all alike, contributing and participating alike. WAS has been doing many innovative, inspiring activities since its inception in 2016, and its major ones have been based on this concept of mentor and mentee. And these resident sessions, these programs are one of those types. Though we have provided a competitive element to keep the spirit high and the excitement still higher, the main purpose is to provide the young to-be professionals a taste of the outside world, that is outside their routine working grooves, provide them an opportunity to be under the podium limelights, and of course, learn from the mentors and the stalwarts who are going to be on the platforms and part of all programs. We do appreciate the enthusiasm and motivation given by all the faculty mentors who have supported the students for today's presentations. And along with a power-packed 35 mentored presentations from 10 medical colleges across Gujarat, we'll also be having certain informative talks by invited stalwarts. So all in all, making it super interesting and action-packed day to day. So before we move on, and I think Dr. Madhu ma'am is yet to join. Till then, I'd like to invite Dr. Meenakshi Dhar. Each innovative idea and action that happens always has one or more super brains behind us. And so does this set of resident programs. And we are fortunate to have with us one of these super brains, Dr. Meenakshi. She is a pan-India senior ophthalmologist. Earlier, she was working in Kerala in the Amrita Medical Sciences Institute for 2 decades, and now she has moved on for another new venture to Faridabad in the north. She has more than 28 years of teaching experience and has done various observerships in the UK and US. And her specialty fields of interest are glaucoma, pediatric, neuro-ophthal, squint, and cataract. And she's a regular invited faculty at scientific programs of various levels. So I request you, Dr. Meenakshi, to share your valuable ideas about this entire set of programs that we are having and some take-home pearls for the residents of today. Thank you.
Thank you, Dr. Purvi, for those kind words. It's always a pleasure to be a part of WAS ventures, and I'm so happy that this resident program has taken its own wings and it's now flying. Dr. Mohita's brainchild, as usual. We had thought of this around some months back, and we never thought that this will take its own wings and fly on its own. So it's on autopilot mode now and doing so wonderfully well. To think that we had one just a couple of weeks back, we have one the Gujarat chapter today, and a week later the Delhi chapter. So the kind of enthusiasm and the kind of response it has evoked, it's really wonderful. And in these days after a COVID pandemic, this is such a good platform to be able to exchange views. And earlier the students used to get an opportunity to go from one place to another and attend things. This is actually in many ways better. Of course, it prevents interaction, but it allows you to be wherever you are and still be able to get updated. And my few pearls to the residents are, when you take up a case, try to be very methodical, go step by step, think of common things. And as I usually say that if you think of a rare diagnosis, you are rarely to be right. So think of whenever you're approaching a patient, go methodically, take all aspects, remember your basics, and in 99% cases, you will reach the correct diagnosis and management. And when you are presenting, it's actually a skill and art to present cases. And when you go for your exams, it's the way you speak, it's the words that you use. Make the examiner take your path which you are guiding towards. So know your strong points, and you can guide the examiner to ask you in such a manner that it actually you are able to perform your best. Remember, you get around only 5 to 10 minutes to put your best foot forward, and that's what you should do during that time. I wish the Gujarat chapter, today's events are really, it's a wonderful set of cases, and we have an action-packed day. And thank you, Dr. Purvi, and the whole of Gujarat team for putting up such a great thing together, and best wishes for the whole program. Thank you.
Thank you, Dr. Meenakshi. Those were wonderful inputs about the WAS opportunities for residents as well as important pearls. So now, so those were wonderful pearls, Dr. Meenakshi, and I suppose the residents of today, from these small tips and pearls that are going to be shared all through the day, they are going to learn a lot and benefit a lot. Dr. Madhu ma'am is having some connectivity issues, so she'll try to log in and join us whenever she can, and she has requested us to keep moving forwards. So I would now like to introduce the chief moderator for today, who has been my backbone for this program and is also going to be the connecting bridge for all today's sessions and talks. So that is Dr. Gunjan Tak. Dr. Gunjan is an assistant professor in one of the corporation hospitals here in Ahmedabad. She has also been a student and my working colleague for quite some years, but then she chose to shift places and go off to another hospital and college. She is also an executive committee member of the Ahmedabad Ophthalmic Society and the Women's Wing, that is the WDW of the IMA at Ahmedabad. She is also pursuing her PhD and a hospital management course. So a multifaceted and multidimensional personality. And as you will soon witness her engagement and the way she conducts the program, you'll realize she is very active, dynamic, and an ever enthusiastic faculty with a never say no attitude. I now request Dr. Gunjan to please take the show forward. And here, before handing over, I'd like to welcome Dr. Mohita Sharma, the Executive Secretary of WAS. Hi, Dr. Mohita.
Hello, Dr. Purvi. How are you?
Good.
Okay. Let's get started.
Yeah.
Good morning, everyone.
Good morning.
Good morning, ma'am. Today we are on as a part of World Glaucoma Week and as also part of and before International Women's Day. We are here with the WAS Gujarat Chapter Resident Competitive Program, and I invite all of you for the same. Our first speaker today is Dr. Rohit Shetty, sir.
Dr. Tejas has joined, I think, so we can request him to officially kind of raise the curtains and let the show begin. Yeah. Good morning, Dr. Tejas.
Yes. Good morning, one and all. Well, yeah. So, well, I was the curtain raiser. It reminds me of only two things. One is catch them young, and second is encouraging them to the fullest. And this program of WAS is actually doing the same. I'm so happy to see so many of the youngsters getting involved in such activities. It was probably not at this level before a few years. So I wish all of them all the very best, and the best may win. But of course, all those who do not win today, make a vow next time. With these words, I would like to hand over to the moderator and have a rocking session. Thank you. Signing off.
Thank you, sir. So we have our first speaker, and he doesn't need any introduction. We welcome you, Professor Dr. Rohit Shetty, sir. Sir is DNB FRCS PhD. He is Vice Chairman, Clinician and Translational Scientist, GrowLab, IBMS Lab, Narayan Nethralaya, India. He is additional professor at Maastricht University, the Netherlands. He has over 250 publications in peer-reviewed journals and is a reviewer for many index journals in the specialty. He is also on the editorial board of Journal of Refractive Surgery. Awards are many, but the important are called Rangachari Award for overall best paper of the conference for his work on Is Inflammation Driving Keratoconus, a holistic study of molecular pathways at the 2015 annual conference of All India Ophthalmological Society, and Casbear Award for Outstanding Contribution in Refractive Surgery by ISRS in 2019. Sir, we all are very eager to hear you. We welcome you, sir, on behalf of WAS Gujarat chapter.
Thank you, madam. And at the onset, I would like to thank the WAS team, Dr. Madhu, Dr. Mohita, and Dr. Purvi for organizing this meeting. I would start off my talk on Pearls for Residents, because what I believe is each one has to drive your own destiny, and each one knows how to do it, because all of you are not in kindergarten or not in school anymore. But still, in the 6 minutes I have, I would like to bring in the concept of 5 C's. 5 C's, the first one is stop comparing. That one thing which I realized in today's younger generation of residents, fellows, and it goes on because this becomes part of your DNA, is when you start comparing yourself, you start losing the joy of doing work, joy of doing studies. So comparison is a thief of joy. You know, your colleague does faster FACO, faster SICS, that itself kills you from your real aim. So the first one is the compare. Never compare. I know it's a philosophical, metaphysical way of talking, but you start at least making 1% change a day. If you stop comparing with one thing a day, maybe when you reach 5, 6, 7, 10 years, probably you'll stop comparing. So you can't just stop. Even I.
Sir, I think some connectivity issue.
Yeah, I think he got.
Hear me now? Yeah. This is the poor connectivity. Can I hear you? Hear it now?
No, not.
Am I audible?
Yeah. Now
Yes,
it's better. Yeah. Please carry on.
And the second one which I would like to say is stop complaining. That's one of the second major problem with the challenges with the students today, is that you start complaining. Whenever I do an interview, am I audible?
Yes.
Some interruption is there.
Am I audible? Can I just leave it?
Yeah, please, you can just log out and log in again, if that's possible.
Is it better? Can you ask somebody else to do it? Then
Yeah.
I'll log in from different
I think
source and I'll
it's
come
fine
back.
now. It's fine now, I think so.
Yeah. Yeah. So second one is about, complaining. Many times we start complaining. What happens is, am I audible or is still the same?
Yes. No.
Yes.
It's fine now.
Yeah, so it's second one is all about complaining. When I interview people, one of the major challenges what I see is people start telling that this was a COVID batch.
I think we have lost him again.
Can I call, sir, or?
Yeah, I think you can just call him and you can sort it out. And meanwhile, Dr. Mohita, should we proceed with your talk?
Yeah, I think he sent a message that he'll rejoin a little later. So I'll get started till then.
Yeah. Okay.
Fine.
So I would take this opportunity to welcome Dr. Mohita Sharma. She's the heart, mind, soul, and spirit of WAS as its founder general secretary. And I have been a witness that amidst lot of resistance and criticism, she has stood steadfast and led the society to where it is today, at the top and on a global platform. And under her strong and dynamic leadership, WAS has given wings to so many individual women professionals as well. She has actually given true meaning to the statement that you are not alone through the concept and the society of WAS. Individually, she is also the chairperson of the Tirupati Eye Center at Noida. And I would just like to say thank you so much, Dr. Mohita, for giving all of us WAS. So I request you to share some of the opportunities that WAS provides to everybody and to the young professionals in particular.
Thank you so much, Purvi. And everybody, welcome here for this WAS session. And first of all, thank you, Dr. Purvi, for your kind words. And in fact, I should say thanks to you because it's the whole team which has really worked very well. And as you said, there was a lot of resistance. And despite that, everybody at whatever best they could do, they were fighting that resistance. And today we are here and we are established and we say that WAS is already there and there is no resistance at all. In fact, there is whatever there is opposite of resistance now, and everybody welcomes us with such open arms. And it's all related to all the executive members and their and I can see that you have such a strong team with you, which is backing you. And thank you so much for putting this program together. So now, starting with what Dr. Rohit said, that we should not compete. Yes, this is a competitive session, but I agree with him. Even if it's a competitive session, we have to be supporting each other, and it has to be more of we put our best foot forwards and move forwards, supporting each other. So that is what WAS is all about. So I will, in short, give you a little gist about what all opportunities currently are there in WAS. And along with that, I'll talk mainly about women in research, which is which is one of the flagship programs of Women Ophthalmologists Society. So as I said earlier, WAS is all about supporting each other. We call it givers gain. That is, more we give, the more we get. So every member, when you become part of this society, some of you are already now WAS members, you'll realize that every member is trying to support each other, and every member is trying to always think how they can make you better rather than gaining from you. And that's what is the essence of WAS is, because when so many people are trying to support you and you are trying to support every member, the gains that we get are exponential. So most of the programs of WAS are based on you are not alone in your professional journey. this concept. And hence, most of these programs are based on the mentor-mentee concept. And today's program, though it's a competitive session, it's again based on a mentor-mentee concept. And thank you to all the mentors who are supporting their mentees. Lots of time nowadays, it is said that the student-teacher relationship is no longer what it used to be. But I disagree with this. I feel that that student-teacher relationship can never change. And when the mentors are mentoring their mentees reciprocate in a similar manner. And that's what we are trying to bring forwards in WAS. And once the student-teacher relationship is made stronger, I'm sure it's the younger generation which is coming up can do much better in their life, because we've always felt that women as ophthalmologists or women as professionals have their own unique challenges. And once they have their mentors and their role models whom they can see and who are supporting them, they can perform up to their full potential. So WAS is all about being different. So all the programs are also designed in a similar manner. We have a mentor-mentee program where on a one-on-one basis, you can choose a mentor, and this keeps happening regularly. And these mentors will support you on a one-on-one basis throughout the year and maybe even lifetime if you develop a good association with them. We have rendezvous series where a lot of men and women will talk about how they reached where they reached. Women of substance, men of substance are there. So we realize that there are small tricks for reaching there to the top. And if these men and women share these tricks with us, our life becomes simpler and better. So we find that women are less as leaders. So we have leadership sessions, and we feel that you have to be a leader in all aspects of your life. And when you learn these leadership qualities, you tend to perform better in your lives. And we also have regular academic sessions like any other society, and we have sessions on life beyond ophthalmology, which is important too. So today I'm talking more about women in research, because this is one very unique program which Women Ophthalmologist Society has. And we feel that research is a very, very important thing, because research is something which will help you analyze your data. It will help you build knowledge and mastering your topic. It will help you upgrade your knowledge and skills throughout your life. And it is also a career option. Now, many tend to feel that this cannot be a career, but today you will hear talks which will tell you that there are clinician scientists, and that's what is the need of the hour, and that's what is something which will bring excitement and in your life as a professional, because when you're doing your clinical part as well as doing your research part, you'll realize how much different things can be, and this will also help in your improved patient care. So women are known to be creative and perseverant, and these are two qualities which are really needed for research. So we feel that there is an untapped pool of large number of women ophthalmologists which who can actually go into research, and WAS can help you get there. So WAS can provide you an opportunity to do this, and with research you also can have flexible timings and better work-life balance, because you need flexible timings as women ophthalmologists in certain phases of your life. So WAS will provide you those opportunities, those mentors, those industry ties. What you have to do is take out a little more time from your clinical work and get into research activities too. So this is when we started. This was around 4 years back. There are a lot of mentors with whom you can discuss your ideas, and they will support you to take your research ideas forwards. And there are a lot of meetings which keep happening. There are training courses on research, and we have our ethics committee, and this ethics committee is open to all WAS members. So these are some of the ladies who are from Gujarat who started with their initial studies, and now there are several who are getting into research through WAS. So these are some of the photographs of all the sessions that we keep holding, and including hands-on training session on molecular research. So here I also want to announce that WAS is soon coming out with a website on women in research, and this will have a lot of national and international opportunities for research which you can take, and this can also help you build up a career in research. Along with this, there are going to be research mentors who will help you build this career, and this will be soon launched within a month. And you can, once you're a member, you can access this website and you can access all the training courses that are available there and all the opportunities, national as well as international. In fact, there are certain schemes which government has which are specifically for women, and you can take those opportunities and you can actually incorporate women. You can actually incorporate research in your career along with the clinical work. We have a rare eye disease group in which you can become, again, you can become a part, and you can be carrying out research on rare eye diseases. So just to summarize 7 steps how you can incorporate research in your practice. One is you start thinking you are not meant to be ordinary and come out of your comfort zone, the most important point. Secondly, you should be willing to give some time for research activities. Thirdly, you have to start thinking and improving your knowledge, attending more conferences, sessions, etc., and reading journals. Fourth, you have to form groups and collate your ideas. And fifth is you have to have access to statistician and ethics committee, which WAS can provide you. You should improve your industry ties. Again, WAS can help you do that. And you should learn how to publish your paper. So finally, I end by saying that research is possible and research is for all, and it's the give back time to the nation, society, and patients. There is more joy in giving than in taking. And again, these are 3 projects which some of the WAS members are doing along with the Government of India, and you can also be one of these names in future. So join us at WAS and join us at Women in Research to become extraordinary in your profession, and I'm sure we can give you a lot of opportunities. And this is the age as residents where now you will be entering into a phase of life where you would find that there are certain challenges which are unique to women, and this is where you have to learn to perform up to their full potential and not take a backseat in life. So thank you, everybody, and all the best for today's competition.
Dr. Gunjan, can I add a comment?
Yes, Dr. Tejas, please.
Yes. So at all other meetings, I start my talk like, ladies and gentlemen. Well, this is not what I do at WAS meetings. It ends at ladies. Correct? Now, any society, any organization becomes strong only if it has got a lot of members and lot of active members. So I believe it was very well explained by Dr. Mohita that each one of you should become a member, but that's not it. You should also bring another friend as a member. So I believe that is where the WAS should go. Excellent presentation, Dr. Mohita. Many thanks, Dr. Gunjan, Dr. Purvi, and everybody behind this meeting. Thank you.
Thank you, Dr. Tejas. And here I would like to add that Dr. Tejas has been one of the biggest men supporters of WAS at the time where nobody was supporting. There were few men, and Dr. Tejas and Dr. are 2 of them, and we would always thank these 2 for supporting WAS. Right, Dr. Purvi?
Yeah.
You are a witness too.
Thank you. Thank you so much.
Yeah, so now I would request Dr. Rohit.
Yeah,
please continue.
sorry for that. I don't have a presentation. I'll be just quick in 5 minutes. The one is what I said is stop comparing. I mean, comparing what you cannot change, basically. But like today is a competition, so these are like any sport. You have to compare with what you were yesterday. For example, I keep telling this to my residents and fellows that you compare with what surgery you did yesterday. Did you do better? Did you spend less minute? Even if you have done the surgery by 1 minute faster, that is comparing. But comparing with somebody else on somebody different platform probably will bring you more sadness than happiness. And complaining, the second C is complaining, because when you complain, you just lose that power of optimism and positivity in you. See, one of the things when I interview fellows for residency is one thing which all of them say is, we are COVID batch, we are COVID batch. It's become like a badge of honor. I understand COVID batches will remember, but the society forgets it. And if you're not trained yourself, if you're not groomed yourself in what you're supposed be. COVID is not going to be there forever. Tomorrow you're going back to practice. Tomorrow you're going back to join a fellowship. So you have to find a way how to overcome this complaining attitude which has come, especially in this batch. I'm not denying the fact that the challenges were plenty, and you went through a lot of troubles to reach safely out of all of that phase. Still, it is important that you have to stop complaining that you're a COVID batch. That's why you're weaker. You're COVID batch. You're not done surgery. You had to find a way, and practices like this, or I think WAS is coming out with the short-term fellowships and those kind of stuff, is definitely the way to go forward. And please attend meetings. Please attend these kind of meetings in whenever it happens physically. So you meet people. When you meet people, then you realize that your problems are much less than what you actually is. And and the third C is about control. We are in sometimes, we get into that we want to control everything. That controlling what kills a lot of us. So trying to control what you cannot brings you more happiness in your practice, and especially start trying to do it now. The fourth C, what I want to say is compassion. Compassion is very important, and that is one of the most important thing in today's thing. It's compassion about your patients. Compassion towards your colleagues is very important. Sometimes what happens is, we just we just block ourselves from the challenges what my colleagues are facing. So it's very important that compassion has to be there for the colleagues. And the last one is conversion. I think somebody's
Sonali ma'am, please unmute yourself.
Mute yourself.
Mute yourself.
Somebody from the tech team, if you can take care of this, please mute the non-speakers. Rohit, please continue.
Yes, the last one, what I'm trying to say is convert to what? Conversion. The last one, when you would say conversion, that's a saying that you should always be teachable. Teachable is you should always be ready to change or convert to anything which you felt once very rigid about. We have this very rigid policies in our mind that this is the way I'm going to do. And this happens a lot, even in a post-graduation or a fellowship. I'm not going to change from this. So always be teachable. When I say teachable, always be change, even not only in practice. Of course, you have fantastic teachers here. I heard a lot about each and every person here, because I think I have 7 to 8 of my best fellows are all from Gujarat. And I heard about Dr. Purvi, I heard about Dr. Deepali, Purohit. I've heard about everybody out here. So all your students talk so highly about you. Not the skill you have imparted in them. Ask them, what did they impart in you? Most of them skill can be imparted by anybody. What they say, the amount of patience you all had when you're training, the amount of way you used to take care of everybody without a class, creed, race, or whatever. I'm talking about in the constitutional language. So this is the greatest power, what you are imparted on your students. And that is what I mean by teachable. And the last one, even though it doesn't come under the C, is about faith. I believe that if you don't have faith, you're not going to reach anywhere. And please keep that faith. My talk may look very philosophical, but all the C's what I mentioned, compare, complain, compassion, control, and the last one is to convert into things which is teachable, are all what I have followed all my life. This is my 20th year of my practice. And I teach every single student exactly the same C's so that they can try to become better in their life. I thank Dr. Purvi, Dr. Moita for this opportunity. And I see only very good things happening with WAS now in very multiple forms. It looks confusing. Everything looks crazy when it starts. I think that crazy part is now over. Now everything is becoming more sense, more everything has a more direction. I wish you all the best and all the 35 contestants today. I think this is the best place to showcase your skill in presenting and also how you can take it forward. I thank you again. Thank you. Sorry for the earlier issue with my connection.
It's our pleasure, sir, always to have you with us. Now I'll invite Purvi Madam to give instruction and rules about today's program.
Yeah, thank you, Dr. Rohit. And in fact, that is also something which the residents need to learn, how to overcome the minorest of challenges without, losing confidence or getting down or any hesitation. It could be technical or it could be academic or scientific, whatever. So now we move on to the actual competitive case presentation sessions, which are the heart of this program series. And we begin with session 1 first, which includes case presentations on ocular surface and glaucoma. It has been shared earlier in the groups also, but for the sake of all who are joining and watching us live through different platforms, I'll share the instructions. The case presentations have been mentored by a guiding faculty. Can somebody stop sharing the screen first till the name is announced? So the presentations should conclude at or within 4 minutes. And one of the session moderators will be there who will be alerting everybody regarding the time limit. And the judges after that will be asking you questions or may have a brief discussion. We have 3 judges for each session. And the time for this question and answer and discussion is 2 minutes, which will also be notified live by the moderator of that session. The judges will be evaluating the presentations based on your history taking points, the examination that you have done for the case, the investigations and management done, the logical sequence of all the parameters mentioned, and of course, the overall presentation. And as soon as the entire session is over, the scores will be submitted to the core team for the final collation. And the 3 winners will be decided and declared at the end of the entire program. And again, as repeatedly informed, of course, we'll have 3 winners from the state, but only one who is a WAS member will be able to proceed for the interstate level. So all the best to all and enjoy your learning. And if any faculty or mentor has a brief comment or take home message to give regarding the case presentation, they are welcome to do so. And anybody else regarding a case, if they want to share something or ask something, you may please put in the chat box and one of the moderators will take up that point or that question. Thank you so much. So again, all the best to all the residents, and you can now continue with the session, Dr. Gunjan.
Thank you, ma'am. Now our first session is on ocular surface and glaucoma. And to moderate that session, I invite Dr. Kamini Prajapati ma'am and Dr. Shvetambari Singh ma'am. Dr. Kamini Prajapati ma'am is Associate Professor Glaucoma Unit at MNJ Western Regional Institute of Ophthalmology, Ahmedabad, Gujarat. She is Joint Secretary of ISM SICS Gujarat chapter. She is also an Assistant Editor in Global Journal of Cataract Surgery and Research in Ophthalmology. She is member of various local, state, national, and international ophthalmological society. She is former executive member of AGOS. She is member of Institute of Postgraduate Students Committee, Standard Treatment Guidelines, BJ Medical College, Civil Hospital. She has been awarded by Health and Family Welfare Department, Gujarat State, for National Program of Control of Blindness on World Sight Day, and she has various publications in various journals. And she is a very nice human beings, and both Purvi madam and Kamini madam are always supporting me in my all programs. The next moderator is Dr. Shvetambari Singh. She is cornea, cataract and refractive consultant at Ocular Eye Care Hospital, Ahmedabad. She has done her post-graduation from MNJ Institute of Ophthalmology in 2008. She has done her long-term fellowship under Dr. Abhay Basavda at Raghudip Eye Hospital. She worked as an associate professor at Nagari Eye Institute from 2019 to 21, and she joined as cornea refractive cataract consultant at Ocular Eye Hospital in Ahmedabad recently. She has various publications, and she has also given various talks in various conferences. I invite Dr. Shwetambari Madam and Dr. Kamini Madam, and I'm now handing over the session to you.
Thank you, Gunjan. Thank you for the introduction.
A very happy morning, respected ones and dear ones. And thank you very much, Dr. Gunjan, for kind introduction. I am very thankful to WASH, Dr. Mohita Sharma ma'am, Gujarat State Chapter Secretary, Dr. Purvi Bhagat, and Dr. Gunjan again for this opportunity. I and Dr. Svetambari like to invite our respected judges and the participants for this session on ocular surface and glaucoma. I have great privilege to introduce respected Dr. Deven Tulishar. He is a renowned senior glaucoma specialist as well as an excellent academician practicing in Delhi. He has done glaucoma clinical fellowship from RP Center, AIMS Delhi, and from USA. He is working very hard as an organizing secretary for the coming Glaucoma Society of India Conference 22. A warm welcome, sir. I am very happy to introduce our MNJ alumni, Dr. Alpa Atul Purabia, as a judge today. She is a senior cornea refractive surgery and cataract surgeon at Apollo Spectra Hospitals, Hyderabad. She has received prestigious awards, the Rising Star in Ophthalmology and Best Surgical Skills by WAS. I welcome you, madam. I am very happy to introduce a well-known glaucoma specialist, a multi-talented woman practicing in Mumbai, Dr. Preeti Kamdar. She has done glaucoma fellowship from LVPI Hyderabad. She has been invited as a speaker in many state and national level conferences, CME, webinars, and workshops. She has received Women Achiever Award by Government of India, Beti Bachao Initiative, and Special Contribution Award by Maharashtra Ophthalmological Society. She is doing good clinical work and community work in juvenile diabetes, glaucoma, and for cancer patients. Welcome, madam. Now, I welcome today's first participants, Dr. Shraddha Sravani from Government Medical College, Bhavnagar. Her topic is simple limbal epithelial transplantation surgery in patients with post-chemical injury limbal stem cell deficiency. Her mentor is Dr. Krupali Rao. Now, your time starts now. Dr. Shraddha.
I think the timer can be started after
Yes.
she actually starts speaking.
Okay.
She is not,
Okay.
yeah.
Okay. I request all the speakers to stick very much because we are following very strict time guidelines. So please don't overshoot your time. Otherwise, your presentation will be cut in between. So please follow the timings.
Dr. Shraddha, please just put it on a slideshow mode, full screen, and then you may begin. Your screen is already shared. Just put it to a slideshow. Yes. Yeah, perfect. Please begin.
Okay. I am audible, ma'am?
Yes, you are audible.
Yes.
And if it's possible, just turn your video on so everybody can see you, and you actually need to be in the limelight today. If it's possible, else it's okay. Begin, please begin.
Sorry, ma'am, it's not possible.
No issues, please carry on.
Okay. Good morning, everyone. I am Dr. Shraddha Samani, going to present a case of post-chemical injury limbal stem cell deficiency in a patient with simple limbal epithelial deficiency. This is a history of 40-year-old female patient come to our hospital with a complaint of the diminution of vision, redness and the burning sensation in the right eye since 3 months. And then we diagnose the patient as a status post-chemical injury with limbal stem cell deficiency and advise her for a SLAT surgery. There is a past history, there is a history of the alkali burn 1.5 years back, and personal and family history is not significant. On general examination, patient is vitally stable and cooperative and conscious. On torchlight examination, the both lid matters with leg of thalmus because there is superior symbioferum formation. With cornea, there is a corneal opacity with vascularization, with pupil reaction and normal with vision of 660. On slit limb examination, because of leg of thalmus, there is because of superior symbioferum formation, with there is a peripheral corneal opacity with 360-degree conjunctivilization with panospermia all things is normal, and the dilated fundus examination is not possible with indirect ophthalmoscope. This is pre-operative slit lamp photo of patient. The first photograph will be show the superior symblepharon formation, and the second photograph we can show there is a 360-degree conjunctivalization with pannus formation and vascularization. We do the all routine investigation and the Shermer test to rule out any dry eye, or anterior segment OCT to rule out any stromal opacification, and ultrasonography to rule out any posterior segment pathology. We did the SOCT photograph to see the any stromal opacification. First we prepared the right eye with brimonidine and phenylephrine eye drops alternately 3 times 30 minutes before the operation. And first the donor eye limbus is marked with a 1 clock cover or 3.5 to 4 mm slightly behind the limbus on the conjunctiva. Then conjunctival bleb is created with injecting the fluid under it and lifted until the 10 ounce capsule insertion at the limbus. Then further dissection is carried out with a 15 number blade until the gray color cornea is visible, and then the conjunctival part is excised first, and then the limbal part is cut separately, and it is preserved in a balanced salt solution. In the recipient eye, first we remove the symblepharon, and then we did the 360-degree peritomy around the cornea, 2 to 3 mm behind the limbus, and then dissection is further carried out with the help of Vanna scissor to release the conjunctivalized pannus which cover the cornea from the limbus. Then we go centrally with the blunt and the sharp dissection. After that, we applied the human amniotic membrane with basement membrane side up over the cornea with the help of the fibrous length, and then the human amniotic membrane is stuck under the conjunctiva in the all quadrants, and it is smoothed over the cornea with the help of blunt spatula, and then we preserve limbal tissue is cut in the 10 pieces with the help of Vanna scissor, and which is placed over the cornea in the mid periphery in a concentric pattern, and the drop of fibrin cylinder is placed over the each piece to ensure it is adhered to the membrane. After the 1 minute of it, we apply the therapeutic soft contact lens in the eye. Post-operatively, we opened the donor eye after the 4 hour and started the moxifloxacin and the CMC eye drop studious and the prednisolone BD. And the recipient eye is open 24 hours after the surgery, and we start the moxifloxacin and CMC studious and the prednisolone 6 times a day. This is the first photograph post-operative day 2. We can see there is a human amniotic membrane is in the place with 10 bits of the limbal conjunctival tissue are in place in the mid periphery of cornea. This is the photograph of post of 1 month. We can see the cornea has become more clearer and the pupil is visible with 10 bits of the limbal tissue are in place in the mid periphery of cornea. This is post of 2 months. We see that there is a more clearer cornea with 10 limbal tissue bits are in place in the mid periphery of cornea. So conclusion is that the corneal blindness is very most important cause of blindness in developing world. Out of this, ocular burns are contain the poor prognosis because it causes the limbal stem cell deficiency. For this, autologous sled is very effective technique for the long-lasting corneal regeneration and the vision restoration in case of unilateral limbal stem cell deficiency. Thank you.
Yes, it's absolutely completed in 4 minutes. Now, the judges for the questions.
How many follow-ups were done?
Ma'am, the patient is operated around 2 months before, so patient will now will come after the 1 month around. We did the 3 follow-up of the patient.
Dr. Preeti, you need to unmute.
And it's like this, the burns were 1.5 years before the person presented to you. So
Yes.
during that time, had she taken any treatment?
Ma'am, patient will tell us that he go to the Nagri hospital at Ahmedabad and then lost to the follow-up. There is no any paper available on this and no any treatment paper documents available.
And how long will you be continuing the steroids for her?
Sir, we taper over the 1 weekly or mostly 6 weeks. We continue the steroids of this patient.
Only for 6 weeks you'll continue.
In the case of the yes, ma'am. In the case of donor eye, we started BD, so it will be stopped after the 2 weeks. And the recipient where we should continue at least 6 weeks.
Okay. And did you make sure that the left eye is absolutely healthy?
Yeah, ma'am. Yes, ma'am. We about the history. There is patient not history of any surgery or any trauma. With we also did out any Shermer test or the wet cornea and the tear films or this slit lamp examination. All this thing is normal of this patient.
Okay. So the alkali burn did not affect the other eye at all?
No, ma'am.
Okay. Fair enough. So
I just want to ask one question. So
Hi, can you hear me?
Yes, ma'am.
Yeah. So how did you tackle that symblepharon? So did you do conjunctival autograft in that area, or I think I missed out on that?
Sorry, ma'am, we just remove the symblepharon. There is no any conjunctival defect that much. So it doesn't needed any conjunctival autograph.
2 minutes are over.
Because okay, just one comment on this, because there are very high chances that whenever we remove the symblepharon, there
Yes.
will be some kind of a defect, and if we do not do conjunctival autograft in that area, the symblepharons will reform and will later on kind of jeopardize your outcome. Otherwise, the outcome in the initial stages were very, very good.
Nice presentation, Shraddha. And we can go on to the next one. No?
Yes. Thank you, everyone. Now I invite Dr. Saija Shah from CH Nagri Eye Hospital, Ahmedabad, for a presentation on primary angle closure glaucoma. Her mentors are Dr. Reema Rawal and Dr. Kintu Shah. Over to Saija.
Good morning, everyone. I'm Dr. Saija Shah, second.
Saija, can you increase your audio, please?
Yeah. Is it better?
No, still it is low. The volume is low.
Now, ma'am?
Yes, it is okay.
Yeah. I'm Dr. Shailaja Shah, second year resident at CH Nagri Eye Hospital, and I'm presenting a case on bilateral primary angle closure glaucoma. A 55-year-old male, mechanic by occupation, belonging to a lower socioeconomic status, resident of Ahmedabad, presented with the chief complaint of diminution of vision in both eyes, right eye more than left, since 6 months, with occasional heaviness and redness in both eyes since 1 month. The patient had gone to the optician thrice in 6 months, but was dissatisfied with the prescribed glasses. Patient was relatively asymptomatic before 6 months. Then he developed diminution of vision in both eyes, which was gradual and progressive in nature and associated with occasional heaviness and redness since 1 month. The pain was tolerable and was relieved on its own without any medication. It was not associated with any colored halos, no history of episodes of severe pain with vision loss, no history of trauma or any topical or systemic medications, no other major systemic condition requiring hospitalization, no history of any systemic illness or significant personal or family history. The general examination of the patient was within normal limits. Facial symmetry was present and head posture was normal. The best corrected visual acuity for distance with distance Snellen's chart was 636 for right eye and 624 for left. The best corrected vision for near was N6 in both eyes with plus 2.5 diopters. The intraocular pressure with Goldman's applanation tonometry was 36 mm of mercury in right eye and 32 mm of mercury in left eye. On slit lamp examination, the lids and lacrimal apparatus were normal in both eyes. There was mild circumciliary congestion in both eyes. The sclera was clear. There was corneal edema present in both eyes. The anterior chamber depth was von Harrich's grade 1 and AC cells were present. The iris shape was convex and the shape was normal. There was no iris bombay, neovascularization, loss of pattern or any atrophic patches. The pupil was round, single, centrally placed and reacting normally to light. Gray reflex was present in both eyes. My diagnosis is both eye primary angle closure glaucoma with immature senile cataract. For the initial management, an intravenous injection mannitol 20% was given over 20 minutes to the patient, and 1 drop of pilocarpine 2% eye drops was instilled in both eyes and repeated after 30 minutes. Dexamethasone eye drops 0.1% was also instilled in both eyes. The patient was then given oral tablet acetazolamide 250 milligrams 4 times a day, pilocarpine eye drops 2% 4 times a day, dexamethasone eye drops 0.1% 4 times a day, and timolol eye drops 0.5% 2 times a day. On 1 week follow-up, gonioscopic examination using Goldman 4 mirror was conducted for the patient. Both the eyes, according to the Schaffer's classification, all the 4 angles were found to be narrow. On indentation, the inferior and temporal angle opened up to the trabecular meshwork and peripheral anterior synechia was seen. A laser peripheral iridotomy was performed for the patient at 11 o'clock position in the right eye and 1 o'clock position in the left eye using the Nd:YAG laser. The patient was then followed up after a week and he was symptomatically better. The peripheral iridotomy was found to be patent in both the eyes, and the IOP was 17 mm of mercury in right and 18 mm of mercury in the left eye. The corneal thickness was normal in both eyes. I conducted a dilated fundus examination of the patient thereafter. The disc in both the eyes was round in shape, normal in size, and the cup disc ratio in the right eye was 0.7 to 0.8 vertically and horizontal was 0.5 to 0.6. Moderate cupping was present. Superior, inferior, and temporal rim were thin. Bipolar thinning was present in the right eye.
4 minutes are over. You can conclude fast.
Yeah, bayoneting and nasalization of vessels was present, and peripapillary atrophy was present. In the left eye, the CD ratio was 0.5 with moderate cupping and superior, inferior, and temporal rim thinning.
Okay. Shailaja, yeah, now the vision was 6 by 36, 6 by 24 at presentation, and you have written N6 near. So what was the cause of the blur vision? And you said the person came with an attack, but the picture showed very clear cornea.
Ma'am, in the slit over here, yeah, the in this image, the corneal, it was not very significant, but there was corneal edema. In this picture, I have not been able to capture it very clearly, but in this here, we can see that there is some amount of corneal edema.
And did the vision improve later on?
Ma'am, the vision slightly improved, but that was not very significant because he also had cataract developed, and plus there were disc changes. So it was not very significantly.
You have not done a perimetry for that person?
No, ma'am. I would like to do it on follow-up.
It should have. See, you have labeled this as an attack, but I felt it was more of a chronic angle closure because the cornea seemed quite clear. And I think there was a gap of 1 week between you managing with mannitol and doing an iridotomy. Usually, if there is an attack, I don't know about the logistical issues you may have, but usually when you control an attack, you try to do an iridotomy at the same sitting, because when you leave the patient for a week, there is always a chance that he is going to get another attack in that 7 days. And one more thing is that how commonly do you see bilateral acute angle closure attacks in a primary glaucoma? So all in all, I felt that this was not an acute attack of angle closure, it was chronic angle closure, and you have managed it well by doing an iridotomy and other fact. But one thing I would like to say is that why is the vision less? Perimetry would probably explain it. If there is a slight cataract, then instead of putting, you said he's of a lower socioeconomic status. Yes. Hello?
Yes, ma'am.
Yeah, so he's of a lower, so then if there is a cataract, removing his cataract may decrease his need for all the medications, provided the vision loss is because of a cataract. So just investigate that and do a perimetry at the earliest.
Yes, ma'am.
All right. And just one thing, when you are actually presenting, you can put it in the form of points. It's very easy. You can describe it, but you can put it in the form of points. It's very easy for the judges to note the relevant points. That's all, but it's a nice presentation, Darshana.
Thank you, ma'am.
Sorry, Shailaja, not Darshana. Shailaja.
Dr. Tuli, sir?
No, I think we can go on. We should stick to time. I'll comment on the next, please.
Okay, sir. Now I ask Dr. Kinjal Patel from CH Nagri Eye Hospital, Ahmedabad, for her case presentation on primary open angle glaucoma. Her mentors are Dr. Reema Rawal and Dr. Kintu Patel. Sorry, Dr. Kintu Shah. Kinjal. Dr. Kinjal, share your screen.
Am I audible?
Yes, you are.
Yes.
presenting a case of bilateral primary open angle glaucoma. Patient with a 55-year-old female, housewife, middle socioeconomic class, residing at Ahmedabad, coming with a chief complaints of diminution of vision since 6 months with a occasional heaviness in the both eyes. Patient was relatively asymptomatic before 6 months. Then she developed diminution of vision in left eye, followed by the right eye, which was gradual and progressive in nature, associated with occasional heaviness. For the same, she consulted at a private hospital and was referred to the tertiary eye care center for the further evaluation. There is no associated with the headache and other ocular symptoms like vomiting, color halos, no episodes of acute pain, no history of similar complaint in the past, no history of trauma, any topical or systemic medication, frequent changes in the glasses, no other systemic illness or personal history. There is positive family history of the glaucoma in grandmother. General examination was normal. Facial symmetry is present and head posture was normal. Unaided vision is 612 in right eye and 618 in the left eye. Base corrected visual acuity for the distance is 66 in the both eye, and the base corrected visual acuity for the near is N6. Intraocular pressure with the Goldman applanation tonometry in right eye was 24 and in left eye was 26. Central corneal thickness in both the eyes is 475 micromillimeter. Torchlight examination was normal. On the slit lamp examination, depth of the anterior chamber was normal with the von Herrich's grade 3. Pupil was normally reacting to light, and 360-degree pupillary rough was intact with the gray reflex in the both eye. Gonioscopy with the Goldman one mirror gonioscope. There were grade 3 according to Schaeffer's classification. We can see this up to scleral spur. Iris contour was normal, and there is no evidence of the peripheral anterior synechia. These are the dilated slit lamp examination of my patient, which shows the early nuclear sclerosis cataract, right eye more than left eye with the orange glow. My fundus findings were in right eye, round normal size disc with the cup disc ratio vertically 0.5 to 0.6, horizontally 0.4 with the moderate cup depth in superior rim thinning, nasalization, bayoneting, and the normal vascularization. Peripapillary area, macula and periphery was normal. There is diffuse RNFL loss. In the left eye, round normal size cup with the CD ratio of vertically 0.8 and horizontally 0.7 with the moderate cup depth with a concentric enlargement of the cup. Nasalization, bayoneting, normal vascularization, and the peripapillary area, macula and periphery was normal. There is diffuse RNFL loss. Perimetry examination of the patient of 24-2. Reliable criteria was perimetry was reliable. That was showing the right eye early nasal arcuate, and in the left eye superior and inferior arcuate with the nasal step. My clinical diagnosis was both eyes primary open angle glaucoma, left eye more than the right eye with the both eyes immature senile cataract. I would like to manage with the medical therapy. In both eye, I would like to start the prostaglandin analog, and regular follow-up of the patient was advised to monitor the target IOP. Thank you.
So yeah, very nicely done, Kinjal. I think you presented well as it is. And just tell us why prostaglandin.
Sir,
it's a correct approach, but why?
Sir, because prostaglandin we are instilling once a day. There is a long half-life, so that the patient compliance was very good in prostaglandin.
Great. Yeah, I think this is good, but also mention the IOP lowering. Na? In open angle glaucoma situation, you must mention the target pressure. So that is why I was taking it there. You must mention before starting treatment what the target pressure is in your case. Otherwise, very well done. Preeti, go ahead.
No, very well managed, and the way we would manage it in our clinics, that's the way you have managed it. Only thing is perimetry, maybe when you become a little senior, you'll realize that probably these were little artifacts and they may disappear when you repeat perimetry, but very well managed.
Yeah, thank you.
Good job, Kinjal.
Thank you, ma'am.
Thank you, Kinjal. Now, Now invite Dr. Bansri Latiwala from CH Nagri Eye Hospital, Ahmedabad, to present her case on pseudophakic bullous keratopathy. Her mentors are Dr. Deepali Satani and Dr. Parul Danayak. Dr. Bansri, share your screen. Make a slideshow. Dr. Bansri? Dr. Bansri, you are not audible. Hello? Is there any colleague present here with Dr. Bansri? May I go to another presenter?
Yeah.
Yes, I think we can switch the sequence by the time Bansri is ready.
So Bansri has to stop the screen share, please. Okay. So now, Dr. Ishita, are you ready?
Yes, ma'am.
Yes, sir. So I'd like to invite Dr. Ishita Ravalya from CH Nagri Eye Hospital, Ahmedabad, for her presentation on keratoconus. Her mentors are Dr. Deepali Satani and Dr. Parul Danayak. Over to you.
Good morning. Today I'm presenting a case of bilateral keratoconus. My patient details are, I'm presenting a case of a 21-year female Hindu who is a student and comes from middle socioeconomic class and is residing in Ahmedabad. Her chief complaints at the time of presentation were blurring of vision since 6 months, frequent change in refraction since a year, and she complained of frequent itching in both the eyes, upper lid. Patient was relatively asymptomatic before a year. Then she developed blurring of vision, which was for distance and gradual, progressive, and bilateral, associated with headache. For this, she consulted a private hospital and got a subjective correction done. According to her, previous refraction was in right eye -1 diopter spherical and in left eye -1.25 diopter spherical. 4 months ago, she again developed a similar complaint and got a refractive correction done, which in right eye, which was -2.25 diopter spherical and -0.75 diopter cylindrical at 70-degree axis, and in left eye was -2.25 diopter spherical and -1.5 diopter cylindrical at 100-degree axis. Again, after this, she was not satisfied with the correction and consulted a few optometrists, from where she was referred to tertiary hospital for further management as she was having higher astigmatism. In her past history, she had a past history of myopic glasses and no history of trauma or foreign body or contact lens wear or any ocular surgery or any medication, topical or systemic medication use. No significant past history of skin allergy, asthma, TB, diabetes, hypertension, or any other systemic illness. There was nothing significant in personal or family history. In ocular examination, I have examined my patient in adequate light and exposure. Patient was conscious, cooperative, and well-oriented to time, place, and person. Patient is well-built and nourished. Her visual acuity in right eye was 624 and in left eye was 636 with her presently prescribed glass, which she came with. Intraocular pressure with gold band apprehension tonometer was in right eye 16 mmHg and in left eye 18 mmHg. On torchlight examination, in both the eyes, leads were normal. Conjunctiva and sclera was clear. Cornea was also clear. Anterior chamber was normal intact. Pupil was normally reactive to light, and lens was clear. On slit lamp examination, leads and adnexa were normal in both the eyes, and conjunctiva and sclera, conjunctiva in upper tarsal conjunctiva showed papillae. In cornea, Vox stria were seen in both the eyes. On slit, anterior chamber was normal intact. Pupil was round, single, centrally placed with normally reacting to light, and lens was clear. This is a slit lamp photograph for right and left eye respectively, and both the eyes Vox striae are seen here, which are vertical striae seen in the posterior stroma or Descemet's membrane, we can say. And this is a Munson sign which I elicited on the patient which is a keratoconus patient. Her past her glass prescription was present glass prescription was right eye minus 2.25 diopter spherical, minus 0.75 diopter cylindrical at 70 degree, and in left eye was minus 2.25 diopter cylindrical and minus 1.5 diopter, minus 1.5 50 diopter cylindrical at 100 degree. And at our hospital, when her current refraction was done, it came out to be right eye minus 4.50 diopter spherical and minus 2 diopter cylindrical at 80 degree, and left eye minus 5.50 diopter spherical and minus 4 diopter cylindrical at 100 degree. Our best corrected visual acuity is right eye 612 and left eye 618, which did not improve further. Fundus.
I think you can miss that and go to the conclusion. Only 10 seconds left. Yes.
Investigation is right eye pachymetry is 477 micron and left eye is 458 micron, and axial curvature in this is a topography of both eyes. Right eye was astigmatism of 4.70 diopter and left eye was 5.50 diopter astigmatism, and red warm areas are seen in both the eyes, which is suggestive of keratoconus. And this is a summary of which I already described previously. My diagnosis is both eye keratoconus with allergic conjunctivitis. Since she showed papillae on in both eyes, and my advice would be both eye drops olapatadine 1% twice a day, and left eye C3R followed by right eye. Collagen cross link.
Yeah. To the judges, please.
Alpha should comment, please.
If you said you have diagnosed patient with allergic conjunctivitis, I think you didn't mention in your findings what were findings you actually saw. So whatever is your diagnosis, that investigation you have done and whatever findings you saw, that should be mentioned in your examination. You didn't mention that there were papilla. When you are talking about diagnosis, you are telling there were papilla.
On slit lamp, ma'am, I found papillae, and patient also complained of frequent itching episodes, and on slit lamp, I found papillae on both the upper lateral conjunctiva, ma'am.
How did you counsel the patient? What did you tell him?
I told her that this is a condition which is found mostly in adolescent population, and this is a thinning of cornea, which we might say thinning of cornea, and there will be protrusion. If we wouldn't take a step right now, then there might be chances that later on there might be scarring, and you might lose your vision or something like that would probably happen.
No. What happens is that after you tell them that you need to undergo C3R, they expect even the numbers to go away. You have to tell him or her that the numbers are not going to go away. She will require something else for her visual correction also. So your treatment is going to be two-pronged. One is to prevent further progression, and the second is to rehabilitate. So both have to be done, because if you don't tell them, if you don't tell them about, if they will think that with C3R they are going to see clearly. So that's why I asked, how did you counsel? No other reason, but otherwise well managed. Well, the good history.
What's the age of the patient?
21
years. 21 years.
Yeah, just wanted to confirm we are marking for Rishita, right?
Yes, ma'am.
Yes.
Okay, go ahead to the next, please.
Thank you.
Thank you, sir. Dr. Bansri, are you ready? I think Dr. Bansri is not there. And Dr. Rutul Patel is not presenting today. So I request Dr. Svetambari to continue the session ahead.
Yes. So now I would like to invite Dr. Shivani. She is from CH Nagri Hospital, and yes.
Yes, who is?
Yes, so she will be presenting vernal keratoconjunctivitis case on that, and her mentors are Dr. Dipali Purohit and Dr. Parul Danaya.
Just a minute, Dr.
Bansri?
Yes, ma'am. Am I audible?
Yes, you are audible.
Yeah, so yes, so we are going back to Bansri now.
Yes.
So start your presentation, Bansri.
Yes, good morning, ma'am. I'm Dr. Bansri Ladiwala from second year student of CH Nagri Hospital. I will present a case of pseudophakic bullous keratopathy. A case of 62-year-old Hindu retired male coming from socio-economical class residing at Ahmedabad came to us with the chief complaint of diminution of vision and photophobia in right eye since 6 months. Patient was relatively asymptomatic before 6 months. Then he developed the diminution of vision in right eye, which was gradual, painless in nature, and photophobia. Complaint was increasing since last 2 months. Past ocular history: in the right eye, cataract with IOL surgery done 1 year ago, and in left eye, cataract with IOL surgery done 1.5 year ago. History of wearing bifocal glasses since 1 year. There is no history of similar complaint in past and trauma, foreign body, and using any eye drops. History of hypertension since 7 years, taking antihypertensive tablet telmisartan 40 milligram once a day. There is no any other history of diabetes and any other systemic illness. No significant personal and past history. On ocular examination, I examined my patient in adequate light and exposure. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is well-being, nourished, and vitals are stable. Head position, spatial symmetry, and ocular movements are normal. On best corrected visual acuity, right eye, there is a hand movement, perception of light is present, and projection of rays in all 4 gaze. And in left eye, there is 6/9 vision. Intraocular pressure with Goldman applanation tonometer. On right eye, there is an error, and left eye 20 mm of Hg. On torchlight examination, Xenia and conjunctiva are normal. Sclera is also normal in both eye. On cornea, right side cornea showing the corneal haze with edema, and in left side there is a clear. Anterior chamber normal depth in both eye. Iris and pupils, iris are normal in both eye, and pupils are normal reacting to light in both eye. Lens are pseudophakic in nature in both. On anterior segment examination, on slit lamp, right eye, there is a lead at axia normal in both eye. Conjunctiva is normal in both eye. Sclera is normal in both. Cornea on right eye showing corneal edema, epithelial microcyst and bulla with the stromal haze. On in left eye, there is a clear. Anterior chamber, it's normal depth and clear in both eye. Iris is normal pattern. Pupils are round, shingle, centrally placed with normal reacting to light in both eye. Lens are pseudophakic in both light. On examination of corneal sensation, patient is reducing corneal sensation on right eye. Showing this picture, on left eye, there is a clear cornea with the pseudophakic eye. In right side, there is a microbulla with centrally macrobulla and stromal haze with scarring inferiorly present on the right eye. On fundus examination, right eye is media haze. On left eye, media is a clear with normal glow. Normal cup disc ratio is 0.3 with healthy neuroretinal rim with well-defined margin. Macula is normal and peripheral retina is also normal. On investigation on specular microscopy, right eye vision is obscure because of corneal edema. So pathology is not seen properly, and left eye specular microscopy is normal. On corneal pachymetry examination, is 630 micrometer and left eye is 510 micron. Diagnosis: my corneal edema with stromal haze with pseudophakic in right eye. So most probable diagnosis of right eye is pseudophakic bullous keratopathy. On management, patient was started topical steroid eye drop of 0.5% loteprednisolone 4 times a day, 5% hyperzole eye drop 4 times a day, and 0.5% imolol eye drop 2 times a day. Patient is advised for right eye optical penetrating keratoplastic surgery. Thank you.
Yeah. So what do you think is the cause of the keratopathy? You think surgical trauma?
Yes, ma'am.
You feel it's a surgical trauma during post-surgical trauma. Now, did you give any of the, there are now some eye drops which are touted to sort of improve endothelial function. Did you try any of those Rho kinase inhibitors particularly?
Rho kinase inhibitor, yes, ma'am.
Did you try any of them?
No, ma'am.
You have not tried. Second is, why PKP? Why not DSEC or MSEC?
Because there is stromal layer is also edematous and descending membrane is also involved. So there is the
we can't hear you.
Corneal haze as compared to penetrating keratoplasty.
He's been symptomatic only since about 3-4 months. How many months?
Last 6 months, but complaint was increasing last 2 months.
Okay. No, what happens is, no, what I agree, and a corneal specialist would be able to tell you better. But even when you have a short lasting history, whatever you showed, it didn't show any permanent stromal scarring. There will be permanent stromal edema would be there because the keratopathy, the endothelial function is lost. But if you do a DSEC in them, they do get good vision, because over a period of 6 months it doesn't give you the dramatic effect with a PKP, but the chances of rejection and post-op rehabilitation are much better. But a corneal specialist will be able to tell you better. DSEC could be an option in this person.
Yeah, so can I make one or two comments here? As a cornea specialist also.
Yes.
So as Dr. Preeti very rightly said, that I think this patient really can do very well with either DSEC or DMEC. Second, the Descemet membrane is involved. That's the indication for this thing. I think you just said that Descemet membrane was also involved. So in DSEC and DMEC, we are removing that. Corneal mild haze improves with Descemet membrane change. Second thing, when you mentioned, in your history and examination, you have reduced that the painless decreased vision and the corneal sensations were decreased. Now there are these two things. Maybe it warrants that whether you were dealing only with pseudophakic bullous keratopathy or something like that, if you have got this finding. Because in a pseudophakic bullous keratopathy, there's no reason for it to have decreased corneal sensations. In fact, patients do get a lot of pain and all when you have these bullae and all, the kind of bullae you had it on your patient. So if there are less sensations, then there is some other reason, and that again warrants, especially if you're doing a PKP and all, the epithelial healing, because anything which has reduced corneal sensations have healing problems. So I guess that needs to be checked, whether the sensations were checked properly or were they checked post parakin or something like that.
I think the time is over now, so we can switch to the next case.
Yes.
Thank you, ma'am.
Yes. So now we can invite Dr. Shivani. You can share your presentation. She's from CH Nagri Hospital, and she's presenting a vernal keratoconjunctivitis, and her mentors are Dr. Dipali Purohit and Dr. Parul Danayak. Yeah, you can start your slideshow and you can start. Yeah. Yeah, slide, yes. Yes, Shivani. Shivani?
Shivani, you are not audible.
Yes, Shivani, please unmute yourself and start your presentation.
No.
Shivani, we are not able to hear you.
Can you hear me now, ma'am?
Yes. So you can start from the beginning. Yes.
Okay, keratoconjunctivitis. A 14-year-old Hindu male patient from low socioeconomic class residing at Nagar, Ahmedabad, was brought to tertiary hospital by his parents with chief complaints of itching, redness, watering, and foreign body sensation since 2 months. The patient was relatively asymptomatic before 2 months. Then he developed symptoms of itching, redness, watering, which were progressive in nature and which increased on outdoor activities. The patient had 2 or 3 episodes of similar complaints in the past since 2 years, for which he had taken treatment at private hospitals, but no documents were available. Patient is currently instilling olapatidine eye drops twice daily, moxifloxacin eye drops thrice daily, and carboxymethyl cellulose eye drops thrice daily as prescribed by private practitioner, but symptoms were not improving. No associated ocular symptoms like dimness of vision, eye strain, stickiness of lids, pain. No history of trauma, foreign body, or any ocular surgery. No significant history of systemic illness, allergies. No significant personal or family history. The general examination was normal. On ocular examination, unaided visual acuities in the right eye 6/12 and left eye 6/9. Best corrected visual acuity was in the right eye 6/6 with -1 diopter cylinder at 180 degree, and in the left eye 6/6 with -0.5 diopter at 175 degree. I have confirmed my torchlight findings on slit lamp examination. The findings were lid and adnexa. In the right eye, there was mild upper lid edema, medium-sized upper palpebral conjunctival papillae with conjunctival and circumciliary congestion, In the cornea, Horner-Trantas spots involving 270 degrees around the limbus, limbal hypertrophy, and SPK at 12 o'clock position. Anterior chamber depth was normal, pupil was normally reacting to light, and lens was clear. In the left, thyroid and adnexa were normal. Conjunctiva and sclera showed medium-sized upper palpebral conjunctiva with conjunctival and circumciliary congestion. Horner-Trantas spots involving 180 degrees and limbal hypertrophy was there. Anterior chamber depth was normal. Pupil was normally reacting to light and lens was clear. These are my slit lamp photo. Intraocular pressure with Bowman's applanation tonometry was in right 16 mm of mercury and left eye 14 mm of mercury. Fundus examination, both eyes showed media clear with a normal round 0.3 with a disc of 0.3 CD ratio with healthy neuroretinal rims and normal peripapillary area with normally arising dichotomous vessels and normal foveal reflex. The topography of both the eyes was normal. So my diagnosis is a 14-year-old male with both eye vernal keratoconjunctivitis, right eye more than left eye. Treatment given was loteprednisolone eye drops 0.5% BS with weekly tapering, olapatidine 0.1% eye drops BD, tacrolimus 0.1% eye ointment HS, and carboxymethyl cellulose 0.5% eye drop DS, along with the instructions given like cold compressions to avoid allergen and exposure to dust, avoid eye rubbing, and to wear protective glasses and frequent follow-ups. Thank you.
Can you just go through the slide where the treatment you've given?
Yes, ma'am.
Loteprednol. Okay. Earlier, he was given loteprednol is a very low dose steroid, and you have established the diagnosis very well. Earlier, he was given prednisolone and other eye drops, which you have said that there is no other, not from you, but previous history.
No, ma'am. They were only no steroids were given. Only olapatidine, moxifloxacin, and CMC was given.
Okay, sorry. So, have you followed up the patient? How was he? Did he respond to the treatment?
Ma'am, follow-up was not there. This was only on the first presentation.
Okay, so you have not followed up like how whether he reacted, because it seemed to be quite severe, the
Yes,
Horner-Trantas spots, and so you think he will respond well to loteprednol?
Yes, ma'am. If instilled properly, and he will respond.
Okay, and how will you counsel the patient?
We have to counsel the patient, means that it is a it will occur in season during this season for up to puberty. So they will have to keep patience, and when he becomes adult, these symptoms may resolve on his own. And during that time, whenever these symptoms occur, he has to consult a doctor, and otherwise these cold compressions and specifically to avoid eye rubbing, he has to do.
Okay. Yeah, so one thing is about long-term treatment, and second is if he does not respond to loteprednol, he may go to somebody else who will be given, and he'll be given higher steroids, and believe me, he will keep on putting these steroids without any supervision, and it's one of the main causes of steroid, VKC is one of the main causes of steroid induced glaucoma. So even the negative counseling, you have to tell him that you should not put these drops on your own, especially the steroids. So that's one common counseling you should give before you release the patient.
Yes, ma'am.
Right?
Yes,
but well presented.
Thank you, ma'am.
Yes. Now we will move to the next presenter, that is Dr. Hardi Patel. She will be presenting a unique case, that is Rho kinase inhibitor induced reticular corneal edema. And she is from MNG Institute of Ophthalmology, Ahmedabad, and her mentors are Dr. Purvi Bhagat and Dr. Jignesh. So over to you, Dr. Hardi.
Yes, ma'am. Yes, ma'am. Good morning. I am audible?
Yes, you are audible.
Yes. Okay. Ma'am, I am presenting Rho kinase inhibitor induced reticular corneal epithelial edema. Here, as we know, the glaucoma is one of the most common eye disorder leading to blindness worldwide. And treatment modality includes the conditions and laser therapy and surgery. But the Rho kinase is the newest among of them. Is the serine and threonine protein kinase involve the regulation and the modulation of the cell shape size by the action on the cytoskeletal, thereby the claim to be useful in the glaucoma and the endothelial dystrophy and diabetic retinopathy. Here, the two Rho kinase inhibitors, dipasodil and letrozole, have been launched currently as the anti-glaucoma agents. Nitarsodil 02 was approved by the United States Food and Drug Administration for the lower IOP presentation, the glaucoma patient. And the mechanism is to reduce the IOP via the increase the outflow from the radicular meshwork and reduce the aqueous humor production and decrease the episcleral venous flow. Vasoconstriction leading to decrease the blood flow to the ciliary process and thereby the initiating the aqueous humor productions. Other beneficial effect is the and decrease the inflammation, preventing the scarring following the glaucoma filtration procedure. And here I case series. Our first patient is the 64-year male with the affected eye vision is the HM plus PL plus PR plus 4 with IOP 20 mm magic with close angle and advanced neovascularized glaucoma diagnosed. Using treatment is maximum. Patient is on the maximum anti-glaucoma medication plus we added the nitazoxanide, and on the follow-up day 7 we find the typical corneal reticular epithelial edema, and on omission the nitazoxanide, reticular edema is the reduced on the third day follow-up. And our second patient is the with the both high bilateral 360-degree cynocular closure with diagnosed advanced neovascularized glaucoma. Patient is using atropine eye drop and tab acetazolamide 250 milligram BD with maximum anti-glaucoma medications, or we added the nitazoxanide, and on the day which we added nitazoxanide, after 7 days we found the typical corneal reticular epithelial edema, and on omissions we found the reticular edema reduced significantly on the 5th day. Our third patient is the patient with the neovascular glaucoma with the iridocorneal endothelial syndrome, and on the treatment of the homeotropine with maximum anti-glaucoma medications, and on the follow-up 8th day we found the typical corneal reticular epithelial edema. On omission, reticular edema is decreased on significantly after 4 days. On fourth patient with is diagnosed as a complicated pseudophakic with a raised IOP. Patient is on the monotherapy nitazoxanide. We found the typical corneal reticular epithelial edema on the 21st day. On omissions of the nitazoxanide, reticular edema is reduced significantly on the 6th day. Here the case present, we found the slit lamp, honeycomb appearance of the reticular epithelial edema, and conjunctival hyperemia is the most common side effect reported with the nitazoxanide, followed by the incidence of the corneal verticillata. The rocket trial, conjunctival hyperemia was the most common side effect, followed by the corneal verticillata and corneal subconjunctival hemorrhage. Mark M. Fernandez reported that the use of nitazoxanide in the patient with the edematous cornea developed the reticular epithelial edema, which resolved after the continuation. Our 4 patients with characteristic of the reticular corneal edema after initiation use of the nitazoxanide, which resolved completely after the omission. Since edema is developed soon after the initiation of the nitazoxanide and resolved on the omission, the causality could be established, and it is undeniable to nitazoxanide is effective medications to lower IOP, as we observed in many clinical trials, but if evidence is needed to understand the effect of the medication is warranted. Now, few case report is published regarding to Rho kinase induced reticular epithelial edema. In fact, the multiple review of the literature suggests the beneficially action of the compromised cornea. So, option 2 is the Rho kinase inhibitors
Please conclude.
Lowering the intraocular pressure in the open angle glaucoma and ocular hypertension. So gradually, nitazoxanide is become the part of the glaucoma drug. And we needed to be aware of this new possible adverse effect nitazoxanide induced in reticular corneal edema. In the patient, we presented 4 cases such as induced Rho kinase inhibitor, which resolve the incidence warrant further studies regarding the clinical significance to understand the mechanism of corneal edema.
Hardi, your time is over.
Okay, ma'am.
Hardi, you presented well.
Thank you.
Hardi, you presented very well, but the pictures were so similar. Are they from the same patient?
No, sir. No.
Okay,
it's different patient. Okay.
So that just reaffirms what you're trying to say, that the pattern of the drug toxicity is quite similar in most patients, and that is something very well established by you. Preeti?
Yes.
No, she's presented well, and it is in fact these Rho kinase inhibitors are also touted to be used in bullous with corneal pathology, particularly when the endothelial function is low. So when the corneal specialists are using these, they also have to know that using this can also sort of worsen the corneal pathology. So it's a double-edged sword sometimes when you use it. In glaucoma, yes, you are not expecting any corneal improvement, but this is a side effect. But when it is used for other purposes, like improving your endothelial function, you have to know that it can worsen the endothelial function also. Not the endothelial function, but the corneal edema.
Yeah, great point. For Preeti, but just a message to all the presenters who are presenting cornea situations. Even if you don't have access to the photographs or the photography part, please learn to draw the corneal diagrams. I think that should be still a must. You can, when you're presenting on PowerPoint, you can just do it on a paper and take a photograph and do it. When you get examiners from Delhi, and a lot of you in Gujarat do get examiners from Delhi, they still expect it. So just keep this in mind. Very well done. We can move to the next. Thank you, Hardi.
Thank you, sir.
Now we can go to the Dr. Kshitij Gandhi from MNJ Institute of Ophthalmology. The topic is neovascular glaucoma, and the mentor is Dr. Kamini Prajapati. So over to you, Dr. Kshitij.
Am I audible, ma'am?
Yes, you are audible.
Okay. Good morning, respected consultant.
You can enlarge your screen, slideshow.
Good morning, respected consultants and my fellow students. Today I'm going to present a case of neovascular glaucoma. A 41-year-old male patient referred to our MNJ Institute for chief complaints of progressive and perilous diminution of vision in right eye for both distant and near vision since 1.5 months. Patient had no history of trauma and no associated complaints of flashes, floaters, colored halos, or distortion of vision. Patient had earlier consulted an outside clinic 1.5 months after initial chief complaint, where primary investigations were done, and patient was diagnosed with some retinal pathology for which bromphenic 0.09% eye drops thrice a day and tablet vitamin C 500 milligrams thrice a day were prescribed. Patient was then referred to MNJ Western Regional Institute of Ophthalmology after 4 months of treatment outside for vitreoretinal surgeon opinion. In terms of past history, patient had no history of ocular trauma, using glasses, any ocular surgeries or procedures, no history of drug allergy, no history of chronic systemic medication, and patient was recently diagnosed with hypertension since 3 months, and patient was taking tablet telmisartan 40 milligram OD for that. Patient had no history of diabetes mellitus, TB, or asthma, and family history and personal history were not significant. Coming to anterior segment examination, in right eye, the best corrected visual acuity was no PL, while in left eye, it was 6/6 on Snellen-Stat with -2 diopter sphere. Mild conjunctival congestion was noted in both eyes with normal anterior chamber depth of grade 4, Von Erich, and in right eye, relative apparent pupillary defect was noted along with rubeosis iridis around pupillary margin with ectropy on uvea. And in left eye, iris pupil were normal and gray reflex was noted in both eyes. Taking IOP with Goldman inclination tonometer, in right eye the pressures were 32 millimeter of Hg and in left eye 14 millimeter of Hg. As we can see in these slit lamp images, in right eye we can see the capillary tufts around the pupillary margin, which is also known as rubeosis iridis, while in left eye the anterior segment appears normal apart from conjunctival congestion. On further examining the patient, we undertook gonioscopy, in which in right eye the grade 0 to 1 angle was noted, along with neovascularization of the angle, as can be seen in the image. In left eye, the gonioscopy grade 3 open angles were found. The patient was then dilated with tropicamide and phenylephrine, and on slit lamp examination, cataract grading in both eye was nuclear sclerosis +2. On fundus examination, as can be seen in the photos, the media was hazy, and as a result, disc and blood vessels were hazily seen. Macula was not seen, while in background we can see fractional retinal detachment and vitreous hemorrhage in the right eye. Left eye fundus findings were normal with 0.2 cup disc ratio and healthy NRR, and fovea reflex was present. We did routine blood investigations which were within normal limits, and the blood pressure of the patient was at the time of presentation was also controlled at 138/82 millimeters of mercury. My provisional diagnosis was right eye neovascular glaucoma with fractional retinal detachment and vitreous hemorrhage post central retinal vein occlusion with immature cataract and controlled hypertension with treatment. Left eye findings were normal. Undertaking management of the patient, we started the patient on tablet acetazolamide 250 milligram 4 times a day with potassium supplementation. And in terms of topical therapy for right eye, we started prednisolone acetate 1% eye drops 4 times a day, atropine 1% eye ointment thrice a day, and brimonidine and timolol combination eye drops twice a day. Patient was also advised right eye anterior retinal cryotherapy with cyclocryotherapy for the painful blind eye in right eye. Thank you.
Go ahead, Preeti.
Yeah. Okay. What did you say was the age of the patient?
Ma'am, the age of the patient was 41 years old, male patient.
Okay, so pretty young. So now, vision-wise, he's no PL, you have said, in the right eye. So what we have to do is two-pronged. One is to find the cause why it occurred, one. And second is prevent a painful blind eye. Did he complain of pain from you? The pressure was 32, not much.
Yes, ma'am. The patient at the time of presentation did not complain of pain, and even the diminution of vision, as according to the patient, it was painless and progressive.
Okay, so one is that he does not have pain, and with a pressure of 32, so that does not really constitute a priority. The priority would be to find out why the CRVO occurred in that young patient who is non-diabetic and just, I think, hypertensive.
Yes,
Yeah, so that's what we need to find out. So you need to investigate the person more systemically to find out where he is. I mean, do a 2D echo, do a Doppler testing to find out the cause of the clot. So that needs to be more investigated more. And of course, painful blind eye, if it turns painful, then you can treat it as and when it occurs.
Yes, ma'am.
Right? But good presentation, good case.
Yeah, the same thing I would reiterate to you. Don't depend too much on photography. Please learn to draw retinal diagrams.
Yes,
Thank
sir.
you.
Thank you, sir.
Thank you.
Thank you, sir.
And thank you very much, sir, and Dr. Preeti ma'am. And we have also inquired about the COVID status of the patient, because the post-COVID, that might be a vascular occlusion.
Okay, so now we are going to the next presenter, that is Dr. Shalaka Chakrabarti. She's from GMERS Medical College, Guthri, and she's presenting a case of mucormycosis with a secondary bacterial infection. The mentor is Dr. Ashwini Sapre. So, Dr. Shalaka?
Ma'am, am I audible?
Yes, you are audible, but your screen is not visible. You can redo the thing because your screen is showing it has started sharing, but we are not able to see it. So if there is an issue, we can switch the presenters. Dr. Ruhi, are you available?
Yes, ma'am.
Yeah, so you can start sharing your screen. So Dr. Ruhi Gunai, she is from Drashti Netralaya, Dahod. She will be presenting conjunctival mass, and the mentor is Dr. Shreya Shah. Yes. Slideshow.
Yes, ma'am. Just a moment.
I'll request Dr. Alpa to comment on this at the end. You've been so quiet, Dr. Alpa.
So just click the slideshow. Yes, next to that.
Yes, ma'am. Actually, it has hanged. So I am waiting.
So if you can start presenting, so without slideshow, is it going? Then you can start.
Good morning, everyone. I am Dr. Ruhi Gune, a primary DNB resident of Drashti Netralaya. Today's case presentation is a case of limbal nodule.
Can't hear you.
Yeah, we can't hear you.
Am I audible now?
Yes,
Yes.
you are audible. You can start speaking. Yes.
The case history begins with a 49-year-old female who presented to the outpatient department with complaints of redness, watering, and foreign body sensation in her left eye for the past 1 month. The patient was relatively asymptomatic a month prior to the complaints. Then she developed redness, watering, and foreign body sensation in her affected eye, which was gradually progressive in nature. There was a history of trauma with a shard of wooden stick in her left eye. No other significant history was presented to us. On general examination, the patient was conscious, cooperative, and well-oriented in time, place, and person. Her vital parameters were normal. Her pulse was 72 per minute, respiratory rate was 16 per minute, blood pressure was normal. Her CVS, CNS, respiratory system, and per abdominal systems were normal. On ocular examination, the patient gave us an uncorrected and a best corrected visual acuity of 6/6 for distance and N6 for near. On slit lamp examination, the lid was within normal limits. The adnexa was normal. Patient showed a sectoral conjunctival congestion with a 6/5 millimeter nodular, fleshy, well-defined, circumscribed, elevated mass, which was situated at the limbus with 2 large feeder vessels that were present. Her cornea, anterior chamber, sclera, iris, pupil, and fundus were within normal limits. Her other eye findings were normal. The less commonly noticed signs, the signs that we missed, were a restriction of the abductor movements, 1 millimeter of lid lag, a loss of corneal sensation, and a mild axial proptosis. We investigated the patient by doing an anterior segment photography. We measured her ocular movements. We did a Hirschberg testing in all gazes. We did a complete strabismic workup. We did an exophthalmometry keeping the mild axial proptosis in mind. And we did an USG in an orbit mode. The provisional diagnosis that we thought it could be a pyogenic granuloma, since the patient gave a history of trauma in her affected eye. The second provisional we thought could be a squamous cell carcinoma because of the description of her mass and the presence of the large feeder vessels that were seen. But we missed out these DDs that it could be a paretic strabismus or an inflammatory nodular pathology or an axial proptosis. We started her on an anti-inflammatory cover by giving her prednisolone acetate 1% thrice a day for 7 days, along with ocular soothing agents, that is carboxymethylcellulose 0.5% 2 hourly. We called her for a routine follow-up after 3 days. The patient was then diagnosed to have a simple inflammatory nodular limbal mass because it regressed in size and intensity on administration of the topical anti-inflammatory agents, along with the regression of her other symptoms as well. We called the patient for routine monthly follow-ups, tapered the steroidal cover. We monitored the progression and regression of symptoms, and we evaluated the size, intensity of the limbal nodule, as well as surrounding tissue invasion, if any. Thank you.
You said you consider it as a pyogenic granuloma also?
Yes, ma'am.
But you started steroids. So how did you rule out that?
Ma'am, we did not do any other investigations to rule it out. The patient was actually of a poor socioeconomic status. So we thought the best approach would just be to give her a topical anti-inflammatory and then see her course and see the regression of her pathology and her symptoms and then decide accordingly.
Was the picture more like a nodular episcleritis?
Yeah, no, Rui, but what Dr. Alpa is asking, if you were to do the investigations for a pyogenic granuloma, what would you do? Tell us that.
A histopathology sampling of the sample can be sent in order to diagnose it as a pyogenic granuloma.
So histopathology specimen will come from where? What biopsy will you do?
Or the nodular mass, I mean the excision of the mass.
Yeah. So
And
Dr.
the
Alpa,
surrounding lesion as well.
Dr. Alpa, for the audience, why don't you summarize the correct approach?
Dr. Ruhi, your presentation was good. what we are trying to tell you is that whatever you are presenting, you should always support it with whatever you have done. So you were telling your differential diagnosis as you have a pyogenic granuloma, you said, so that you have to support by your investigation.
Yes.
If your first diagnosis was nodular episcleritis, then it is your approach is good that you have started steroid, because that was your first diagnosis. You would have said that differential diagnoses are other, but you have ruled out by your clinical, okay, your patient was not socioeconomically good and you didn't do other investigation, then also you can present that these are the other things by which we ruled out these, and we said that this must be nodular episcleritis or inflammatory in nature, and that is why we started steroid.
If there is a time, I'll ask only one question. What is the difference between Dr. Ruhi, pyogenic granuloma, and the diagnosis which you made, inflammatory nodule, I guess? Dr. Ruhi, can you hear me?
Yes, ma'am, I can hear you.
So actually, pyogenic granuloma is a misnomer. It's an inflammatory condition which gets treated very well with steroids. So I think that is what Dr. Alpa was trying to say, that before you start steroids, the only thing what you need to rule out is whether it is infective or not. And your treatment was good. So this could be put even under the pyogenic granuloma, which supports your history also. Pyogenic granuloma is a misnomer and it's an inflammatory condition.
Absolutely. So now we have come to the end. It's the last presentation, and that is by Dr. Shalaka. So you can start sharing.
Ma'am, am I audible now?
Yes, yes.
Yeah, a very good morning to everyone present over here. I'm Dr. Shalaka Chakravarti from GMERS Hospital, Vadodara. I'll be presenting a case of mucormycosis with secondary bacterial infection admitted at GMERS. So beginning with the patient details, 54-year-old male.
You can make your slide. No, we are not able to see your slides. So make your presentation in a slideshow mode. So it's not going, it's not forwarding. Dr. Shalaka?
Ma'am, can you see the slideshow now?
No, we are able to see only your first screen. So if you are not able to do slideshow, then click every slide. Like go to the second slide now.
Okay, ma'am. So presenting a case of 54-year-old male.
No, still we are not able to see your second slide. You click the second slide.
I think Dr. Shalaka, you have selected that box within your slide. So you are in the edit mode.
Yes, yes, you are in your edit mode. So come out of that.
So just click on your slide 1 and then put it on a slideshow mode. I can simply close your PPT and open it again.
Ma'am, can you see it now?
The first slide is visible, but the slides are not moving.
Just double click on the second slide on the left. Double click on that. The one which is highlighted, uske niche wali ko double click karo.
I think she is seeing different than us. So you can go back and start sharing again.
Ma'am, can you see now?
Yes, yes. Now we can see. And you can go to the slideshow if it is possible. Otherwise, you can start talking.
Yeah. So presenting a case of 54-year-old male who was admitted at GMERS on the 27th of May 2021 with a biopsy confirmed mucormycosis case. So the patient presented to us with presented to us with chief complaints of dimness of vision in his left eye and pain on the left side of face and headache. On examination, we found out that the visual acuity of the patient was a no PL at presentation. His EOM showed a total restriction in all directions, and there was presence of proptosis, ptosis,
congestion. Pupillary reflex showed relative afferent pupillary defect. As per the protocol, we made all three references. From the ophthalmology side, we decided to go on for a MRI. From the ENT side, they decided to go on for a FEST, and there was no active management from the dental side. The MRI findings were suggestive of pansinusitis and involvement till the left orbital apex, while the FEST findings came out positive, the biopsy came out positive for mucormycosis. So based on the findings, the opthal side, we decided to go on for retrobulbar amphotericin B, while the ENT people decided to start on intravenous amphotericin B in this patient. 5 doses of retrobulbar amphotericin B was given, and on the last dose, we observed that there was a flare-up of the swelling and conjunctival chemosis and congestion in this patient. So we made an oculoplastic reference for the same, and we thought that we would have to go for exenteration with this patient. But here comes a turning point in this case, which makes it worth a mention, that we examined that the swelling was a fluctuant one. So we decided to go on for a repeat MRI in this patient, and with the repeat MRI we found out that the patient had an abscess in the superomedial quadrant of his left orbit. So exenteration was deferred for the meanwhile, and we went on for a superior orbitotomy in this patient with regular dressings with topical antibiotics, and systemically we started him with linezolid twice a day dosing for 14 days. The results that we got were quite unexpected and nice, that the patient could be discharged after 21 days of his intravenous amphotericin B, and on his subsequent follow-ups we saw that the overall bulk had reduced, the patient felt better symptomatically and cosmetically, and the patient was saved from undergoing an exenteration and a lifetime of debility. Thank you.
So to the judges, any comment?
So the second MRI was done on your insistence, or it was done on the insistence of the oculoplasty surgeon whom you had referred to? Because that changed the management. That's why I'm asking.
Ma'am, we decided to go on for a oculoplastic opinion because there was a flare-up with the findings.
No. So the second MRI, the oculoplasty guys ordered.
Yes, ma'am.
So no, well presented and well managed, and the patient had a happy outcome. That's a nice thing. So
Thank
no
you,
questions from my side. If the other judges, Tuli sir, is he there?
Sorry, I'm there. I was.
Okay. Hi.
Yeah, so I think very well presented by all, and I can use one. I know one Gujarati word, which is Saras presentation by all. So thank you so much.
Yes. So now we have come to the end of our first session, that is ocular surface and glaucoma. I would like to thank all the presenters and their mentors for their wonderful contribution. And big thanks to all the judges for their very valuable inputs. I'm very sure that that will be very helpful to the residents for their future presentations, and as well as their clinical management when they will be dealing with the patients. So thanks to everyone, and thanks to Dr. Purvi and Dr. Gunjan for all this organizing this such a big meet. Thank you very much.
Thank you all.
Thank you, ma'am. I'm very much thankful to all the judges of our first session, and Kamini madam and Shwetamari madam to moderate this session nicely. I'm very much thankful to all the residents because they stick to time and we are bang on time. So without wasting time, I'll go to the next speaker. I think someone who's there is some disturbance.
We are not able to see find any disturbance, so you can continue.
Okay. Our next speaker is Dr. Savitri Deval. She will be speaking about journey of a clinician scientist. She has done her MBBS from Baroda Medical College and MS Ophthalm from AMC Met Medical College, LG Hospital. She is presently working as cataract and refractive services clinician and translational researcher at Narayan Nethralaya, Bangalore. Her work experiences as a senior resident at CH Nagari Eye Hospital, Ahmedabad, and fellowship in cataract and refractive surgery at Narayan Nethralaya, Bangalore. Academically, she is very sound. She has several paper, poster, and video presentations at various international and national state platforms like International CXL Experts Meet, All India Ophthalmological Conference, All Gujarat Ophthalmological Conference, and Delhi Ophthalmological Society Annual Conference. So on behalf of WAS State Gujarat Chapter, we welcome you, Dr. Savitri. Over to you.
Am I audible, ma'am?
Yes, you are audible.
Okay. I'm sharing my screen now. A very good afternoon to you all. So before I begin my presentation, I take this opportunity to thank WAS for their kind invitation and also express my deep gratitude towards Dr. Rohit Shetty sir for giving this opportunity to present our work on this platform. So I'm walking you now through my amazing journey as a clinician scientist. So everyone has their own path and their own life, and my life has been different on certain lines. So I'm a military kid, and growing up as a defense brat, so I imbibed certain traits my father had. So discipline, persistence, perspective, teamwork, and self-confidence was deeply rooted in me since the beginning. I always had one dream, which was to become a doctor. So all I ever knew was that sky is the limit. This is basically what my PG life looks in a nutshell. So juggling between different authors, huge piles of books, performing surgeries, and presenting few papers at state and national levels. So then came the year historical 2020. So historical for me as I got convocated as an MS Opthal, so which was the accomplishment of a lifetime for me, and historical for the world because it was endowed with the famous COVID-19 pandemic. So adding to the confusion later was the most unwelcomed global lockdown, which offered training constraints everywhere. So this got me to question myself, my future, my fate, and the choices I opted for in life. So then 2022 happened. So I got married, and you must be wondering how these images are relevant to today's talk. So that's my husband. He's a fighter jet pilot in the Indian Air Force. So along with the husband, 2021 gave me answers to all my questions and all my insecurities. So this was a time when realization dawned upon me that you have no bounds and sky is not the limit. It's just the beginning. Sky is not the limit. I am the limit. So what was my inspiration for joining NN? So I'm glad to be one of those PGs who had a clarity by the end of their MS as to what specialty they want and what their inclination was. So I had no doubt, and I had to join the mecca of the refractive surgery, which is the NN. So enthusiasm was always there for innovation and publication. And the unflinching quest and the zeal for research was always there. And undoubtedly, ours is the only training institute which has stood by its students and is still doing justice to their training as far as the global pandemic and lockdown is concerned. So this started the new chapter in my life. So beginning of a new journey, I shifted to Bangalore. So this is what a daily routine of my life at NN looks like. So in the morning, we have a camp OT and camp OPDs, wherein we are performing phacoemulsification surgeries and the topical. And also we are well versed by now in complicated IL calculations. For example, the post-refractive surgery IL power calculations, the toric calculations, and also the customized IL for the cataract surgery in the keratoconus. As far as the refractive and the KC procedures are concerned, so we are doing LASIK, PRK, topo-guided custom ablation treatment, and collagen cross-linking, topography-guided photorefractive keratectomy, that is the TPRK, and the phototherapeutic keratectomy routinely. So the afternoon sessions are actually a blessing because we get to work in the lab. So this is what my fancy workstation in the afternoon looks like. Now, being a clinician scientist and researcher at NN, so these are the building blocks of our lab. So we have the GROW lab, which stands for the Genes Repair and the Regeneration in Ophthalmic Workstation, which is very much instrumental in all our genetic ventures. We have the IBMS, which is the Imaging Biomechanics and Mathematical Modeling Solution, which offers a screening and decides for the refractive surgery which the patient has to undergo. So reflecting back a little now, so how it started in my PG was doing refraction, surgery, regular OPDs, and of course attending ICALs. So how it's going is that we are working on research, publications, and international presentations as a routine now. I'm going to discuss and showcase some of my projects here. So I'm very fortunate to be a part of this extensive study, which is the BED study, that is the blood epithelium in the tear study. So what this study is actually about, so it's a high put-through sequencing for the new molecular biomarkers in keratoconus. Why this study was undertaken at all? So only so worldwide, whatever studies are done in this direction includes only the Western population. So ours is the first institute, which is including the South Indian population. Also, only a few panel-based mutations targeting genes like the LOX, the MMP9, and the interleukin-6 have been studied. And also, we know that keratoconus is a multifactorial disease whose etiology is yet to be elucidated. So how this study is working is that we collect the blood and subject it to genome profiling. So from the epithelium, we are studying the RNA expression and correlating it with the mutations. And from the tears obtained from the Schirmer strips, we are subjecting it to the protein expression. So in this way, we are basically addressing all the three dogmas of the molecular biology. Another one of my studies is the keratoconus family pedigree genetic study. This is also a high throughput sequencing where we are checking the factors and their influence in a pedigree family. It helps in identifying the mutations which may be the cause of KC, and also in certain patients, we are seeing this disease at an early stage of 12 to 13 years. So it is helping us to identify those genes which are causing an early onset of KC. Another one of my studies is the genome-wide association study, which is commonly known as the GIVA study. So why this study was undertaken at all? Because there was a need of global genomic association as to what is causing keratoconus at all. So it's a panel-based mutation screening wherein 50,000 genes are being targeted, and we are finding genetic pattern of LOX, MMP, and the interleukin-6 and its associated genes. So this is just to offer you a glimpse of our dedicated clinical grade gene therapy vector production facility at NN for clinical grade viral vector manufacturing in India, which is a part of Make in India project. This is world's first one of its kind toolkit, the BioM Pathfinder, wherein the biological samples like the tears obtained from the Schirmer strip, the aqueous and the serum are subjected to sampling. And at the end of 1 hour and 20 minutes, a complete and comprehensive analysis of all the samples are obtained in the form of a test report. So as you can see, it gives a panel of biomolecules, for example, the interleukin-6, the interleukin-10, VEGF-A, and ICAM-1 to name a few. So how we intend to put this in our daily routine is that these biomolecules can serve us as a surrogate marker in the diagnosis and management of ocular illness like dry eye management, the uveitis, and retinal disorders like the ROP and optic nerve degeneration. We have the Vision Research and Center for the Unknown, wherein clinicians questions dilemmas. We have the genetic and the gene therapy, the BioM Pathfinder and imaging, where answers to the unknown are sought and addressed at the eye gaps, and which forms the basis of the personalized medicine and ophthalmology. So now, what's the way forward? So we are fortunate enough to have the brains and the resources at NN to open up new avenues in gene therapy worldwide. We are working towards human trials for gene therapy in India. So this biomolecular kit can bring about a paradigm shift for the future generations to come. We are extensively working at NN. We are analyzing hundreds to thousands of samples daily to build up a huge database so that it can be brought to the market very soon and will be available for the clinicians to make up diagnosis based on biomolecules alone. So towards the end, to sum it up, so my amazing journey as a clinician scientist and my success has been deeply rooted in the belief that we have to make the things happen. It's not about being the best, but it is about being a better version of who you were yesterday. With that, I conclude my talk. Thank you for your patience listening.
Thank you, Dr. Savitri.
Thank you.
It was a wonderful, wonderful presentation. And most of our residents during residency, they are like relaxed. So because residency is going on, and suddenly when the results are announced, there is sudden vacuum that what to do. So here they can have some of an ideas what can be the next plan.
So that was basically the plan of bringing out this presentation, because I have been through the same phase. So this might be a guiding path for the PGs or who are going to pass out next year, because this lockdown is not going to end. It's going to continue. It's the new norm.
Yes, yes. Hope it ends soon.
Yes.
Okay.
Thank you.
Thank you. Our next speaker is Dr. Insha Aftab. She will be speaking about journey forwards towards enhancing surgical skills as a woman ophthalmologist. She is presently working as a fellow in phaco-refractive surgery at Tirupati Eye Center, Noida. She has done her MBBS from GSVM Medical College, Kanpur, MS Ophthal from RIMS, Manipur. She is ICSC from WH Smith Memorial School. Her areas of interest are phaco-refractive surgery, and experiences has worked as RK Netralaya Varanasi and ongoing fellowship here. We welcome Dr. Insha. Over to you.
Thank you, ma'am. Thank you, ma'am, for introducing me. Can you hear me?
Yes, yes, you are audible.
Thank you, ma'am. Good morning, everyone. Sorry, good afternoon, everyone. We will be talking on, I will be sharing my screen now. Okay, just 1 second. Did it share? Okay. 1 second. My screen is visible? No. Yes. Is my screen visible to everyone?
Yes, it is visible.
Okay. I will be talking on journey towards forwards towards enhancing surgical skills as women ophthalmologists. In foreign countries, minimum surgery requirement that is required, like in Australia and New Zealand, you need like almost 20 intraocular surgeries in first 2 years only. Sorry. In UK, they need 50 cataract surgeries in first 2 years and 50 at the end of training. And in US, they need 86 cataract surgeries prior to graduation. But in India, this is a harsh truth that we know there's inadequate surgical exposure to us in residency training. Like my own experience in first year, I did just assisting. In second year, I was doing minor OT procedures and a little step in SICS. Then by third year, final year only, I got some hands-on SICS training and this one fake TGM surgeries, but no phaco I got there. So we need more surgical exposure in surgical residency training. As a women ophthalmologist, we have these gender differences. Like at our end only, we have to balance between work and family. We need to we tend to take some breaks also, like for maternity leaves or for family things. So there's gender differences comes from our end also. Then at patient level also, like my own people, I've heard that they prefer to go to male surgeons more than female surgeons. So we have to change that also at patient level. At mental level also we have seen, but I haven't experienced this thing. At mental level, whether it's a male sir or a female ma'am, all have given us equal opportunities. But some people say that they have this difference there also. We need to enhance our surgical skills. Why it is there? Because these days, one study was telling us that in cataract surgery, complications are now the third most common cause of blindness in Indians above 50 years of age. It accounts for 7.2% of blindness nowadays. So we have to improve at our end. There's a huge unmet need for standardized and monitored training. Like we need more quality-based training and quantity-based training. My professional journey, I told before, like in 3-year residency, I just got few SICS, no phaco. And after doing job after residency, post residency, I got mostly SICS only, few phaco. I thought that I need to improve, enhance my skills. So that won't help. So I joined a fellowship training. Right now I'm ongoing in this phaco refractive fellowship training, which I'm getting more hands-on phaco, more enhance the skills. Like so. as a women ophthalmologist, we have to improve ourselves. We keep on improving ourselves until unless we are at that platform that we want to go. There's a good survey done by Dr. Ishita. This survey was done on women ophthalmologists. You can see that most of the women ophthalmologists, they are interested to go in clinical work, but they are not getting enough clinical work post residency. Okay. And why they are not getting? They are saying that either due to inadequate patient load, like at the patient level, they want to go to more towards male surgeons than female surgeons. They are not getting enough clinical training. Environment, working environment is not there, or gender bias they are seeing. Then, but still, they want. They are more interested in future training or fellowship to improve themselves at our end. Then, but still, as women ophthalmologists, we all want a short-term trainings instead of long trainings. Like mostly, they prefer for 1 month training, 1 week training, less than 1 year training. And most of them, they didn't feel that we have enough training and fellowship facilities in India. But they are still willing that if they are trained enough, they can train for the future women ophthalmologists. They are willing to train them. But right now, they are not happy with the current residency program going on in our country right now. And how we can improve the surgical skills? We can set criteria like in foreign countries, we have seen already, they have set criteria from mentors to residents, how many surgeries they should be undergoing. And like we call more patients from tertiary centers, but they have more complicated cases. So we don't get good surgical skills from them. So we can call patients from community health centers, which have more common cases. And we can have separate training OTs. Plus communication and managerial skills can be improved on a, there should be more review of surgical videos, more virtual reality surgical simulators. We can have wet lab trainings. As women ophthalmologists, we need to balance family and work and move forward. But we are not alone in this. We have this very good platform, Women Ophthalmic Society, in which we have a very good mentor and mentee program, in which we can mentor others who need it, and we can be a mentee also. So we can join on this platform. Together, hand in hand, we can move forward. This mentorship program is there, mentor and mentee program, and online resident programs is also there. Today, I'm going to this one. We need to celebrate how far women ophthalmologists have come, but this thing that we need to go more far than this. So hand in hand, we can move forward. We can teach others, and we can learn from others. With this, I end up my presentation. Thank you. Thank you, everyone.
Thank you, Dr. Insha. Really, and this year's International Women's Day theme is also break the bias. We all know that it is very difficult to break the bias, but together definitely we can do the difference. And what I want to suggest all residents, that even if you are not getting good hands-on, you can always observe your senior surgeons, because you have to observe how they are performing the surgeries, how they are managing the complications. So that is also important. Not every time you will not be doing each complications on you by yourself. So you have to learn from other surgeons and other surgeons' complications and their skills also. Everyone has a different technique. So just next time, whenever you go in OT, just observe everything, because the maximum you observe, maximum you will be learning. Now we'll move forward to our next session, that is on oculoplasty and trauma. And I'm the one of the moderators, and along with me, Dr. Ravija will be moderating this session. She is a very good friend, and she is a fellow of Orbit Oculoplasty and Reconstructive Services from Sankara Chennai. And she has done her graduation from Baroda Medical College, Gujarat. She was awarded gold medal for Best Outstanding Fellow, and currently she is working as assistant professor at MNJ Western Regional Institute of Ophthalmology. Welcome, Dr. Ravija. Over to you.
Thank you, Dr. Gunjan, Dr. Purvi, and WS, and congratulations for this amazing webinar. I'll begin with introducing our distinguished judges. The first one is Dr. Jayashree Barua. She is the Joint Secretary of International Society of Manual Small Incision Cataract Surgeons, State Coordinator of Assam Chapter of
ISMS-ICS, Coordinator of Global SICS Training Program, and State Coordinator of ECOIN Assam Chapter. She is currently the Consultant and Head of Comprehensive and Community Services at Tejpur Eye Hospital. Her specialization is anterior segment and medical retina. She has been associated actively with improving the eye health in several unreached and difficult terrains of Uttarakhand, instrumental in starting state-of-art facility for the underprivileged, downtrodden, and poor in the north bank of Assam. She is passionate about serving the needy and giving the best in difficult and complicated cases, and has the record of operating most challenging cases of differently abled and physically challenged children having congenital and complicated cataracts. She is also actively involved in clinics, academics, training, as well as research. Her areas of interest are surgical training programs in PHECO and manual SICS. Our next judge is Dr. Radhika Paranjpe. She is working as Associate Professor in the Department of Ophthalmology at D.Y. Patil Medical College, Pune. She was ex-secretary of Pune Ophthalmological Society and recipient of the POS late Dr. Asha Kelkar Award. Our third judge is Dr. Rajwinder Kaur. She has done her MBBS from Government Medical College, Amritsar, and MS Ophthalmology from GMC Patiala. She also has fellowship in ROP from Arvind Coimbatore. She is currently working as professor at Adesh Institute of Medical Sciences and Research. She is a senior consultant in Retina Clinic and a regular presenter at international, national, state conferences, and she has many publications to her credit. I welcome you all to this session of oculoplasty and trauma, and I would like to request the participants to abide to the time.
So we start with our first presenter. He is Dr. Mayur Dangi. He is from AMC Medical College, Ahmedabad, and his mentors are Dr. Anupama Mahant and Dr. Sapan Shah. And the topic is cavernous hemangioma. Dr. Mayur, please share your screen. Dr. Mayur, are you there?
Yes, ma'am. My screen is visible, ma'am?
Yes, visible. You are audible also.
Okay. Okay. Hello. Good afternoon, everyone. I am Dr. Mayur Dangi, second year resident doctor. Today I am presenting a case on the orbital cavernous hemangioma. My mentor is Dr. Anupama Mahant ma'am and Dr. Sapan Shah sir from AMC Medical College, Ahmedabad. 65-year-old Hindu female patient come to the IOPD with the chief complaint of swelling in the right eye since last 6 months and diminution of vision since last 6 months. There is no history of any trauma, redness and irritation in the eye, changes in weight and appetite. There is no history of any heat or cold intolerance, no history of swelling elsewhere in the body. There is no history of night sweats and no history of similar complaint in the past. On an ocular examination, I have examined the visual acuity of both eye, where there is no perception of light in the right eye, and left eye there is visual acuity of 6/24. On examination, both right side, both upper lid and lower lid are edematous, while left eye is normal. On conjunctiva, right side conjunctiva is mild congested. Cornea is clear right side. Right side anterior segment is normal in both eye, normal in depth and quiet. Iris appear normal in color and pattern in both eye. On right side, there is a relative pupillary afferent effect, whereas the normal in left eye in size in reaction to light. Both eyes there is immature senile cataract. In the globe position, there is a right eye axial proptosis, visible proptosis in the right eye, where normal left eye is normal in position. Right sided, there is a restricted movement of extraocular muscle in all direction, and there is a free and a full movement in the left eye. On fundus examination, there is a right eye disc failure with a choroidal fold and pigmentary changes in the periphery, effardal and tessellated background present, whereas the left eye fundus is normal. On my orbital evaluation, there is a right eye axial, visible right eye axial proptosis. I have measured the proptosis by Hertel exophthalmometer, where base is set at the 90 mm, and my reading in the right eye is 26 mm and left eye 18 mm. There is a restriction of ocular movement in all direction. There is intake and regular orbital margins, and a finger insinuation is possible between the globe and bony orbital margin. This is a preoperative picture of the patient, which shows the visible right eye proptosis with upper and lower lid edema, and there is mild congestion in the right eye, whereas the left eye is normal in position, and no such edema or congested in the left eye. We have done the imaging MRI orbit and brain. MRI findings suggestive of 3.5 to 3 centimeter well circumscribed right intracorneal mass in the location, which is compressing the optic nerve superiorly, as shown in the slide of MRI scan, and which leads to the outward displacement of the right globe. We have done all the blood investigation, routine blood investigation, which is within a normal limit, and systemic screening like chest X-ray, USG, abdomen, pelvis, which shows no evidence of any metastasis. We have operated the patient for right eye inferolateral orbitotomy surgery with inferior forenasal approach and mass excision biopsy under general anesthesia. In which there is an intracorneal mass of approximately 3.5 to 3 centimeters exist during the surgery, and it is later sent for the histopathological examination. This is a post-operative picture of the patient immediately after post-operatively next day, which shows there is no visible proptosis, but there is a mild edema and congestion of both upper lid and lower lid of right eye. Histopathological examination, microscopic examination. Hello.
You have 2 minutes left, which includes discussion as well.
Your time is over.
I will manage. Okay. Microscopic examination revealed the tumor composed of the proliferation of mainly cavernous-sized vascular channel. It is lined by endothelial cell.
You can summarize now.
Yes, ma'am. I have a follow-up patient in 1 week with no complaint, proptosis resolved, and movement normal in the all direction. On discussion, cavernous hemangioma is benign, slowly progressive.
You can skip this. Now we can invite judges for the question.
Yeah, very well presented, Dr. Mayur. I just wanted to know, did you rule out any other involvement in any other areas, and specifically in the lacrimal apparatus, which is the area that you should look out when you're dealing with such a case?
Yes, ma'am.
Yeah, where are the other areas where you should rule out? Because there are chances where you may have multiple tumors, right? So what are the other places where you have to rule out?
Ma'am, tumor most commonly there is a intraorbital tumor. So there is two part, intraocular and extraocular. In extraocular, there is three intraconal, conal and extraconal spaces where tumor may be present. And the fourth one is intraorbital tumor, intraocular tumor.
Okay. Specifically, you should look for the lacrimal gland area, because the osseous involvement, apart from the orbital bones, there is the involvement of the osseous involvement occurring inside the lacrimal gland. So you should be very specific about looking into the lacrimal gland area. Yes, but very nicely presented. Good and good documentation. Thanks.
What were the other differential diagnoses?
This is an intraconal mass of orbital tumor. So there may be optic nerve glioma, there may be optic nerve meningioma, may be possible. Capillary hemangioma, maybe to be ruled out.
Okay.
Time is over.
That's all. Good presentation.
Our next presenter is Dr. Pooja Patel. She is from AMC Met Medical College, Ahmedabad. Her mentors are Dr. Anupama Mahant and Dr. Vijay Damor, and she will be speaking about golden hair syndrome. Dr. Pooja.
Is my slide visible? Hello?
It's visible. It is visible.
Visible.
Yes. So good afternoon, everyone. I am presenting a case report on a golden hair syndrome, and my mentors are Dr. Anupama Mahant ma'am and Dr. Vijay Damor sir. we have an 11-month-old Hindu female child was brought by her parents, complaining of a right eye swelling over the inferior area since the birth. The birth history and the family history was not so significant, and the developmental history patient has achieved all the milestone for her age. On the torchlight examination, as the patient is 11th month old, so visual acuity is that the patient follows object in both the eyes. The eyelids were normal in both the eyes. There was a 2 into 1.5 centimeter size yellowish solid swelling located at the inferior limbal area, extending onto the cornea and covering half of the pupillary area on the right side. So the anterior segment and the fundus in the right eye is normal till the visible extent, while the left eye is quite normal. And the other features includes the bilateral preauricular skin tags, flat nasal tip, deviated nose, and the facial asymmetry. These are the picture of a patient showing right eye limbal dermoid which extend on the cornea and covering the pupillary axis, half of the pupillary axis. It also showing that the preauricular skin tags and the facial asymmetry, where the nose is deviated towards the left side and the flattening of the nasal tip. On a systemic examination, there was no any other abnormalities were detected. The complete blood counts and the peripheral smear was also within the normal limit. We performed the chest X and the X-ray of spine to rule out any spinal deformities or any abnormal rib deformities. We also performed the ECG and 2D code to rule out any cardiac association. The autoacoustic emission test was performed to rule out any hearing loss or is there or not, but all of them were normal. On the management, we did the complete excision of the limbal dermoid along with the amniotic membrane graft and glue under the general anesthesia and sent the tissue for a histopathological examination, which reveals the stratified squamous epithelium and subepithelial tissue showing a thick bundle of a collagen with a mature adipose tissue, and the specimen also containing the hair follicle. So it's suggestive of a lipodermoid tumor. This is a post-operative picture on the follow-up on day 10, which shows the graft in a position, and there is a there is a no deformity. And the Goldenhar syndrome is a birth defect resulting from a maldevelopment of the first and second tracheal arches. There is an incomplete development of the ear, nose, soft palate, lips, and the mandible. It is sporadic and it is more common unilaterally. That is 70 to 80% of the cases. The incidence rate is between 1 into 3,000 to 5,600 live births. It is more common in the male than the female. The ratio is 2:1. The classical triad of a Goldenhar syndrome is epibulbar dermoid, preauricular appendages, and the pretracheal fistula. The ocular manifestations are there in the 50% of the cases, which includes the limbal dermoid, which is more common and located into the inferior temporal area. There can be presence of eyelid coloboma. In the extraocular manifestation, it includes the ear-related anomalies, which are more common, which includes the preauricular skin tags, microotia or anotia of the external ear with the hearing loss and the middle ear malformation. The vertebral anomalies includes the butterfly vertebrae, hemivertebrae, scoliosis, spina bifida, and the congenital heart disease could be there, which includes ASD or VSD. There could be possibility of central nervous system involvement, which includes the hydrocephalus, intracranial lipomas, and the mental retardation. The management part requires a multidisciplinary approach from the different departments. From the ocular point of view, the large eyelid coloboma requires a surgical repair. If there is a small dermoid which causes astigmatism, then it could be treated with the glasses. If the patient is not concerned with the patient is not concerned with that dermoid. If the dermoid causing occlusive or astigmatic amblyopia due to the large dermoid, it requires a superficial keratectomy and excision.
Pooja, your time is up.
Okay, ma'am.
You can summarize.
And thank you.
Now I invite judges for the questions.
Pediatric consultation was done in this case?
Yes, ma'am. The pediatric consultation was done to rule out any kind of abnormalities associated with the Goldenhar, and they have asked for the 2D echo and the ECG to rule out any kind of cardiac abnormalities were there or not, and we sent them to perform all these things. But all the there is no any systemic association like a cardiac or the vertebral anomalies were not there. There's only two features, that is an ocular and the ENT related features were there.
Do you have the long-term follow-up of this child now?
Yes, ma'am. We
Post
have
10 days.
Yes, we have asked the patient to come on a regular follow-up, but patient is outside of not residing in the Gujarat, so she lost the follow-up further.
You have to see how he is doing in long-term.
Yes, we want to see. We have the contact number that is not possible.
Yeah, this is very important to counsel them for refraction part of view, because graft is there, so they should be counseled for that from vision point of view.
Yes, ma'am.
And what were the rehabilitation done by ENT people?
ENT people ask for that preauricular tags excision, but that patients, parents are not convinced by them, and the rest of the ocular, rest of the ENT side, the patient hearing is also normal, so they are not much more concerned for that point of view. They are concerned for that ocular lipodermoid, for that they have come only.
So they are more concerned with the cosmetic part.
Yes, cosmetic, and that eye is very large dermoid. For that, they are very much concerned.
6 minutes are up.
Thank you.
Thank you, Dr. Pooja. Our next speaker is Dr. Ruju Upadhyay. She is from GMERS Medical College, Gotri. Her mentor is Dr. Hina Radadia, ma'am. And the topic is orbital exenteration, a life-saving surgery in post-COVID rhino-orbital cerebral mucormycosis. You are not audible, Ruju.
Yes. Good afternoon, everyone. I'm presenting a case of orbital exenteration in post-COVID rhino-orbital cerebral mucormycosis patient. The patient was 58 years old, male. He was a non-worker, Hindu by religion, and residing in Baroda. The patient presented with a complaint of headache. Sorry, ma'am. The patient presented with the complaint of headache since 15 days, pain and swelling around eye since 7 days, loss of vision in right eye since 7 days, and nasal bleeding since 7 days. The headache was over right side of the region and right side of frontal region, and it was continuous in nature. The pain over right eye was also continuous in nature. He also developed swelling in periorbital region of right eye along with redness of the eye. Patient had sudden loss of vision since 7 days. He also had 2 to 3 episodes of bleeding from nose and pain around root of nose. On presentation, patient also had breathlessness and was unable to eat and chew food since 3 days. There was no history of vomiting or nausea, no history of ocular trauma or trauma to nose, no history of flashes or floaters or shadow or curtain-like things obstructing visual field, or no recent surgeries. Patient is a known case of diabetic mellitus since 10 years and is on regular medication. He had contracted COVID-19 infection before 2 months, and on before 2 months of present.
Sorry to interrupt. If you can do it on a slideshow mode.
So patient was a known case of patient had contracted COVID-19 infection before 2 months of presentation and was hospitalized for the same and was given O2 therapy and injectable steroids. During his hospital stay from COVID, he had uncontrolled sugar levels, no history of similar complaints in past, or no history of previous hospital stay before COVID, or chronic cough, breathlessness, cardiovascular disease, hypertension, or other systemic disease. Patient was a vegetarian with markedly reduced appetite, disturbed sleep pattern, unaltered bowel bladder habits, and tobacco addiction since 25 years of age, since 25 years, and there was no significant family history. On general physical examination, the general physical examination of patient was normal with saturation 98% with 4 little nasal prongs. Patient had poor dental hygiene, stained teeth, and no evidence of pallor, icterus, clubbing, cyanosis, lymphedema, or edema. Systemic examination, cardiovascular, respiratory, per abdomen system were normal. On ocular examination, head posture is erect, facial symmetry was maintained, Visual acuity unaided of right eye was no perception of light and left eye was 6.9. Near vision, right eye no perception of light and left eye was an 8. Extraocular movements of right eye were restricted in all directions and left eye it was normal in all directions. This is the picture of right eye on presentation. On torchlight examination, patient had severe ptosis and severe proptosis of right eye. There was chemosis and congestion of conjunctiva. Cornea was clear, anterior chamber and iris normal. Pupil was mid-dilated and not reactive to light, and lens had immature cataract. Left eye was normal. Refractive status of right eye, no perception of light. Of left eye, it was minus 6.6 and M6 with glasses. On fundus examination, right eye was suggestive of CRAO and left eye was normal. We went for MRI of the patient. So on MRI findings, we have involvement of right cavernous sinus, right orbital apex, right internal carotid artery involvement, and also extracorneal and fat muscle involvement of right eye. And patient also had pansinusitis and bilateral masticator space was also involved. So we went for KOH of nasal and sinus mucosa. So we removed a part of nasal and sinus mucosa on endoscopy, and patient was the KOH finding was suggestive of mucormycosis. So the diagnosis was right orbital, retroorbital, pansinusal, and potential cerebral spread with right eye CRAO. So on management, patient was
for 4 minutes.
Okay. So, ma'am, patient was given an M4B and from oculoplastic reference, orbital exentration was planned and orbital exentration was done. But after 2 months of post-operative, pus was found and which came back positive for E. coli, and doxycycline was given, which cleared out, and now he is awaiting for a socket reconstruction.
Judges, you can please ask the questions.
Yeah, Dr. Ruju, did you go for a ENT consultation simultaneous with our ocular management?
Yes, ma'am. Surgical as well as medical management was hand in hand with ophthalm and ENT surgeons.
Okay, and no issues of you didn't suspect anything before the MRI was done. You didn't suspect for mucormycosis or something related before the MRI was done.
Yes, ma'am. We were suspecting mucormycosis because patient had history of COVID and was also given injectable steroids during his COVID stay, and also he had developed uncontrolled sugar levels during COVID. So we were suspecting mucormycosis from the beginning. As per patient also presented with the findings which were pointing out towards mucormycosis.
Okay, any black eschar or something in the hard palate or in the turbinates that you noticed?
No, ma'am. Luckily, the hard palate or hard palate wasn't involved, but the there was a potential spread. There was a spread to retroorbital space, and also we were suspecting direct intracranial spread. So we went for exentration as soon as the patient was diagnosed.
But you said there was involvement of all the sinuses, right?
Yes,
so, actually, no, in most of the cases where you have the involvement of the sinuses, especially the maxillary sinus, you tend to have those black patches in the turbinates. So you have to be very particular. That could have given a clue even before the MRI, you know, where the ENT people was looking to the hard palate and to the turbinates, because they will give a definitive clue that, yes, this is a case of mucormycosis. Otherwise, management point, it was life-saving for the patient, maybe that was good. Okay.
Yes, thank you.
Debridement of the sinuses was also done along with exentration?
Yes, ma'am. Along with exentration, we cleared out as much as tissue was possible. Necrotic tissue, we cleared out everything.
That was done by ENT people?
Yes, that went hand in hand. ENT surgeon and oculoplastic surgeon both were present during the surgery, and it went hand in hand.
Okay.
Thank you, Dr. Ruju.
Thank you.
Our next speaker is Dr. Isha Gandhi. She is from Government Medical College, Baroda, and her mentor is Dr. Indravardhan Vasava, and she will be presenting on a ptosis.
Hello, am I audible?
Yes, you can start.
Okay, myself, Dr. Isha Gandhi. I am presenting a case of congenital ptosis with a jaw winking phenomenon. I have taken a consent from patient and her parents for using photographs for education purpose. A 12-year-old girl presented to the ophthalmology OPD with chief complaint of drooping of left eye upper lid since birth. Onset duration progression, as told by patient's parents, they noticed her daughter's drooping of left eyelid since birth. The ptosis does not seem to increase in severity over time and with increased age. They noticed eyelid opens wider and appears to wink when jaw is moved, like in chewing and in clenching movement of the jaw. Their past history, personal history, and family history was not significant. In examination finding, patient was well built, well nourished, conscious, and well oriented to time, place, and person. All vitals were stable. External examination, patient's gait was normal. Head posture, in head posture, chin elevation is noted. No other obvious facial asymmetry or physical deformity found. In ocular examination, vision in right eye and in left eye was 6/6. Eyebrows are in normal position. Eyelids in right eye it is normal position, and in left eye moderate ptosis was found. In anterior segment in both eye within normal limits. Pupil in both eye round, regular, in brisk reaction to light. Eyeball movements were full in all 9 directions. In ptosis examination, corneal sensation was present in both eye. Bell's phenomenon was also present in both eye. Upper lid crease was normal in right eye, and in left eye it was shallow. Palpebral fissure width in right eye it was 10 mm and left eye it was 6 mm. Marginal reflex distance 1 in right eye was 4 mm and in left eye -2 mm. Marginal reflex distance 2 in right eye was 4 mm and in left eye it was 3 mm. Marginal crease distance was in right eye 10 mm and in left eye also 10 mm. Levator palpebral superioris function in right eye it was more than 10 mm and in left eye it was 8 mm. Lid leg sign was absent in right eye and it was present in left eye. Jaw winking was present in absent in right eye and present in left eye. Here's a photograph where patient opening her mouth, her ptosis improvement was seen. This is a video. Which was showing as the movement of jaw occurs, there is an improvement in ptosis occurs. My probable diagnosis was unilateral left eye congenital moderate ptosis with jaw winking phenomenon. Thank you. Ma'am, we have counseled the patient and her parents about the surgery, but patient was little hesitant about the surgery. So next follow, we are taking follow-up for the patient for convince for the surgery.
Okay.
What so you sorry.
Remember, I was asking about questions.
Dr. Radhika, you ask.
Yeah. What surgery are you planning for her? For the jaw
we were planning a frontal LPS resections followed by frontal sling surgery for this patient.
Okay. And what about the jaw winking phenomenon? What are about the disinsertion of the nerve?
If there is a aberration nerve innervation in between pterygoid muscle and LPS muscle. So if the jaw winking is minimal, it can be negligible. But if it was more significant, surgery was done. We could plan for a surgery, LPS resection followed by sling surgery.
Yeah, because it will not improve unless and until you tackle the nerve. Just do ptosis surgery.
So, yeah. But so we can resect the LPS muscle as we cannot do with the nerve aberration. So we are resecting the LPS muscle, so its function was unable. So we can frontal sling surgery can be done.
Dr. Isha, did you comment about the tear meniscus in the examination? I don't think so.
No, I didn't, but it was normal. There was no significant dry eye noticed in both eyes.
But along with the corneal sensations and everything, you should be mentioning about the tear meniscus also, because in such patients, you may see severe dry eye also, up to severe dry eye also.
Yes, ma'am.
Yeah. Thank you.
Rajinder ma'am?
No, that's all. No question from my side.
Then we move on to next resident, Dr. Nitisha Khare. She is from MNJ Western Regional Institute of Ophthalmology, and her mentor is Dr. Aveja Kathiara, and she will be speaking about canaliculatis.
Good afternoon, everyone. I am Dr. Nitisha Khare, second year resident at MNJ Institute of Ophthalmology, and I'll be presenting a case of canaliculatis under the guidance of Dr. Aveja ma'am. A 54-year female patient presented at a tertiary center with chief complaints of watering, redness, and discharge from right eye since 10 months. The patient had previously consulted at some private hospital for the same and was diagnosed as right eye viral conjunctivitis. The patient had been prescribed with right eye ganciclovir eye ointment 0.15% 5 times a day and ofloxacin dexamethasone eye drops 5 times a day for the same. Patient then came to a hospital for further management as the symptoms were not relieved with this treatment. She had no history of foreign body, trauma, or any previous eye surgery, and patient is a known case of diabetes, mellitus, and hypertension under management for the same since last 5 years. On her examination, right eye, she showed an unaided vision of 6/18 and a best corrected vision of 6/6. There was mucopurulent discharge present in the right eye. There was a localized swelling over lower lid margins medially, and she was Roplas negative. Patient showed conjunctival congestion. The anterior chamber was normal in depth and it showed no AC reaction. And she had early cataractus changes in both eyes. On left eye, the anterior segment was normal and the patient was Roplas negative. This is an image of the patient. As you can see, there is a medial canthus. There's a swelling present near the medial canthus or the lower lids. She had mild conjunctival congestion and mucopurulent discharge present. Patient was initially diagnosed as right eye dacryocystitis, and she was started on dry hot fermentation 4 times a day, moxifloxacin eye drops 4 times a day, and CMC eye drops 4 times a day, and on a course of tablet augmentin 625 milligram thrice a day for 1 week, and was called for follow-up. On follow-up, the patient's symptoms were only mildly relieved, and she was then referred to us. She came again with mucopurulent discharge over medial canthus. She was Roplas negative. She showed a localized swelling at the region of lower canaliculus and showed conjunctival congestion. The examination gave an impression of right eye lower canaliculitis. On performing sac syringing in right eye through both puncta, it was suggestive of a patent lacrimal passage. Sulfur granule-like discharge was expressed from the lower puncta, which was then sent to a lab for microbiological examination. This is the microbiological examination. It showed gram staining suggestive of thin, fragmented, gram-positive bacilli, which resembled those of actinomycetes. As you can see, some gram-positive bacilli are present here. This one. This confirmed the diagnosis of right eye lower canaliculitis caused by actinomycetes. Patient was then started on right eye dry hot fermentation and moxifloxacin eye drops 4 times a day. She then underwent right lower canalicular cut down and curettage, and post-operatively, patient is doing well and is relieved of her symptoms. Canaliculitis is an infection of the lacrimal canaliculus, which could be caused by bacteria, fungi, or viruses. The most common agent reported being actinomycetes. It is a relatively rare disease, and as a result of which, it is somewhat hard to diagnose and eradicate. Patients with canaliculitis typically present with epiphora, punctal discharge, and pouting punctum. However, they often masquerade as dacryocystitis, conjunctivitis, or chalazion, leading to unnecessary manipulations and delay in the treatment. Actinomycetes are filamentous gram-positive bacilli, and the infection is characterized by formation of multiple sinus tracts that discharge sulfur granules, as you can see in this picture. Conservative management includes dry hot fermentation, topical or systemic antibiotics, and intracanalicular antibiotic irrigation, but it is often inadequate, and expression of sulfur granules and canalicular content is the key to curing canaliculitis. Different surgical techniques involve canaliculotomy and canalicular curettage, where an incision is made through the conjunctival approach parallel to the dilated canaliculus, and evacuation of the concretions and sulfur granules within the canaliculus is performed. And in more advanced cases, canaliculoplasty with stent placement may be required. This canaliculitis should be appropriately diagnosed and treated to avoid recurrent inflammation and possible obstruction of the lacrimal system. Thank you.
What is your take-home message that when we should suspect canaliculitis?
Ma'am, if there is any patient who comes to us with a complaint of watering from the eye and there is a swelling present in the region of, in the lower lids around the medial canthus region, we should keep in mind that canaliculatus could be an important diagnosis because it is very commonly missed, and as a result of which the patients often are treated with some different diagnosis and they are not relieved in the symptoms for a long point of time. And that can further lead to complications and obstructions in the passage.
Okay, what is the role of syringing in an acute case of canaliculitis? You have a patient coming to you. Will you go ahead with the syringing directly?
Ma'am, in the case of acute
canaliculitis, in the acute stage, patient has come with the inflamed stage. No, will you go for syringing in such a case?
Ma'am, actually, we can do antibiotic wash. Actually, antibiotic irrigation can be performed in order to reduce the infection and the bacterial load. But as such, just for the diagnosis, syringing is not often performed.
Yeah, actually, you have to be very careful while doing the syringing because there are lots of chances of false passage being created. One is that it will be very painful for the patient. You have all those inside, the granules and other debris inside.
Yes.
So it will be painful to the patient. So be very particular when you are doing syringing, and there is every tendency of creating the false tracks because you may divert from the actual track. So you have to better to let the acute stage subside a bit.
Yes, ma'am.
Okay, thank you. Dr. Ravija.
Okay. So we'll go on to the next presentation. The next presentation is by Dr. Sania. She is a resident from MNJ Institute of Ophthalmology. Her mentor is Dr. Niharika Shah and Dr. Jignasha. She is presenting a case of compressive optic neuropathy due to ono cells hypertrophy. You can start sharing your presentation.
Good morning, everyone. Am I audible? Hello.
Yes, you are audible, but your screen is still not. Okay, done.
Good morning, everyone. Myself, Dr. Sania Bulwani, and I am presenting a case on compressive optic neuropathy secondary to hypertrophy of ono cells. I'm a second-year resident in MNJ Institute of Ophthalmology. My guiding faculty being Dr. Niharika Shah and Dr. Jignasha Makhana. So I'm presenting a case of a 23-year-old male patient residing in Aurora, Ahmedabad, who is a student.
Make it as a slideshow.
Okay, ma'am. Is it okay, ma'am?
Yes, yes.
Hello.
Yes, yes, yes.
Yeah. So he presented with chief kind of diminution of vision since 1.5 months, which was sudden, painless, and progressive in nature. Patient had a history of viral fever associated with cough and cold. Yes, cough and cold since 2 months back, following which symptoms started, for which no treatment and medications were taken. Patient had no ocular complaints in his left eye. There was no significant history of headache, convulsion, or any other neurological manifestation. In ocular eye movement, and there was no past significant medical history, and he was not in any regular medication. The negative patient got tested for COVID, which was negative in rapid test, and his social history was unremarkable. Patient not being a smoker or had any addiction. Patient ocular history was also normal, not wearing any glasses, ocular trauma, foreign body, and he didn't underwent any ocular surgeries in the past. There was no illness, that is diabetes, hypertension, asthma, TB, cardiovascular disease, thyroid, hyperlipidemia, autoimmune condition, or tuberculosis. There was no significant family history. General examination, patient was conscious, cooperative, well-bit, and well-oriented to time, place, and person. On ophthalmic examination, we can see the visual acuity of the right eye was counting finger.
I think slides are not moving.
I think she has got logged off.
Sania, are you there?
Hello.
Yes.
Am I audible and visible?
You are audible, but screen is not yet. You are audible, but yeah, okay, fine.
Yeah, okay. So yeah, right eye iris pupil reaction was RAPD grade 1, and left eye was normal shade. Extraocular movements being less, anti-segment was within normal limit. Yes, Pachymetry was done. Right eye was 549 mm, left eye 550. In intraocular pressure, right eye was 14 and left eye was 16. Color vision chart was done. Right eye was not visible because of the
Your voice is not clear. Sanya?
disc which is very much visible in this photograph.
I think we can.
Hello.
Yes.
Hello.
Yes, yes.
Yes, ma'am.
There is some issue in your network. You can
Yes,
again
ma'am.
restart.
Yes, ma'am. So in right eye fundus, we can see there's a temporal disc
I cannot see your screen.
Hello.
Yes, yes.
Yes.
Now it's visible.
Yes, ma'am. So in the right eye, we can see there's a temporal disc pallor with well-defined margin. Cup margins were obscured. There was tortuous blood vessels seen, and there was absence of intraretinal hemorrhage and macular edema. Left eye fundus was normal, that is 0.3 CDR with normal blood vessels and background. On intraocular examination, indirect ophthalmic examination was done to rule out any peripheral pathology, and we can see there's no peripheral pathology seen. And then on the basis of the findings as well as the fundus findings, we advised the patient to undergo MRI brain with orbit to rule out any intracranial pathology. But to our surprise, there was no intracranial pathology, but we can see a right-sided onody cells present, which was of the measure, which was measuring 10 into 8 millimeter, and it was causing optic nerve compression, and optic nerve got narrowed to a caliber of 4 millimeter, which we can see in this view. And there was no any other intracranial or extraocular muscle pathology seen. In the coronal view, we can see again there was a presence of onody cells, which is in a close approximation to the optic nerve, and which is very commonly missed out in many patients because it's a very rare pathology. It is seen only in 39% of population. So our provisional diagnosis came up to right-sided compressive optic neuropathy due to hypertrophy of onody cells. Patient was then referred immediately to the ENT department for further management, where he underwent right optic nerve decompression surgery within 48 hours, that is functional endoscopic sinus surgery, where onody cells were visualized and broken through transnasal functional endoscopic sinus surgery. You can see the presence of onody cells and optic nerve relation. This was taken from internet. On prognosis, patient was under observation and injectable antibiotics and ceftriaxone 1 gram 12 hourly, and symptomatic treatment was given for 5 days. On follow-up examination after a week, patient right eye best corrected vision got improved to counting finger 2 meter, not improving with pinhole, and there was a reversal of RAPD seen. On follow-up examination of 3rd week post-operative, patient right eye best corrected vision then got improved to counting finger 6 meter. And now patient is under observation every 15 days to look for any sudden worsening or any kind of improvement.
The time is up.
Yes, ma'am. So my conclusion being that early diagnosis and treatment is the key for vision salvage in compressive optic neuropathy. And according to the literature, compressive optic neuropathy should be managed within 24 hours of the onset of symptoms. Delayed management can lead to poor visual prognosis. Thank you.
Any questions?
That was a very good presentation, Dr. Sania.
Thank you, ma'am.
On the MRI, do you see the lobules?
Actually, ma'am, we were actually suspecting an intracranial pathology, so we had advised an MRI. But ideally, to see any sinuses or any kind of onody cells like present, we have to go for non-contrast CT scan. But earlier we were misinterpreting, but to our surprise, again, as I said, we got to know that there was a onody cells, but patient was not affording, so we could not go for NCCT again.
Okay. So detailed view is not available.
Yes, ma'am.
Sanya, you can stop your screen share.
The recovery was partial only?
Yes, ma'am. Actually, it's been only 3 weeks since the patient got operated. So we are taking a daily follow-up.
And what medication?
Follow-up.
What medication is he on?
No, ma'am. Right now, he is not on any in systemic medication. He's just on any symptomatic. If he's pain complaints, we'll take any pain relieving agent. But right now, he's not any.
He will not put on steroids or anything like that?
No, ma'am. Actually, we were in talks with ENT department about the same, but they suggested right now it is not such. If there is a worsening or if patient complains of any other, then we would put him on steroids. Him being a young male patient, they thought it's not ideal.
Ravija, you have to unmute.
So we have to move on to our next presenter. She's Dr. Trushna Desai from Mimer, Surat. Her mentor is Dr. Manisha Patel. She's presenting a case on proptosis. Dr. Trushna?
Yes, ma'am, I'm right here.
You can go to the slide. Okay, fine.
Good afternoon, everybody. I'll be presenting a case on proptosis under the guidance of Dr. Manisha Patel, HOD and professor of the ophthalmology department. Patient, 21-year-old male, Hindu male, residing at Kadodra, Surat, working as a daily wage worker, coming from a low socioeconomic status, came to the OPD with a chief complaint of protrusion of right eye since a year and dimness of vision in the right eye since 6 months. The history of the present illness, my patient was relatively asymptomatic before a year. Later patient had a history of road traffic accident and had taken treatment at the hospital at some private hospital for the same, for which no record is available. Followed which patient had a small swelling inferomedially to the right eyebrow, which increased in size and which was followed by gradual in onset and progressive protrusion of the eyeball. The protrusion would increase by the end of the day or while bending. The protrusion of the right eye was also accompanied with dimness of vision gradually over 7 to 8 months, which was associated with redness and watering, and there was no history of diplopia, pain, or headache. Past history, the only significant history, we found out that the patient had a history of RTA, road traffic accident a year ago. There was no history of thyroid or any orbital surgeries. Personal history, there's no addiction, normal bowel bladder movements, and had mixed diet with adequate appetite and sleep. Family history is not significant. No significant family history present or any similar complaints. General examination showed that the patient was conscious, cooperative, and well-oriented to time, place, and person, and was vitally stable as well at the time of presentation. There was no sign of pallor, clubbing, sinuses, icterus, pedal edema, or any lymphadenopathy. Ocular examination showed that right eye visual acuity was 6/36 and improving to pinhole with 6/24. Left eye 6/6 vision and pinhole 6/6. On inspection, there was no head tilt. Forehead was absolutely normal. Face, so it showed asymmetry. Orbital margins, there was a small swelling near the medial side. Left side was normal. Eyebrows, eyelashes was normal in both the eyes. Eyelids showed scleral show on the right side and it was normal on the left side. Eyeball. Right side on inspection, there was axial proptosis which increased on bending. Ocular movements on monoocular testing, abduction was restricted on the right side, and on binocular testing, there was dextroversion that was restricted. Palpation, retropulsion test showed that it was resistant to retropulsion and it was a non-compressible. Thrill was palpable. Orbital margins were irregular on the medial aspect, showing swelling over the supramiddle right orbital margin. There were no palpable lymph nodes or any anesthesia or paresthesia around the right orbital margins or lids. On auscultation, bruit was present, and on transillumination, it was negative. Exophthalmometry using plastic ruler measured 28 mm, which increased to 4 mm after bending forward. This is the ocular movement showing that there is abduction restricted in the right eye. Left eye was absolutely, anterior segment was absolutely normal, and it was confirmed on the slit lamp as well. The exophthalmometry of the left eye was 16 mm, which did not increase with Valsalva or cuffing or any other methods. Conjunctiva showed right eye dilated tortuous blood vessels on the medial and the temporal aspect, as you can see on in the picture. Left eye was completely normal. Cornea was clear in both the eyes. Sclera normal in both the eyes. Pupil showed RAPD in the right eye, grade 2. Left eye was normal and reactive to light. Lens was clear in both the eyes. Intraocular pressure was measured with the NCT, non-contact tonometry, and it showed 25 mm Hg. In right and left, it was 70. Dilated fundus examination on slit lamp biomicroscopy, it showed that the right eye had mild disc pallor with vascular tortuosity in the blood vessels.
Left 4 minutes are over. You can summarize.
Yes. On B scan, we found that there would be a possibility of traumatic AV fistula, and MRI brain and orbits was done, which showed that superior ophthalmic vein dilatation as seen over here, because the cavernous sinus was prominent on the MRI. Therefore, we suspect that patient had pulsatile proptosis due to formation of cavertico-cavernous fistula secondary to the trauma, and mild disc pallor in the right eye secondary to the trauma. The patient was advised digital subtraction angiography followed by embolization. Thank you.
Questions? Radhika ma'am.
What is history of the trauma history?
Ma'am, patient had a history of a road traffic accident a year ago.
Okay. Okay, ma'am. Radhika ma'am, you can ask.
Sorry. How did you see the pulsatile proptosis on clinical examination?
Ma'am, I did the 2-finger test on the closed upper eyelid, and there was a movement of both the fingers. So yeah, it was a true pulsatile proptosis.
Is there any better method you can utilize to see the pulsatile proptosis? On slit lamp?
Yeah, on ma'am. No, actually.
You can do it on applanation tonometry. You can actually see the applanation tonometer ticking.
Okay.
Okay. You can see the movement of the applanation tonometer because that pulsatile proptosis sits on the tonometer, right?
Yes, ma'am.
That is a better method,
Yes,
sure
yes,
shot
yes.
method to see a.
And how did you manage the case?
Ma'am, it is yet to be managed. Patient was advised embolization.
Okay.
Mention radiologist that is there in Swimmer itself, but patient is not really affordable, so he comes for the daily follow-up to the OPD.
Time is up.
So we move on to the next. Dr. Dhruvi Shah from GMERS Medical College. Our mentor is Dr. Deepika Singhal ma'am. She is presenting a case report of cherubism with ocular involvement.
Very good afternoon to one and all present here. I hope I am audible.
Yes,
You are. Go on.
So I'll be presenting a case on cherubism with ocular involvement, presenting in a tertiary care teaching hospital at Ahmedabad, under the guidance of my mentor, Dr. Deepika Singhal ma'am, who is the professor and head at Department of Ophthalmology at GMERS Sola. Introduction. Cherubism is a rare disorder which is characterized by progressive, painless bilateral swelling of the jaw during childhood. This fibro-osseous condition is usually self-limiting, with symptoms typically resolving during adulthood. In some cases, there is enlargement of the floor of the orbit, which results in eyeball to tip upwards and cause proptosis. The lesions of cherubism can be graded into levels indicating the involvement of mandible and or maxilla, the resorption of the roots of the teeth, and the involvement of the orbits. The diagnosis is based on a combination of clinical signs, the family history, radiographic findings which include panoramic X-rays and CT scan, biopsy, and genetic testing. The treatment usually tends to be conservative, wait and watch, with surgery reserved for the most severe cases. A 27-year-old female presented to our OPD with complaint of disfigurement of face and diminution of vision progressively increasing since 17 years. On gross examination, there was swelling over the cheek region and swelling over the and periorbital swelling. There was elevation of the eyebrows more on the left and the right. There was proptosis in both eyes, more in the right eye as compared to the left eye. The visual acuity on Snellen's examination was 6/18 in the right eye and 6/12 in the left eye. There was restriction of extraocular movements in both eyes. She was subjected to fundoscopy, which revealed a CD ratio of 0.3 with macular foveal reflex dull, multiple retinal folds, and tortuous blood vessels. She was subjected to radiological investigations, which revealed evidence of expansile spongy cystic lesions associated with ground glass haziness, seen to be involving part of the mandible, maxilla, and both orbits. The CT scan showed lesions bulging into both the orbital cavities, resulting in proptosis of left orbit and external compression of the right orbit. Discussion. Cherubism is caused by mutations in the SH3 domain binding protein gene located on chromosome 4. The protein encoded by this gene is important for bone metabolism and remodeling. Mutations of this gene usually lead to an overactive version of this protein, which alters critical signaling pathways in the cells associated with maintenance of bone tissue and certain immune system cells. The overactivity of this protein may cause inflammation in the bones of the jaw, triggering production of too many osteoclasts. Too many osteoclasts would then contribute to abnormal breakdown of bone tissue, which is replaced by cystic lesions. A combination of bone loss and inflammation leads to cyst-like growths, which are usually seen in cherubism. Cherubism is usually firstly detected in early childhood. The symptoms can spontaneously regress themselves, and the regression may occur as early as puberty or as late as the third or the fourth decade. The ophthalmic manifestations vary greatly depending on the level of involvement of the maxilla. In rare instances, the enlargement of maxilla and penetration of the stromal mass into the orbital floor can cause retraction of the lower lid, proptosis, strabismus, diplopia, displacement of the globe, with or without visual loss as a result of optic atrophy, occlusion of the retinal vein, and macular folds with scarring. Treatment. Given that cherubism is considered to be a self-limited condition that improves over time, the treatment should be tailored as per the individual's presentation and the evolution of the disease. Surgical interventions include curettage with or without bone grafting. Liposuction has also been used to recontour the jaws.
4 minutes are over. You can summarize.
Yes, ma'am. So the patient was then subjected to maxillary bone curettage performed by the maxillofacial department. And this is the clinical picture of the patient post-surgery, which shows a significant reduction in the amount of proptosis. So the take-home message is that such patients should be evaluated by an ophthalmologist at regular intervals. So ocular involvement can be detected as early as possible, and the management can be done accordingly. Thank you.
Over to the judges now. Any questions from the judges? Any comments?
Yeah, Dr. Dhruvi, I was just wondering, can it be a case of giant cell tumor of the mandible? Because you have a similar presentation and the age of the patient you said was around 20, right?
Yes, ma'am. Ma'am, that was the first differential diagnosis that came in our mind.
Yeah. How did you rule it out?
Usually, ma'am, central giant cell granulomas usually have a unilateral presentation.
Yes.
And the involvement is more of the mandible and maxilla. Like orbital involvement is seen more commonly in aggressive lesions, and that is a rare finding. And the histopathology of the specimen usually shows unilocular lesions in giant cell granuloma, whereas in case of cherubism, there is multilocular cystic appearance, more of giant cells and fibrovascular connective tissue background. So that was the histology was the key
yes. Good
point.
Yeah, because that's the only differentiation point. Otherwise, very much resembles the giant cell tumor of the mandible. The aggressive form, as you have said, it may lead to ocular involvement at times. Very well presented. Good.
Thank you, ma'am.
So now we move on to the next case. It is by Dr. Murugesa Vaghela. She is from Drashti Netralaya, Dahod. She is presenting under the guidance of Dr. Shreya Shah, madam. Her topic is proline as a splint in lid reconstruction. Dr. Murugesa, you can start sharing your screen.
Yes, ma'am. Is my screen visible to everyone?
Yes.
A very good afternoon, everyone. Myself, Dr. Murugesa Vaghela. I am a secondary DNB resident at Drashti Netralaya, Dahod. I would like to take an opportunity to show my gratitude towards my institution, Drashti Netralaya, Dahod, my mentors, Dr. Shreya Shah, Dr. Mehul Shah, and WOS for giving me this opportunity today to present a case where we use proline as a splint for lid reconstruction. Oh, ma'am, it's not moving.
You can try loading it again. Stop sharing and start sharing again.
Okay. Starting with the background, eyelids are complex structures and play an important role in protecting the globe and maintaining the integrity of the tear film with their dynamic movement. Eyelid defects are caused by trauma, burns, irradiation, post-tumor excision, and congenital colobomas. Reconstruction techniques have evolved over the time, and excellent results can now be achieved with the combination of ingenious flaps and grafts. Evaluation of the eyelid defects involve the preoperative assessment, surgical planning, size of the assessment of the size of the defect, the location, medial or lateral canthus involvement, lacrimal drainage system involvement, age of the patient, the condition of the contralateral eyelid evaluation, and mobility of the surrounding tissue. The goals that we have to look upon is anatomical integrity of the eyelid, physiological functioning, and cosmesis. Having that background, let us start a case. A 33-year-old male presented to Drashti Netralaya with complaint of having a mass over his right lower eyelid since past 1 year. On examination of his visual acuity, he showed both eyes 6.6 with intraocular pressure with 14.6 mmHg of mercury. On anti-segment examination in right eye, he showed a 3x4 centimeter painless non-mobile rough non-mobile mass with having rough margins and rolled out edges, which was gradually progressing in lower lid near the medial canthus. In left eye, the anterior segment examination was within normal limit. The posterior segment examination showed normal fundus in both the eyes. The patient was counseled then for right eye mass excision and lower lid reconstruction surgery. The preoperatively photographic documentation and video consent was obtained from the patient. The surgery was performed then under local anesthesia. Right eye mass excision was done. The tissue was sent for the histopathological examination and posterior auricular graft was harvested. Lid reconstruction surgery was done using the innovative proline splint technique. Topical antibiotic eye drops and antibiotic ointment was given for the postoperative care. The patient was again observed, examined, and photographic documentation was done for the postoperative period. Let us see the technique with the help of a video here. So this is a tumor removal technique done with the cutter in the lower eyelid of the right eye of a patient. The tumor is being cut and then the skin graft was taken from the posterior auricular surface near the master process and placed over the recipient area to cover the defect. Now the stay suture was taken to keep the graft in its place. And then a 90 proline suture with curved arm needle was passed from the medial end of the tarsal plate to the graft. And then it was passed from the through and through thickness of the graft and to give the skeletal support to the graft. Now, the lateral end of the suture was again passed from the periosteum of the bone And then again, the suture was passed again in the reverse manner from the gaff to the medial end of the tarsal plate and tied, and thus making the proline as a pulley or a splint to give the skeletal support to the graft. And then the remaining lower end of the graft was sutured with the catgut suture. So this is preoperatively showing the mass in lower eyelid. This is just before the surgery. This is immediate day post-op 1. And this is post-op picture of day after 1 month showing the sutures in situ and mass and graft doing well. This is, we followed up the patient till 6 years, and this is a recent photograph of the patient showing excellent cosmetic results with no residual defect or any kind of scar or any other complications. So to conclude my talk, I would like to say eyelid defects form one of the challenging areas of the reconstructions, and thus our best approach using an algorithm of the techniques which are based on defect size. Combination of several techniques may needed in the repair of complex eyelid reconstructions. Proline splint is an innovative technique which gives a skeletal support to the graft and gives good cosmetic results with very less incidence of post-operative complications like psychiatrical ectropion, entropion, granuloma, agophthalmos, or lead notching. The availability of tissue, technical expertise, and the specific needs of the patient have to be kept in mind, and the procedure which produces the functional improvement, the best cosmetic result, and most convenient for the surgeon should be the procedure of the choice. Thank you for your patient listening.
Over to the judges.
I would like to mention a comment for all the postgraduate students and their residents actually. When you're showing the photographs of your patients, so it is mandatory that you give a disclaimer that you have taken the permission from the patient. And even if you have taken the permission for the display of the photographs, it's very important that you blur the unnecessary areas that we don't need. Like when you're talking about, I'm not against only this case, but there were previous speakers also who had displayed the photographs. Just make a little bit of area hazy or blurred or just obscure it so that the entire undergoing cosmetic surgery, like you may end up in problem if you're showing it officially. Otherwise, it was a good presentation. And again, I repeat, this comment is not only for this speaker, it's for all the speakers actually.
Yes, ma'am, I would I would take into consideration, ma'am, but I had mentioned that we have taken the photographic and videographic consent, and since it was for the cosmetic appearance that I had to show, so since I did not blur the rest of the part. Thank you, ma'am.
Oh, so we don't need the like the nose area, the mouth area. No, we don't need the area. Just obscure it. Okay.
Yes, ma'am.
Okay.
Yes.
Otherwise, nice presentation.
Thank you, ma'am.
Rukesha, that was a very good video you showed.
Thank you, ma'am.
Can I ask you, did you go for a biopsy for this patient? Because on the clinical photograph of the pre-op case looked to be something like a basal cell.
Yes, ma'am. Yes, ma'am. Actually, ma'am, I could not retrieve the histopathological. We did the excisional biopsy and then we did for the grafting. But I could not, unfortunately, retrieve the histopathological report from the patient. But yes, ma'am, we were suspecting the basal cell carcinoma.
Basal cell. So were there any systemic affections at that time, or did he undergo any other treatment?
No, ma'am. Patient did not show any other symptoms or any other association, and patient was followed for long 6 years, and patient did do really well. This was a last photograph of his before 2 years, and he was followed for the 6 years.
Yeah, he looks pretty good at 6 years, actually.
Yes, ma'am.
So it was only localized swelling, probably, though it was
yes,
not a very sightly appearance initially, but well managed case.
Thank you so much, ma'am.
So now coming to our last presentation, it's by Dr. Shakshi Makloga. She's also from Drashti Netralaya. Her mentor is Dr. Mehul Shah. She'll be presenting a case on traumatic endophthalmitis. Dr. Pradeep, I believe, is not able to present today. So we are moving on to the last presenter. Dr. Shakshi, you can start and you can go into slideshow mode.
Audio is not coming, I think.
Dr. Sakshi, can you unmute yourself?
She's searching the slideshow thing, I think.
Dr. Sakshi, please unmute yourself if you're muted.
Your voice is not clear.
No,
Voice is breaking up, Dr. Sakshi.
Not clearly. You can rejoin.
You're audible, but your voice is breaking up. It's not clear.
Am I audible? Am I clear, ma'am, now?
Yes, you are. Please.
Good afternoon, all. I'm Dr. Sakshi Makloga from Drashti Netralaya, Dahod. My mentors are Dr. Mehul Shah and Dr. Shreya Shah. My case presentation for today is From Darkness to Light, a case of traumatic endophthalmitis with miraculous recovery from no PL to 612. Presenting a case of 7-year-old female, previously healthy female, who came to OPD with complaints of injury by thorn in left eye 6 days back and pain and abrupt loss of vision in left eye after the injury. No history of any medical treatment or any surgical treatment taken for the above complaints. On systemic examination, patient was cooperative, well oriented to time, place, and person. On ocular examination, her best corrected visual acuity for right eye was 6/6 and her anterior and posterior segment for right eye were within normal limits. On examination of left eye, best corrected visual acuity was no perception of light. There was edema in upper lid, ciliary congestion, penetrating injury mark, and corneal edema. On examination of anterior chamber, it was irregular flare 3+ and cells 2+ were present along with the organized exudates. There were posterior synechiae. Pupil was mid-dilated and non-reacting, and there was total traumatic cataract, due to which posterior segment was not visualized. Anterior segment photography for left eye was done, and sonography was done, in which there were hyperechoic shadows depicting most probably the exudates. Patient was investigated and probable diagnosis of traumatic endophthalmitis was made and aggressive measures were started. Intravitreal injection, vancomycin 1 mg in 0.1 ml and dexamethasone 0.1 ml was given under general anesthesia. Along with that, topical treatment was started, which included basifloxacin 0.6% 1 hourly, amikacin 1% 1 hourly, atropine 1% 3 times a day, and oral carbonic anhydrase inhibitors, acetazolamide 250 mg once a day. On serial follow-up on 2nd and 5th day, on examination, patient symptomatically improved. On left eye examination, perception, there was no perception of light. Anterior segment examination revealed there was decrease in lid edema and ciliary congestion, reduced cells and flare in anterior chamber to grade 1. Posterior synechiae and along with total traumatic cataract were present. This is the photograph, anterior segment photograph of 5th day post intravitreal injection. On 20th day post intravitreal injection, best corrected visual acuity of left eye was no perception of light. On examination of anterior segment, there were no cells and flare in AC. After significant reduction in infection and inflammation, patient underwent total pars plana vitrectomy and lensectomy. And she was followed on post-op day 15th of vitrectomy. Unaided visual acuity of left eye was 6/36 and best corrected was 6/36 plus 2 with a refraction of plus 12 diopters of sphere and plus 1 diopters of cylinder at 90 degree. On anterior segment examination, there were no exudates, no cells of flare. Patient was aphakic. Posterior segment examination, media was clear with the retina on. On 30th day of vitrectomy, unaided visual acuity for left eye was 6/36 and best corrected was 6/12 with refraction of plus 12 diopter sphere plus 1 diopter cylinder at 90 degree. Patient was aphakic with normal posterior segment. As significant improvement in visual acuity was obtained after refraction, patient was taken for scleral tuck IOL implantation. On third day follow-up post-scleral tuck IOL implantation, the unaided vision was 6/24 and the best corrected was 6/12 with a refraction of minus 1.5 diopters of cylinder at 140 degree. Posterior segment was within normal. This is a video showing the surgical techniques taken for the patient.
Dr. Sakshi, if you can conclude now, your 4 minutes are up.
Yes, ma'am. Conclusion, ocular trauma is a major cause of monoocular blindness, especially in rural areas. Severely traumatized eyes with no light perception carries an unfavorable diagnosis and is a common indication for enucleation. With advancement in retroretinal surgical techniques, indication for enucleation is no longer determined by post-trauma and no light perception vision alone. Immediate measures and prompt surgical intervention in patient of trauma can bring miraculous improvement in visual acuity of patient. It is time to change the proverb, better late than never to better early than late. No PL doesn't mean no hope. Thank you for patient listening.
Over to the judges now.
What was the age of the patient?
7 years, ma'am. 7 years old female.
Okay, when the patient was taken for intravitreal antibiotics, vitreous
the-
tap was done?
Sorry, ma'am?
Vitreous tap was done when the
No,
patient was
ma'am.
taken for
Due
intravitreal.
to financial restraints of the patient, we could not do the vitreous tap. That's why we had, on the basis of probable diagnosis, we have treated the patient.
But what you were suspecting at the patient has vegetative material thorn injury. So we were suspecting fungal involvement, na? When we
bacterial and fungal both, and
and what intravitreal antibiotics and steroid was given along with
yes,
that?
ma'am. Vancomycin along with the dexamethasone was given intravitreally.
Okay, then what was the cause of vitrectomy? After 20 days, the vitrectomy was done, na? After 20 days. So
Yes,
what
ma'am.
was the main cause for that?
Ma'am, we waited for the inflammation to subside, and first topical treatment and intravitreal injection was given. Then we took the patient for vitrectomy, followed by which the patient has got good results, drastic change in the visual acuity.
There is one query from the panelists that steroid injection in vegetable injury is debatable. So that was one of the concern.
And that too without the proper isolation of the organisms.
Yeah, without vitreous tap.
Without a tap. It is, you were just about lucky probably.
Yes, yes. And usually the vitrectomy is done within a week, within 3 to 7 days. So the patient was improving well. So that is good for you.
Yes, ma'am.
Any more questions or comments from the judges? Okay, so that brings us to the end of this oculoplasty and trauma session. We had some very interesting cases, and thank you, judges, for your valuable inputs. I now hand over this to Dr. Gunjan to take it further.
I'm very much thankful to Radhika ma'am, Rajvinder ma'am, and Jayashree ma'am for the wonderful inputs. We'll now move on to our next chief speaker, Dr. Sunita Dubey. She will be speaking about short-term fellowship program for women ophthalmologists. And she has done her fellowship in glaucoma at Wills Eye Hospital, Philadelphia in 2002. She has extensive experience in management of pediatric refractory secondary glaucomas and having special interest in glaucoma drainage devices and MIGS. She has extensive experience in training fellows and DNB students. She has more than 100 publications, out of which 60 are PubMed indexed, and book chapters in peer and non-peer reviewed journals. She has received several prestigious awards in AIOC, including E.T. Selvam Award, Best Paper Award in Ophthalmic Education, Epidemiology and Prevention of Blindness Selection, and Best Oral Paper Award at International Congress of Glaucoma Surgeries. She is reviewer of various prestigious peer-reviewed journals. She is member AIOS NABH National Committee for Setting Ophthalmic Standards. She is member Glaucoma Task Force, Ministry of Health and Family Welfare, India. She has been nominated as honorary professor by Indian Medical Association in August 2017, and she is treasurer of Glaucoma Society of India year 2012 and 14. And presently, ma'am is working as medical superintendent and head of glaucoma services at Dr. Shroff's Charity Eye Hospital, New Delhi. We welcome Dr. Sunita ma'am. Over to you.
Thank you, Gunjan. I'm sharing my screen. Can you see my screen?
Yes, ma'am.
Okay, so at the outset, I would like to thank Boss and Dr. Mohita for giving me this opportunity. I'll be talking on short-term fellowship opportunities for women ophthalmologists. So why fellowship? Because the ophthalmology residence programs are quite inadequate in India and focus mainly on cataract, leading to inadequate exposure to other specialties other than cataract. And therefore, the practitioners lack the required skills for diagnosis and treatment in various subspecialties, even in glaucoma, which is considered to be a comprehensive subspecialty. Also, there are no training programs available to provide customized hands-on training in various aspects of subspecialties like diagnostics or surgical trainings. Also, the current fellowship programs are primarily based on conventional teaching modalities, and they've not kept pace with modern educational advancements like digital training and distant learning programs, etc. And as a result, most of the fellowships which are available in different institutes are of long duration, wherein you can learn a lot. And however, these long-term fellowship programs may not be feasible for everyone, especially for women candidates who are trying to strike a balance between their personal and professional lives, but they definitely want to do something. So we at Shroff Charity Eye Hospital, we have collaborated with the Orbis for this particular project, which is a kind of capacity building project in the form of a digital hub, with an aim to provide a sandwich fellowship program in various subspecialties. So it's a 9-year program basically, but the first 2.5 to 3 years is for glaucoma. And it combines a series of training modalities to overcome the common barriers. So we know the barriers are the cost of fellowship, sparing time for long-term fellowships. No women at later stages can spare 2 years or 1 year leaving their job and leaving their family. And also, even if they can, they're working somewhere, there's lack of infrastructure and supportive mentoring. So leveraging tele-mentorship and CyberSight. CyberSight is an Orbis tele-education platform. This sandwich program includes innovative training techniques such as distance learning and remote surgical mentorship, wherein a woman can perform surgery sitting at her own institute, mentored by an expert from a distant institute or from the host institute, and also the hands-on surgical skill development. So it definitely will help in minimizing the amount of time spent away from a fellow's home institution and family to no more than a few months at a time instead of 2 years or 1.5 years. So this the focus of blended learning program was to make it feasible for candidates, especially women candidates who already have their setup or practice and they want to upgrade their skills in some specialty without devoting much time. So basically, we have created a digital training hub, which is very well equipped with the state-of-art medical equipment, audio-visual equipment, and the required infrastructure, which is required for the remote mentorship, surgical mentorship, wherein you can, mentor a candidate sitting in our institute and have an approach to their operation theater. So basically, Digital Training Hub combines simulation, digitization, tele-mentorship, remote surgical mentorship, and tele-education with also with traditional in-person hands-on training. And the curriculum is quite standardized and structured, and including wet lab training integrated into the curriculum and using standard international standards and tools for assessment of both knowledge and competency of ophthalmologists in training, like OSCE score, Oscar score, to make it more structured. So even a 6 months duration fellowship can be as good as a long-term fellowship of 1.5 years. So advanced wet lab facility, structured curricula for glaucoma, especially right now we have glaucoma and later on the other specialties also. And so these curriculum are developed by a team of national and international faculty and also a pool of trainers. We have fellowships and observerships, hospital-based training programs, which are called HBTs. So basically, these are surgical training programs of a short duration, say for a week or so, and continuous medical education by lectures, case presentations, log book review, etc., and educational and participatory webinars. And we have also tried to engage the medical institutions which do not have the requisite infrastructure, provide the access to residents and ophthalmologists to enroll and access wet labs for trainings, remote surgical mentorship, and e-consults in glaucoma. So this structured fellowship includes hospital-based surgical training, structured observerships of 3 months, 1 month, and 1 week course, and sandwich fellowships, which can be 1 year fellowship or 6 months fellowship. And then again, as I told previously, the webinars wherein the candidate will participate and present their cases along with the international faculty. So since they are blended fellowship, there is a defined curriculum and very structured curriculum with pre-course activity, which a candidate has to complete before joining in for the program. And it will be an e-learning thing to complete glaucoma modules on CyberSite, and because CyberSite, I'm going to discuss in a while, has all specialty fundamental courses which one can complete and get certificate. And then we also provide with the voice over PowerPoint presentation on basic diagnosis and procedures for the understanding of the candidate before the candidate join in for the course, for the physical course. And we also recommend the reading material and instructional video demonstrating the procedure for performing various diagnostic procedures, so that when the candidate comes for the actual training, he is quite well aware of the theoretical aspect and other things. And we have clear-cut objectives that at the end of the program, what participant is going to achieve. And since it's a blended thing, if it's a 6 months, we have a rotation of 2 months at base and then 2 to 3 months at their own institute. And then again, finally, they'll come back and we'll assess them how much they have learned. So wet lab is again have a very advanced infrastructure and facilities. The candidates, before going into OR or doing live surgeries, they have to first perform the surgeries on animal eyes and simulator eyes, which they help them to understand the procedure very well. And training sessions and even sessions on AI are held by the CyberSite faculty. And the webinars, as I said, they can participate with the faculty and present cases. So CyberSight, a word about CyberSight platform. It's a non-profit telemedicine initiative of the Orbis, and it helps to mitigate the shortage of skilled eye professionals and help those in remote areas combating geographical location isolation. So it has all the courses available if you just register and become a member of CyberSight, which is a free site, and you can have access to live webinars, online courses of various specialties, library, and wherein you can just go through the entire gamut of courses, and live webinars also. And then you can also register for seeking consultations, especially for artificial intelligence. So it's a global platform for improving skills and lifelong learning, and it is free of charge and mentorship learning. And you can also collaborate on diagnosis and treatment of your patients and free AI consult. And when you complete your courses, you will be awarded this certificate also. So that's all I would like to say, that whosoever wants to do short-term fellowships or observerships, it's a very structured thing and with a clear-cut objective, and wherein the candidate knows what he or she is going to learn. And in short, of course, it's a blended thing wherein you can do your, where you can continue working in your own institute and learn also the new skills, whatever you want to achieve. Thank you very much for your kind attention.
Thank you, ma'am. Thank you. It will be very much useful to the residents, because this program is for them, and even we are also finding new opportunities and new things here.
Yeah, it is not only for residents, for women like who have not done fellowship because of whatever reason earlier, and now they have their own institute, so they're working in some hospital and they want to just upgrade their skills in any specialty. So it's a good opportunity for them.
Yes, ma'am.
So can I say something, Dr.
Yes, yes.
So that's a wonderful opportunity. We wanted Dr. Sunita to share, because this is already existing, and Dr. Sunita is the treasurer of WAS, and so she's one of the most supportive mentor that you could have ever thought of. So anybody, if they have lots of times we have a lot of apprehensions, where to go, what to do, how do I take out 1.5 years, 2 years. So this fellowship which they are offering is answering all questions, which all apprehensions that you may have in your mind. So you can contact us at WAS, or you can contact Dr. Sunita, and I'm sure this will be like greatest opportunity for you all.
So we can take it forward through WAS only, and these fellowships are free of cost. Even surgical fellowships we do not charge anything for that. I think that is.
Yeah, thank you, Dr. Sunita, for giving this wonderful opportunity and this talk.
Thank you, ma'am. Now we move forward to our last session, that is about lens and retina. And to moderate this session, I'll invite Dr. Shilpi Shah and Dr. Smita there. Dr. Shilpi has 20 years of experience in ophthalmology in UK and India. She is presently a director and consultant retina specialist. I think someone is. She is director and consultant retina specialist at Eyesight Retina Center, Ahmedabad. She has done MBBS, MS, MRC, Ophthal, and Medical Retina Fellowship in UK. She has been awarded many awards, like Special Mention Award at 3rd Annual Indian ROP Society Meeting 2018, Best of the Best Scientific Paper at Gujarat State Ophthalmology Conference 2014, Best Scientific Paper at Gujarat State Ophthalmology Conference 2012, Gold Medal in Diploma in Ophthalmology, passed her MS with distinctions. She has been awarded as the Best Junior Doctor of the Year 1919 during residency. She is gold medalist for best performance in surgery exams MBBS 1997. She has also been registered with Royal College of Ophthalmologists London and various other societies. We welcome you, Dr. Shilpi. And our next moderator is Dr. Smita Dev. She has done her MS Ophthalm in 2000, and she is trained in glaucoma management from LVPI Hyderabad. She is expert in cataract and glaucoma and have been trainer for phaco and SICS surgeries. She is recipient of Night of Blind Award on Helen Keller's Day for highest number of surgeries with best outcome. From 2002 to 2007, she has done SICS phaco fellowship in Mumbai, Bangalore, glaucoma training at LVPI Hyderabad, and she worked as assistant professor at PSMC Vijayawada also. And presently she is working as a cataract and glaucoma surgeon at Ocurai Hospital. I invite Dr. Smita and Dr. Shilpi to take over this session. Over to you.
Thank you, Gunjan, for your kind words. And to start, hello, Dr. Shilpi, to be my co-moderator. I would like to introduce our judges and welcome all the participants. And I want to say all the best to each of you, and we all will be the winners in spite of whatever winners they announce for us. Okay, so we are all high in spirits, I presume. I would first like to introduce Dr. Chitra. She does not require any introduction. She is head of Vijay Retinal Services at Narayan Netralaya. She's a great leader, and having done her healthcare leadership program in Harvard Medical School, she's a PhD, and she has over 130 PubMed articles published. She has been a joint secretary of AIOS and VRSI, and she's a scientific chairperson of Karnataka Ophthalmic Society. I would like to introduce Dr. Anita. She has so many accolades on her way, and she has been a great worker in public and community ophthalmology. She conducts training in glaucoma and endophthalmitis, and she's associate professor in Regional Institute of Ophthalmology, Patna. She is associated with WHO, and she has got SD Athavale Award for the best paper and Dr. Ajit Singh Gold Medal for the best poster. Lastly, I would like to introduce Dr. Shweta. She has completed her long-term fellowship from Shankar Netralaya, Chennai, and she's a regular presenter in multiple conferences. She has been organizing secretary of National Conference of Glaucoma Society of India. Welcome, judges, and thank you so much for being on board with us, and I hope we all will enjoy this journey forward. Dr. Shilpi, can you take over from here now?
Yeah, sure. Thank you so much, Dr. Smita. So without wasting much time, we'll start with our first presenter, who is Dr. Diksha Thorat from Drashti Netralaya, Dahod. She's presenting a case of microspherophakia along with her mentor, Dr. Mehul Shah. Over to you, Dr. Diksha. Okay, can you please do the slide presentation mode?
Yeah. Yes, ma'am. Ma'am, may I start?
Yes, please.
Okay. A very good afternoon to one and all. My name is Dr. Diksha Thorat. I'd like to express my gratitude towards my institute, Drashti Netralaya, Dahod, and my mentors, Dr. Mehul Shah and Dr. Shreya Shah. The case presentation is long heights with short sights. So an 11-year-old girl came to our OPD with her father complaining of decreased vision since early childhood. The decreased vision is bilateral. Onset of the disease could not be elicited by the parents exactly, but noted more apparent decreased vision since the past 2 years. They also noted that the patient was not keen on doing outdoor activities such as playing and preferred staying indoors. The child's school academic performance was also poor. There's no significant past history. The patient is the only child born of a non-consanguineous marriage. The parents and the grandparents don't have similar complaints. On systemic examination, the patient was cooperative and oriented. The patient is tall, with long, slender arms and fingers, with arm span to height ratio of 1.1, upper segment to lower segment ratio of 0.9, thumb sign positive with high arched palate and pectus excavative. On ocular examination, the right eye best corrected visual acuity is no perception of light, and left eye is hand motion. The refraction, cycloplegic refraction revealed a -13, -2 at 70 refraction of the right eye, and -14, -1.5 at 70 of the left eye. On anterior segment examination, on an undilated examination, the anterior chamber looked shallow of both the eyes.
But on dilatation, microspherophakic clear lens was revealed in both the eyes. The IOP of the right eye was 29.7 and of the left eye was 34.4. This is the anterior segment image showing an equatorial lens margin indicating a microspherophakic lens. On posterior segment examination, the media was clear. The optic disc showed cupping with thinning and pale neuroretinal rim, and a lamellar dot sign was visible on both the fundus. The foveal reflex was normal, and the peripheral retinal vessels were within normal limits. So according to the Ghent criteria that is used for Marfan syndrome, it has to be positive for 2 major criteria or 1 major with 2 minor criteria for it to be a clinical diagnosis. So she had 1 major criteria of ectopia lentis and 2 minor of pectus excavatum, joint hypermobility, and characteristic facies of long, thin face with sunken eyes and crowded teeth. The patient was advised a pediatric reference for assessment of associated cardiac and pulmonary abnormalities, if any. Parents were explained about poor visual prognosis due to late presentation. The patient underwent lensectomy, vitrectomy after controlling IOP for the left eye, after which she was left aphakic with an extremely guarded visual prognosis. No active intervention was planned for the right eye as of now. At 2 weeks post-op, her IOP of the left eye was still 29.4 millimeters of mercury, so she was started on topical carbonic anhydrase inhibitors. A secondary scleral fixated IOL implantation was planned after controlling the intraocular inflammation and pressure. This is the anterior segment SD-OCT of the right eye, which has been left phakic, showing crowding of the angle structures, and the left eye, which is post-op day aphakic. So microspherophakia becomes apparent only on dilatation. Always suspect secondary glaucoma and microspherophakia. Look for systemic associations of microspherophakia to detect life-threatening conditions. Lensectomy and scleral fixated IOLs yield good visual outcomes when managed in time. Marfan syndrome is a rare group of connective tissue disorders which have serious ocular manifestations also. We had conducted a study at our hospital published in IGO recently, which included 86 eyes with Marfan syndrome presented to our OPD with ectopia lentis. Out of these, 5.9% had secondary glaucoma, like in the current case. Whereas a study conducted by Senthil et al. Reported a 51% prevalence of secondary glaucoma with microspherophakia. Management of secondary glaucoma in such cases is challenging, hence early diagnosis and management can prevent irreversible vision loss and augment patients' quality of life. Thank you for your patient listening.
Thank you, Dr. Diksha. That was a very nice presentation. I'd like to invite judges for the question answers.
Yeah, this is Dr. Shweta side, and thank you, Diksha. It was a very nice presentation, as already said, very widely covered the points. Only thing is that I just missed out the gonioscopic findings. If you had done gonioscopy for this case, had you done a gonioscopy for this case?
Ma'am, the child is an 11-year-old girl, and we had attempted to do a gonioscopic examination, but she did not allow us to do a proper examination.
She wouldn't have cooperated with you.
Yes, ma'am. Yes, ma'am. So that's why an anterior segment SD-OCT was done.
Okay, so one take from my side would be here that in these kind of cases, probably though the child was, as you said, that 11 years old, you could have tried a 4-mirror gonioscopy, because in that you don't have to put a gel, so it is not cumbersome for the patient as well as for you also. So because 4-mirror gives you an immediate view, within a second it will give you the view. So you can comment on the angle status as well, and that will help you decide the further management of the secondary glaucoma. As you very correctly said, that these glaucomas are really difficult to manage. Then second point, that what would be your take as a presenter, that say in your OPD, in a busy OPD, if you see a case, so first of all you see that the refractive, the minute the case sheet come in front of us, we have a tendency to look at the refractive status. So what would be the alarming finding in such kind of case, that even if you miss on to IOP, before IOP you can say that okay, this could be a case of microspherophakia. So what are the 2 clinching factors in your clinical diagnosis?
Ma'am, first of all, as you mentioned, the refraction. After performing the refraction of the right eye was -13, whereas of that of the left eye was -14. I would definitely like to examine the fundus examination for a corresponding posterior segment finding, myopic fundus. And ma'am, like I mentioned, a dilated refraction was necessary. That would be the first point. The second point would be a shallow anterior chamber, and of course the and of course the features, the external skeletal features of the patient.
Yeah, good, very good. So that's what I just wanted to focus on, that if a patient is coming, see, normally the angle closures, they do happen when the patients are hypermetropic, but this is a contradictory phase. I can say that the patient is going to be myopic along with a presentation of a shallow AC along with angle closure. So definitely, so that is why the gonioscopies are little important in these kind of cases. So any myopic case with angle closure, it raises the doubt and suspicion of microspherophakia. And as you said that the case was planned for further surgery, but yes, once you leave the case aphakic, yes, the glaucomas are little difficult to manage. So in those particular cases, you might have to plan a same setting of valve introduction in the eye, because you can give a chance to trabeculectomy as a primary surgery along with the primary surgery. But since you have left the case aphakic, then you can give a trial of, because I think you had just put the patient on carbonic anhydrase inhibitors, right?
Yes, ma'am. The patient is actually a very recent patient, and she's still under follow-up. For now, we're waiting for the inflammation to go down, ma'am. And later, there's a scleral fixed IOL that has been planned after reduction of the IOP. And along with that, studies have shown that there are good success results of trabeculectomy in these cases.
Yeah, that is what
there
I'm
is about
trying-
86% success rate of trabeculectomy in such cases.
Yeah, that is
So,
what I
ma'am,
was going to ask. That follow-up period will decide, and the amount of synechia formed in the angle will decide that how much your trabeculectomy is going to work. But yes, for sure, as a primary surgery, trabeculectomy can be taken as an option. Very well presented. Thank you so much.
Thank you, ma'am.
I have one question, Deeksha, to you regarding this particular case. What are the retinal findings you'll be wary of before undertaking any patient for surgery? How will you manage if you find any retinal findings?
Ma'am, since this is a case of microspherophakia with Marfan syndrome, they are more prone to getting retinal, they're more prone to having retinal detachments. So since they are also accompanied by thinning of sclera and enlarged size of the eyeball because of increased pressure, so they may also present with ophthalmos. In such cases, there may be a retinal thinning. So the peripheries of the patient have to be properly examined and looked for any degeneration, such as lattice degenerations or atrophic holes, and those have to be kept in mind.
All right, shall we move on to our next speaker then? Our next speaker is Dr. Darshvi Patel from Jeemers Hospital, Sola, Ahmedabad. She's presenting a case of Alport syndrome under the guidance of Dr. Deepika Singhal. Over to you, Dr. Darshvi Patel.
Good afternoon, ma'am. Am I audible?
Yes.
Good afternoon to everyone present. I'm presenting a case of clear lens phacoemulsification of simultaneous anterior and posterior lenticonus in Alport syndrome. My mentor is Dr. Deepika Singhal, professor and head of Department of Ophthalmology at GMERS Sola. A 22-year-old male presented to the ophthalmic outpatient department at GMERS Sola. Sorry. A 22-year-old male patient presented to the outpatient department of GMERS Sola with diminution of vision in both eyes since past 2 to 3 years. The vision in both eyes was 636 with no improvement in pill hole and no acceptance to subjective correction. He had no history of glasses. He also had bilateral hearing loss since 4 to 5 years with no other systemic complaints. Examination. Slit lamp examination showed bilateral anterior and posterior lenticonus with oil drop reflex in both eyes. Fundus examination showed perimacular fleck retinopathies in both eyes. USG abdomen and pelvis showed right renal benign degenerative cyst with normal renal function test. Pure tone audiometry showed that he had bilateral moderate sensorineural hearing loss. The slit lamp finding shows anterior lenticonus, posterior lenticonus, and the oil drop reflex. These are the fundus finding, perimacular fleck retinopathy. Management, both eyes clear lens phacoemulsification with foldable IOL implantation in posterior capsular bag was done. The post-op vision of the patient in both eyes with correction was 612 on post-op day 1. Discussion. Alport syndrome is an inherited disorder of collagen that affects the kidney, eye, and the cochlea. Approximately 80% of the patients are X-linked. About 10%, in about 10%, the transmission is autosomal recessive. The remaining 10%, there is no family history. The most significant organs affected in Alport syndrome are renal, with hematuria as the earliest sign. This may be primary presentation in this syndrome. As these patients get older, they begin to show signs of progressive kidney disease such as proteinuria and high blood pressure. The auditory presentation of bilateral symmetric hearing loss in Alports is quite significant, and most patients have hearing loss in early stages. Ocular anomalies have been reported in 9 to 82% of the patients. That they are rare in childhood, and they increase in frequency and severity with age. The types of ocular defects described mostly involve the lens, the retina, and more rarely the cornea. The most common changes are anterior lenticonus and perimacular fleck retinal. The anterior lenticonus is an abnormality in the shape of the lens. The people with anterior lenticonus may have shown progressive deterioration of vision, requiring patients to change the prescription of their glasses frequently. This condition may also lead to cataract formation. Some people with Alports have abnormal pigment of the retina called dot and fleck retinopathy, but this does not result in the vision of the patient. Recurrent corneal erosion is another eye problem that occurs in people with Alports. Conclusion. Clear lens phacoemulsification in anterior and posterior lenticonus of Alports yielded good post-operative vision without significant complication. Thank you.
Did you do any slit lamp examination for to rule out any corneal dystrophy, any endothelial dystrophy?
Yes, ma'am.
Was it normal?
Yes, ma'am. The cornea was clear.
And what problems do you expect during the cataract extraction, during the phaco, I think that you did during the cataract surgery? Any special problem that you'll pre-plan, on how to manage when you're going in for a cataract surgery in Alports?
Usually in Alport syndrome, the posterior capsule is quite weak, or there may already be present a rent. So while phacoemulsification and plus anterior capsule is also weak, so capsular excess is quite difficult and has to be done carefully. And posterior capsule being very fragile, the cataract extraction should be proceeded with caution.
Even in the rhexis, rather than starting centrally where the elevation is there, you can start the rhexis start from the periphery.
Yes.
And flats might be a good option in making for the ease of capsular rhexis.
Yes.
And you have to take history of corticosteroid use also, maybe because of the renal, that might add to the the cataract formation.
Yes.
So you should take that drug history also.
Shall we conclude the discussion here?
Just one take from my side would be here, as the speaker said, that this is going to be a continuous progressing disease. So since we are going to take care of the cataract portion by doing a excellent surgery, but yes, at each and every visit, you should pay attention over the recurrent corneal erosion part. That should always be kept in mind, and every visit, just try to stain or take a detailed history from the patient about any dry eye condition or anything like recurrent watering and redness. That will help you a lot, despite the fact that you have taken care of the cataract.
Yes, ma'am.
Right. Thank you so much.
Darshi, are you the presenter?
I'm sorry, ma'am.
Who's the presenter?
Darshi.
Is Darshi the presenter?
Yes, ma'am.
Darshi, the first and foremost thing about a presentation is we need to see the presenter. We need to connect with you. Throughout the presentation, at least I'm not able to see you. Has anybody else been able to see her? Even during discussion, I can't see you.
Yes.
So this is this option is not there when you go on stage, right? So you need to, even though it's a virtual presentation, you need to put your video on.
Yes, ma'am.
Right now, my question to you, since I'm a retina person, is in a patient with Alports, how will you prognosticate the visual outcome based on the retina?
Perimacular fleck retinopathy does not usually affect the vision, but temporal retinal thinning is also noted, and it may lead to macular hole. So we have to check the periphery of the retina in every follow-up. If they are developing retinal thinning or macular hole, then we have to treat accordingly.
What is the connection between temporal thinning and macular hole? I didn't understand that.
The thinning may progress towards the center.
No, there's nothing wherein the retinal periphery thinning can affect the macular holes. There is absolutely no connection. So probably you're talking about a retinal hole secondary to retinal thinning. Fair enough, you need to barrage these patients, but that has no connection with macular holes. Okay, so please read up that part again. Okay, thank you. That's it from me.
Thank you, ma'am.
Thank you so much. We'll move on to our next speaker, who's Dr. Lisa Patel. She's again from Jeemers Sola Hospital. She's presenting a case of ectopia lentis. Over to you, Dr. Lisa.
Good afternoon, everyone. Am I audible?
Yes, please share your slide.
Yes, ma'am.
Is it the same presenter with the second presentation?
We are both from the same college.
Okay.
Yeah, carry on.
Good afternoon, everyone. I am presenting case report of bilateral microspherophakia with ectopia lentis. My mentor is Dr. Deepika Singhal, professor and head of Department of Ophthalmology.
Dr. Lisa, you have not started your screen
No, you're
sharing.
not seeing, yeah. The presentation is not visible.
And as Dr. Chaitra mentioned, please turn your video on so it gives a better connectivity also, personal connectivity.
Is it visible, ma'am?
Yes, but go on to the slide presentation mode. Slideshow mode.
Yes, ma'am. Okay, I am Dr. Lisa Patel, presenting case report of bilateral microspherophakia with ectopia lentis. My mentor is Dr. Deepika Singhal, professor and head of Department of Ophthalmology. Introduction. Microspherophakia, as a rare congenital disease, it is characterized by small spherically shaped crystalline lens. Common complication of microspherophakia include secondary glaucoma and crystalline lens dislocation or subluxation. Microspherophakia, ectopia lentis, and glaucoma may occur as an isolated familial condition or may be associated with variety of diseases, including Marfan syndrome, homocystinuria, Klinefelter syndrome, mandibulofacial dystosis, Alport syndrome. Most commonly, however, microspherophakia is associated with Weil-Marchesani syndrome. It is mainly characterized as follows. It is usually occurs bilaterally. Crystalline lens resembles a sphere with reduced equatorial distance and increased anterior-posterior distance. Entire lenticular equator is visible when the pupil is fully dilated. Because of the abnormal laxity of the lens similar fibers, the crystalline lens might move as the position of the body or eyeball changes. Lens dislocation or subluxation might occur. Glaucoma is common complication. Refractive stage of the eye is usually high myopia. The accommodation might be defective. A spherical lens pushes the central iris forward, leading to decreased anterior chamber depth. Case presentation. 43-year-old female patient presented to tertiary care teaching hospital with chief complaints of diminution of vision in both eyes and watering in both eyes since 7 days. Patient was asymptomatic before that. Patient denied any trauma associated with the onset of her symptoms. Patient had history of deviation of eyes since birth. There was no history of any systemic illness. On examination, vision on the right eye was 612 parts, improved with pinhole to 66 parts, and in left eye was 618 parts, not improving with pinhole. Color vision was normal. Lead cornea sclera or within normal. Anterior chamber depth was shallow superiorly in right eye and shallow inferiorly in left eye. Iris in specific right eye there was iridocorneal touch at 1 o'clock in right eye. Pupil was irregular in size, shape, and reacting to light in right eye. Nuclear cataract grading was nuclear sclerosis grade 2 in both the eyes. Microspherophakia with subluxated lens and iris pigment was present over the anterior lens capsule. Extraocular movement, alternate exotropia was present 7 to 15 degrees with the right eye dominant. Medial movements was restricted. Intraocular pressure Noted with non-contact tomometry was 10. Fundus examination, it was within normal limit. CD ratio was 0.2. Macula and periphery were okay. Epiretinal membrane present in the left eye. On gonioscopy, closed medial angle in right eye and closed superior and lateral angle in left eye. Axial length was 22.16 in right eye and 22.03 in left eye. Power was done in both the eyes and it was plus 28 in right and left eye, it was plus 27.5. Diagnosis and management. Patient was diagnosed having both eye microspherophakia with subluxated lens leading to diminution of vision. Axial length and power was a measurement of lens was done. Autorefractometry was done. In right eye, it was minus 2.5 spherical.
Please conclude.
Yes, ma'am. Yes, ma'am. It was minus 5 in cylindrical and minus 8.75, which can be concluded as high myopic in left eye. Intraocular cataract extraction was done and iris glow implantation in left eye followed by right eye after 2 weeks. This was a picture before surgery in the right eye and left eye. So microspherophakia is a bilateral disease. Small diameter lenses generally can be observed when the pupils are fully dilated and subluxation present as well. Most of the patient present to the ophthalmologist with microspherophakia with complaint of diminution of vision, but some cases can exhibit angle closure glaucoma at the initial presentation. Management of microspherophakia if the patient
Dr.
is
Lisa, you'll have to conclude.
Yes, ma'am. Yes, ma'am. For high myopic refractive correction can be done. Intermittent pupillary block, we can do peripheral iridotomy. Angle closure glaucoma, we can give cycloplegics, and iridotomy trabeculectomy can be done. And lens subluxation on dislocation, we can put scleral fixated IOL, anterior chamber IOL, or iris glow as we have done in this patient. Thank you, ma'am.
Right. Over to judges, please, for any questions.
Yeah, Lisa, it was a nice presentation.
Yes, ma'am.
Can you just tell me a condition which is known as inverse pupillary block? Because your case presentation reminds me of just refreshing it to everybody, all the your residents, colleagues. So can you tell me what is the inverse pupillary block?
Ma'am, because here the zonular fibers can be weak. If we give cycloplegics, it will dilate the pupil and tense the zonular fibers that will lead to move the lens backwards and it will increase the anterior chamber depth. But if we give pilocarpine or any constrictors that will relax the zonular fibers, the lens will move forward, AC will be shallow and IOP will be high. That leads to pupillary block. So maybe, ma'am, this.
Yes, no, not it's maybe it's
Yes.
pilocarpine induced pupillary block.
Yes, ma'am.
And you have to be cautious. Why? Because you have done the gonioscopy. I'm happy for that.
Yes,
Only
ma'am.
thing is that in the cases where you need to do a PI, you don't need to use the pilocarpine per se as a routine regular basis we
Yes.
use, because these are the eyes which are more prone for the inverse pupillary block. That's
Yes.
all from my side.
Yes. Thank you, ma'am.
Yes, in the interim period before you go in for the surgery, these points are very valuable. You know,
Yes, ma'am.
of dilators and the gonio, whether it's a position closure, whether you have a pass, that's going to help you in the interim period before you go in for the surgery.
Yes.
For the surgery part.
Okay, thank you so much.
Thank you, ma'am.
We'll move on to our next speaker, who is Dr. Zainab Dohadwala from CH Nagri Eye Hospital, Ahmedabad. She's presenting a case of diabetic retinopathy under the guidance of Dr. Tejas Desai, madam, and Dr. Ekta Shah.
Yes, ma'am. Am I audible?
Yes.
Good afternoon, everyone. I'm Dr. Zainab Dohadwala, second-year resident ophthalmology at CH Nagri Eye Hospital. My mentors are Dr. Tejas Desai and Dr. Ekta Shah. A case presentation on bilateral moderate non-proliferative diabetic retinopathy. A 69 years old Hindu female housewife belonging to middle socioeconomic status visited a tertiary eye care center with chief complaint of diminution of vision in both eyes for past 6 months. Patient was relatively asymptomatic before 6 months. Then she developed diminution of vision in right eye followed by left eye, which was gradual in onset, progressive in nature and painless. Patient had no associated ocular symptoms like redness, colored halos, or episodes of acute pain. No history of similar complaints in past, history of any ocular treatment. no major systemic condition requiring hospitalization, and nil significant family or personal history. Patient is a known case of type 2 diabetes mellitus and hypertension and is on oral medication for the same since past 10 years. I have examined my patient in adequate light and exposure. Patient is vitally stable with blood pressure of 130 by 80 mm of mercury and random blood sugar of 256 milligram per deciliter. On ocular examination, best corrected visual acuity was found to be 6 by 18 in right eye and 6 by 24 in left eye. Both eyes' anterior segment was within normal limits. Dilated slit lamp biomicroscopy examination showed both high grade 1 nuclear sclerosis with cortical spokes. Fundus examination with 90 diopter lens on slit lamp biomicroscopy examination showed both high clear media with normal shape and size disc with 0.2 cup disc ratio with centrally arising dichotomously branching tortuous blood vessels. Multiple red dot blood hemorrhages over posterior pole were seen in both eyes with few well-defined yellowish deposits suggestive of exudates in superior to macula in right eye and around macula in left eye. Few fluffy white deposits along the superior and inferior arcade were seen in both eyes suggestive of cotton wool spots, and few cystic spaces around macula suggestive of macular edema were seen in both eyes. Periphery was within normal limits as far as viewed. I have confirmed my 90 diopter findings on binocular indirect ophthalmoscopy. To grade diabetic retinopathy and to quantify macular edema, few other ocular investigations were done. This included fundus fluorescence angiography. Right eye showed, in early phase, it showed multiple pinhead hyperfluorescent spots appearing in arterial phase in parafoveal region, suggestive of microaneurysms, and blocked fluorescent area along the superior and inferior arcade, suggestive of hemorrhages. In late phase, these hyperfluorescent spots increased in size and intensity, distorting the normal foveal avascular zone in upper half, suggestive of leakage and focal macular edema. Left eye in early phase showed multiple pinhead hyperfluorescent spots appearing in arterial phase in perifoveal region, suggestive of microaneurysms. And in late phase, those hyperfluorescent spots increased in size and intensity, distorting the foveal avascular zone, overall suggestive of diffuse macular edema. Posterior segment optical coherence tomography was performed. Right eye showed cystic spaces juxtafoveally with partially maintained foveal contour, with central foveal thickness of 320 micrometer, with multiple hyperreflective foci present sub and juxtafoveally. Left eye showed large cystic spaces present sub and juxtafoveally with altered foveal contour, with central foveal thickness of 462 micrometers, with multiple hyperreflective foci present sub and juxtafoveally, with small subretinal fluid pocket present subfoveally. Blood investigations were done to check the diabetic control and evaluate other risk factors causing diabetic retinopathy and maculopathy. And this showed uncontrolled diabetes mellitus and hyperlipidemia. My diagnosis is both high immature senile cataract with grade 1 nuclear sclerosis with cortical spokes, with moderate non-proliferative diabetic retinopathy with clinically significant macular edema. Management. Patient was counseled regarding the present ocular condition as a result of uncontrolled diabetes mellitus and explained regarding the course and prognosis of the disease. Diabetic control was optimized by physician and control of other risk factors like hypertension and hyperlipidemia was done. Treatment of diabetic macular edema included both eyes intravitreal anti-vascular endothelial growth factor injection, ranibizumab, in right eye followed by left eye. On 1 week follow-up, improvement in best corrected visual acuity was noted in right eye from 6/18 to 6/12 after first intravitreal anti-VEGF injection. Monthly follow-up was given for close monitoring and to decide the further course of management.
And please put your video on for the question answers.
Yes, ma'am.
Okay, Dr. Zainab, my question to you would be that you have mentioned that your case had a early nuclear sclerosis grade 1. Yes. What do you expect in your case to happen if the diabetes is uncontrolled to the nucleus per se cataract I am talking about?
Snowflake cataract might be there in cases of long-term uncontrolled blood sugar, or posterior subcapsular cataracts are also common.
And the rapid progression of the cataract that you have to counsel your patient at the first thing, right? From my side, that's all.
Dr. Chaitra, please.
Zainab, yeah, so you showed the FFA, Zainab. What is the one thing that you'd like to see on FA that you did not mention, which will correlate with the vision acuity? which will give you an indication whether this patient is going to respond to treatment or not. What did you not mention on the angiography? Good that you've done an angiography. It gives us a lot more information than we can get clinically. So what is that one information that you can't see clinically? See, clinically you can see the edema.
Yes,
you already know when you do a slit lamp biomicroscopy that there is thickening. You also said there's CSME. On the angiography, what is the one finding that you did not mention that will help prognosticate the case?
There was no new vascularization noted on FFA or ischemic areas in peripheries.
Okay, not ischemic areas in the periphery, but you're getting close. Anything else? Since you only showed the posterior pole, what did you not mention? When you start off, these are important things that you mentioned in an angiography. If you think in those lines, right from filling time, what is the arm to retina time, what is the next thing that you see initially, then you will not forget anything. So you have to mention the FAZ, whether there was ischemia, whether there's macular ischemia or not. Those are very, very important. Peripheral ischemia, we're not looking at the peripheral retina in this case, right? We're not looking at PDR. When you're looking at a patient of NPDR, without looking at the OCT, sometimes the OCT gives you an indication. But despite getting good results on OCT, if your foveal areas ischemia is much more, the vision will not improve. Okay.
Yes, ma'am.
Yeah.
Right. Thank you so much for the important feedback. Yes.
I think Dr. Anita is trying to say something. Anita, you're muted.
I feel, that this point is being missed by residents in the era of OCT. This importance of FA, in knowing whether the macro is ischemic and what you expect and whether you, this point, they're just doing OCT and leaving the FA part. That was a very nice point, Dr. Chat. I'm happy that you emphasized it.
All right, thank you so much.
Now with Octa has come in, Dr. Anita, that has quite helped those people who can't do an angiography, or many patients who are allergic cannot undergo angio. And Octa gives us equally good information as far as the avascularity goes or the FAZ goes.
Yeah.
So that's a substitute, but FA is still there to stay.
I agree, Dr. Chaitra, but the cost still remains the issue. So many institutes will not have access to Octa. Thank you so much. Over to our next presenter, Dr. Harshida Patel, who is presenting a case of full thickness macular hole. She's from the same institute, Nagri Eye Hospital, under guidance of Dr. Tejas Desai, Madam, and Dr. Ekta Shah. Over to Dr. Harshida, and please put your video on.
Am I audible, ma'am?
Yes, you are.
You're
not visible. We can't see you, Harshida. Where are you?
Put your video on as well, Dr. Harshida. Okay, fantastic. Start.
Good afternoon. My name is Dr. Harshida Patel, second year assistant from the CH Nagri Eye Hospital, Ahmedabad. I'm presenting the case of full thickness macular hole. My mentors are Dr. Tejas Desai and Dr. Ekta Shah. 69-year-old male, Muslim retired male coming from middle socio-economic status residing at Ahmedabad. He came to us with chief complaint of diminution of vision since 8 months. Patient was relatively asymptomatic before 8 months ago. Diminution of vision in right eye, which is painless and gradual in manner. Right eye cataract extraction with posterior capsule eye implantation was done 8 years ago. There is no post-operative complication seen at that time. No history of any trauma, foreign body, eye drops, and eyeglasses seen. Patient has hypertensive since 12 years and on treatment for that, and thyroid since 3 years. There is no significant personal and family history. On ocular examination, I have examined my patient in adequate light exposure. Patient is conscious, cooperative, and well oriented to time, place, and person. The patient is well built, well nourished, and vitals are stable. On ocular examination, visual acuity in right eye is counting finger at 2.5 meter, in the left eye 6/12, and vision with pinhole is counting finger at 2 meter in right eye and left eye 6/9. Best corrected visual acuity is in right eye CF at 3, counting finger at 3 meter, in the left eye 6/9. Intraocular pressure with Goldman appellation tonometry is in right eye 13 mmHg and 15 mmHg in left eye. Anterior segment evaluation in the right eye, conjunctiva cornea sclera is normal and clear in appearance. Anterior chamber is normal in depth and pupil is round, normal reacting to light. Right eye is a pseudophakic with no posterior capsule opacity is seen. In the left eye, there is a NS nucleus sclerosis grade 3 is present. Posterior segment evolution is in the right eye media is clear, 0.4 cup disc ratio with full thickness macular hole with posterior vitreous detachment and peripheral retina seen normal. In the left eye, media is clear, 0.4 cup disc ratio and foveal reflex seen dull. On fundoscopic examination, there is in the right eye full thickness macular hole is seen. In the left eye, the foveal reflex seen dull. OCT examination was done. In the right eye, full thickness macular hole with cystic spaces and the posterior vitreous detachment is seen. In the left eye, there is incomplete posterior vitreous detachment is seen. My probable diagnosis is right eye pseudophakia with full thickness macular hole in the left eye immature cataract. For the management, we have planned for the right eye pars plana vitrectomy, internal limiting membrane pulling with fluid gas exchange with C3 gas. And macular indices, which giving the prognostic factor for the macular hole surgery. In hole form factor, where it is the if it higher and there's the post-operative visual acuity is a higher chance, good chances in there. And the macular hole indices where there is a whole height by base, if it is greater or equal to 0.5, it is better post-operative outcome in the surgery. Thank you.
Thank you, Dr. Harshida.
Yes, ma'am.
Yes, questions, please.
Yeah, Harshida, nice presentation. I have a couple of questions for you. Tell me one test that you can do in your OPD to diagnose macular hole. Not your OCT, not your scans, an OPD test that you can use. What is the name of the test? These are all basics I'm asking because I know you're a postgraduate. Tell me, please.
Walzer Anna test. Walzer Anna test.
What? Allen
Allen
test. Okay,
test.
tell me, describe the test.
We on slit lamp examination, we put the slit beam on the with 90D contact lens 90D. We put the slit beam on the macula and show if the line is beam is continue or it's broken for macular hole diagnosis.
Okay, and you spoke about surgery. You spoke about macular hole surgery with ILM peeling. Why are you advising ILM peeling in this person? How does it help?
It relieve the traction for the peripheral. It relieve the traction around the macular hole.
What kind of traction? Is it anterior-posterior traction? Because anterior-posterior traction will be relieved by doing vitrectomy. So before ILM peeling came into existence, people were just doing vitrectomy. Subsequently, they thought, let's try the next step. Of course, now there are multiple things that people do to the ILM itself. Why what kind of forces work to keep that hole open? What do you want to relieve? I spoke about anterior posterior. No, what is the other force that can be there? Something that will pull the hole apart. So the hole is pulled apart by another force. What is that force called? What are you relieving by doing an ILM peel? See, there's VMT, there's anteroposterior traction, which you will sever. So when there's tangential traction is when the macular hole is kept open. So as soon as you relieve the tangential traction around the hole and just remove the ILM, that's when the hole tends to close. Okay, that's all from my end.
Harshita, just a very basic question, not just related to macular hole, Any macular involvement to any macular patient, how do you tell your patient to self-monitor the disease progression if you have decided to wait for the time being, that how the patient is going to home monitor the thing for you?
Ma'am, we give the Amsler grid chart to patient at home for any distortion or metamorphia to as daily monitoring for the patient. We give the Amsler chart.
Yes, yes. Thank you. Nice.
Thank you so much. So much to learn, clinically all relevant. I'll pass it on to Dr. Smita Dev to introduce the next speaker.
Yeah, the next speaker is Dr. Priyanka Karadi from Government Medical College, Bhavnagar. Her mentor is Dr. S.S. Ganwit, and she's going to talk on that. So handing over to the speaker. She's going to talk on the rare presentation on treatment of ROP.
My slide is visible to everyone?
Yes.
Okay. Good afternoon, everyone. Myself, Dr. Priyanka Karadi, second year resident, Ophthalmology Department, Bhavnagar. My mentor is Dr. Chintan Sarvaiya. Today's my topic is a rare presentation seen post-treatment in ROP patients. As we know, it is a disorder of neonatal retinal vascularization in which the laser therapy is a standard treatment in type 1 ROP, which, with the many disadvantages, but the treatment effectiveness is good. In the ROP patient, we've seen that there is an increase of VEGF concentration. So we can give that bevacizumab injection, which is an anti-VEGF drug, but no consensus in the literature on the safety and efficacy, and appropriate indication was there. Bevacizumab also includes development of peripheral retinal vessel, which is continuous in nature. Whereas in conventional laser therapy, there is a permanent destruction of the peripheral retina. Come to our case, the patient presented to us at the age of 32 weeks. Patient was 28 weeks preterm with the 1500 grams low birth weight. The risk factor was respiratory distress syndrome, a history of oxygen therapy for 15 days, history of CPAP therapy for 2 days, and diagnosed as neonatal jaundice. Patient was examined by with the right cam and diagnosed as stage 2 threshold with zone 2A. At this stage, we advised patient both eye injection anti-VEGF. After follow-up of 2 weeks post anti-VEGF, the patient is progressed to stage 4A. So we decided to do both eye laser therapy. And then after laser, patient came to us after 4 weeks of laser therapy. The images show there is a regressing of the ROP stages. Then on 6th week of post laser therapy, we observed that there is a linear fibril vitreous condensation at the site of the original fibrovascular ridges, which is suggestive of partial vitreous detachment. Then again, after 12 weeks of follow-up, there is a both eye regressed ROP and also regression of partial vitreous detachment. In our patient, the same mechanism of volume effect and functional effect arising from the anti-VEGF and laser-induced shrinkage of regressed vessel was seen. So many studies previously done shows that cicatricial ROP that had undergone cryopexy or a photocoagulation had vitreous changes. Another study shows that a series of 3 patients with a delayed onset of atypical fibrous traction membrane was produced after 2.5 to 4 months after injection bevacizumab. In third study, it was seen that there is a clinical course of 5 premature infants with similar vitreous changes after a single dose of intravitreal bevacizumab. All these studies, mostly the PVD is presented at 4 to 12 weeks. In my case, the PVD presented at 8 weeks, that is somewhat earlier. We can treat this patient with bevacizumab, but there is a reduction in systemic VEGF level in adults as compared to ranibizumab. There is a damaging to the preterm infants. In ranibizumab, it penetrates deeply, so affect the choroidal circulation, which provides oxygen with developing retina. These treatments have promising results, but long-term outcomes and systemic effects are still unknown. Further studies can be done whether the anti-VEGF treatment is superior or the laser, and if so, which drug and dose are safe and effective. In these cases, we have to do timely treatment in our timely treatment. Red cam images are 2D. In patient diagnosed as stage 3 threshold, it is better to confirm with indirect ophthalmoscopy. And in case mild traction, it is better to opt to laser than injection. Patient with PVD should have a long-term follow-up as there are chances of retinal detachment, and timely reflection should be done so we can avoid amblyopia in future. And we have to counsel the patient for the same. Thank you.
This is slightly an advanced topic for postgraduate, but I would also like Dr. Shilpi to ask a question if possible, because I know she practices ROP. I have one question to you, and then I'll ask Dr. Shilpi. What are the indications for anti-VEGF in ROP? What is the absolute indication as of now for a baby with ROP as a first-line treatment?
Yes, ma'am. When we can give a patient injection when there is a threshold ROP, that is a patient is in zone 1 or 2, or there is 5 continuous clock fibrovascular proliferation, or 8 non-continuous fibrovascular changes. Then we can give to the patient which is having in stage 3 or beyond that, and on some patient of type 1 ROP with pre-threshold disease.
I'm asking you for indications when laser, when you can't do laser. See, as of now, the studies, at least in our country, show that laser is still gold standard. Because like you mentioned, with any anti-VEGF, we don't know the long-term repercussions. We don't know in these tiny babies how much is systemically absorbed. We don't know. That, of course, trials are going on. It's already mentioned in the chat that the Rainbow trial is going on. But what is an absolute indication when you see a patient that you want to give anti-VEGF and you can't do laser? I'm giving you, a clue also there. Your REDCAM has shown you that there is treatment requiring ROP. When will you give injection? And when the situation is that you can't do laser.
Oh, yes, ma'am. When the patient is in a stage 3 threshold, we can give anti-VEGF. But when it is for A stage, then it's a...
Okay, so no, that's no. Anyway, one of the main indications when you will give anti-VEGF is when there's a non-dilating pupil. When you've diagnosed the stage, it requires treatment, but the pupil does not dilate because there's some amount of vascularity. As a rescue treatment, you can go ahead first with anti-VEGF, and then as the disease comes under control, you don't stop there. You have to follow up with laser. Okay. That's also very, very important. Yes, Dr. Shilpi, anything else you'd like to add or ask?
Yes, yeah. As you said, it's a nice case, but maybe for the post-graduation level, they still don't know a lot of new things in ROP. What you were describing, Dr. Priyanka, is the treatment-warranted ROP, what we call type 1 ROP. But as ma'am was asking you, it is aggressive posterior ROP where the pupils are not non-dilating. The vessels are still in zone 1. They're not even reached probably till macula. Those are the indications where you do primary anti-VEGF treatment. And then you wait till the vessels have progressed into at least zone 2 anterior onwards when you can add with the laser. That is the appropriate way to manage these cases. Now, in your case, what happened was you said the birth weight was 1.5 kg and the gestational age was 28 weeks. So what I feel is 28 weeker would never reach 1.5 kg. In our country, many times the female doesn't know their last menstrual period date, and therefore there is a miscalculation in the gestational age. This is probably a slightly larger baby for 28 weeks. So by the time you treated the baby, you said there was threshold ROP in zone 2 anterior. Primarily you should have done laser there, because zone 2 anterior laser is the treatment of choice. And then you might have avoided this. Again, partial PVD cases are well known after anti-VEGF, and you don't just follow those cases, you follow all treated ROP cases for long term. Yes. They are your patients for life, right? Yes. So all treated ROP, whether you have injected or combined with laser, you have to follow them.
Yes.
Right? Okay.
Thank you.
Thank you.
So we'll move to the next case. The case is by Dr. Dhwani Shah from Government Medical College, Baroda. Our mentor is Dr. S.S. Ganvit, and the topic is diabetic retinopathy.
Yes, ma'am.
Yeah, Dhwani.
Am I audible, ma'am?
Yeah, you can share your slide.
Yes, ma'am. Just a second, ma'am.
Dhwani, you can put on your video as well.
Yes, ma'am. Good afternoon, ma'am. Ma'am, I'm presenting a case of diabetic retinopathy under my mentor, Dr. Shankar S. Ganvit sir, HOD and the Associate Professor. A 68-year-old male presented to our
Dhwani,
OPD with a
as your
complaint
slide
of
is not
diminished.
visible.
Just a second, ma'am.
Share screen is there. You have not opened your presentation.
Just a second, ma'am.
The screen is frozen, Dhwani. I think you should stop share screen, open your presentation, and then start. Don't start opening your presentation after share screen. Keep your presentation open. Stop share first and foremost.
Okay, ma'am.
Stop share. You're still sharing. Okay. Now open your PPT and then share screen and open. Put it on play.
Dhwani, are you able to do it?
Just a second, ma'am. It's not.
Okay, so what we can do, Dhwani, we can move to the next speaker and then you can come back. Is it okay with you?
Yes. Yes, ma'am. Yes, ma'am.
Right. So Yamini, are you around?
Yes, ma'am.
Yeah, so I invite Dr. Yamini Katala from Government Medical College, Baroda. Mentor is Dr. S.S. Ganvit, and she's going to talk about optic neuritis. So it will be a good change for us as well. Yeah, your screen is shared. You can start right away.
Good afternoon, everyone.
Go into show mode, please. Go into show mode. Do you know how to do that?
Hello.
Yeah, you need to go into slideshow mode.
Good afternoon, everyone. My topic is on the optic neuritis. A 35-year-old male with a low socioeconomic status presented with a complaint of loss of vision since 1 month, which was sudden in onset and associated with pain on eyeball movement. There was no redness, flashes, or floaters. Patient also had lower limb weakness and was unable to walk. There was no history of trauma, and there was a negative history of addiction, as well as a no significant history of past personal and family history. Treatment history: patient was relatively asymptomatic 1 month back when he suddenly developed bilateral sudden loss of vision, which was associated with pain, for which patient went to a private retinal clinic where bilateral optic neuritis was diagnosed and an MRI was ordered, which supported the diagnosis. Patient was given intravenous methylprednisolone for 5 days, and some of the blood investigations were ordered. Patient was then referred to a neurocare clinic to rule out any central cause for optic neuritis. General examination: patient was conscious, not cooperative, and not well oriented to time, place, and person. Vitals were within the normal limit. Bedside ocular examination was done, and unaided vision of both eye was hand movements, and perception of light was present, but the projection of rays were not cooperative. Patient was not cooperative for near vision as well as for color vision. Tonometry was done using a Scheidt tonometer in a supine position bedside, and it measured as 17.3 mm of Hg. On anterior segment examination, it was within the normal limit, except the pupillary reaction. The right eye has an RPD grade 1, whereas the left eye has RPD grade 3. The dilated fundus examination of both right and left eye was within the normal limit. The disc was in normal shape, size, color, with a distinct margins and a healthy neuroretinal rim, and foveal reflex was present in both the eyes. The MRI brain with orbit, which was ordered, showed the mild thickening of the anterior half of the bilateral optic nerves with subtle intrasubstance hyperintensity, and subtle perineural fat stranding is noted bilaterally. The post-contrast study reveals enhancement of bilateral optic nerve sheath with subtle enhancement of bilateral optic nerves. There was also a subtle retrobulbar fat stranding is noted in bilateral orbits. The impression of the MRI shows bilateral optic neuritis with perineuritis. An electrophysiological study was also ordered at the private clinic, where there was a bilateral median peroneal and tibial nerve was showing the prolonged latency with a low amplitude and minimally reduced conduction velocity. They came to a conclusion of primarily a demyelinating type of polyneuropathy, which was involving lower limb more than the upper. This is the fundus photo, which was ordered, and both eyes having a healthy dilated fundus, which was recorded. The blood investigations were within the normal limit. We also ordered an ANA and anti-NMO antibodies, which came out to be negative. My probable diagnosis is bilateral optic neuritis associated with demyelinating type of polyneuropathy, probably multiple sclerosis involving lower limb more than the upper limb motor neurons. For managing this patient, the initial 5 doses of IV methylprednisolone was given, which was followed by oral prednisolone at a dose of 1 mg per kg per day for 1 week, and then it was tapered. Patient was come on the follow-up after 1 month, and the visual acuity in the right eye improved from HMPL to finger counting 12 to 13 feet, and in left eye, vision improved to 9 to 10 feet. Thank you.
After how many days did the patient present? Because the visual acuity is not very good after treatment, right? It was not an acute optic neuritis, is it? They usually respond pretty well to IVMP. So how long after the onset did the patient present to you?
Ma'am, patient presented after 1 month of the onset of sudden loss of vision.
So usually
And
patients
no other previous. Go ahead, Dr. Anita.
No, please go ahead.
No, any other previous history he had a month before, because they'll have some sort of other disturbances, especially since you're saying MS was suspected in this patient. Any other neurological symptoms that he had before the onset of vision deficit?
Ma'am, the lower limb weakness also started 1 month back, and the patient started appreciating the vision loss, but he didn't report it to any clinic for the same complaint immediately. He presented late to the clinic.
Last question. You did ask for a fundus photo. Why was the fundus photo ordered? I mean, whatever you could see is already there on the fundus. What other investigation would you like to see in these sort of patients? An ophthalmic investigation, especially when you're investigating the optic nerve. Other than your radio imaging, anything that is there in your clinic can help you in diagnosing or detecting some fluid around the optic nerve.
Ma'am, an OCT can be ordered for detecting the fluid.
No. Anything else? Any neuro-ophthalmologist will also have this particular, it's a very, very common eye investigative modality.
VEP.
No. You can even see cupping when you do that test or that investigation. Very common thing. See, VEP everybody can't have in their clinic. No, this every other ophthalmologist will have. I can see Dr. Smita smiling, so I think she knows what I'm talking about. It's a simple ultrasonography. A B-scan ultrasonography will give you so much information about your optic nerve. You don't need a fundus photo, what you've advised, because whatever, at least for optic neuritis, everything is visible there, right? But when you want to confirm if there's any fluid, or the investigative modality that will actually help is your B-scan ultrasonography. Dr. Anita, please, I'm done.
Sorry. Now, just wondering whether you took any history of pain, whether the diminished vision, both eyes, was associated with any pain.
Yes, ma'am. There was a pain on eyeball movement, and majorly when the patient was elevating his eyes. So we were suspecting it was maybe a retrobulbar variety because we were not appreciating anything on the fundus.
Okay. Second thing, since you are saying probably MS, so did the patient have a MR spine also? Lower limb weakness was there. Lower limb weakness was there. So did the patient have any imaging of the spine?
No, ma'am.
Okay. So because I was asking, because in MS usually the prognosis of the optic neuritis is good. The patient, as Dr. Chatra said, the vision should have recovered. So the vision has not recovered. So basically you're dealing with something which is an atypical optic neuritis. So do you know, can you elaborate the differences between an atypical optic neuritis and a typical optic neuritis?
Yes, ma'am. In typical optic neuritis, it is typical will be unilateral, can be a bilateral. Atypical, majorly bilateral. The vision loss in the typical optic neuritis resolves majorly within 2 weeks, and the patient shows improvement.
Yeah.
Whereas
So right. So you are dealing with the atypical optic neuritis, and you are thinking in terms of MS, but MS is mostly associated with the typical. So any other investigations, any other causes of atypical optic neuritis, which is basically what you're dealing with? You also had a perineuritis in the MR. You also had a perineuritis, right? So that goes in favor of other differentials apart from MS. So I think you should go in for some more tests to rule out different causes of atypical optic neuritis. Right?
Yes, ma'am.
See, why I'm asking, you went in for NMO. You can also go in for MOG because there's a element of perineuritis in it.
Yes, ma'am.
So basically here you have to deal with the workup of a case of atypical optic neuritis. And as a resident, you also have to know what is the differential diagnosis of disc edema. You must be knowing. VP, what do you expect in an optic neuritis patient? What do you want to see in terms of latency of P100?
It will be a reduced latency in the VP.
A prolonged latency. It will be a prolonged P100 because the conduction is delayed, right? Okay, yes. Over to you, Dr. Smita.
Yeah, so is Dhwani ready? Dhwani Shah, are you ready?
Just one question while we conclude Yamini's presentation. That would be a take from my side as a glaucoma person. That Yamini, since you have said that all the optic neuritis, we all know that it's a proven fact that these cases are being treated by hordes of steroids. But do you think that you need to do any other test? That's a clinical, I should say, a office clinic test, which you should monitor your patient with when the patient is being subjected to so much of steroid. Maybe it's in the form of IVMP or an oral steroid with a continuation of a 1 month period. Yamini.
Blood investigations will keep a follow-up.
No, that's a very basic office test I'm talking about. You don't need to send the patient anywhere else. You monitor the intraocular pressure for those particular cases because some of them, they turn out to be strong steroid responders, and then the patient is from the sea to the frying pan. So you have to take care of both the things at the same time. I'm done. We can proceed to the second speaker.
Thank you.
Yeah, and just to add, I would say that perimetry can be done post-treatment also because we might get deficient centroceptal scotomas, and which would be a great evidence and help for us in the future. Okay, so get back to the speakers. Let me call Dhwani Shah to continue her presentation on diabetic retinopathy with Dr. S.S. Ganwit as her mentor. Dhwani, up to you.
Yes, ma'am. Ma'am, am I audible?
Yes.
Ma'am, I'm presenting a case of diabetic retinopathy under Dr. Ganwit sir. He is HOD and associate professor of our department. A 63-year-old male presented to our OPD with a complaint of diminution of vision in both eyes, right more than left, since 4 months. The onset was gradual, painless and progressive, and having no complaint of peripheral defects or distorted vision or any glare or contrast. He was having near vision glasses since 10 years but not wearing it regularly. There was no history of trauma or any eye surgery. The patient is a known case of type 2 diabetes mellitus since 20 years, and he was on regular medications. The family and the personal history was not significant. On examination, the vision in the right eye, unaided, was finger counting 17 feet, whereas left eye was 636. With the best corrected visual acuity, it was in the right eye 660 with plus 1.5 plus 1.5 spherical at 20 cylindrical at 20 degree, and in the left eye it was 624 with plus 1.75 cylindrical at 180 degree. The near vision was N by 36 with addition of plus 2, and left eye was N18 with addition of plus 2. The rest of the anterior segments was within the normal limit with the pupils of normal size and reacting to light, with the lens having a nuclear sclerosis of grade 2. The intraocular pressure on the Goldman's applanation tonometer was 16 mm of Hg in the right eye and 14 mm Hg in the left eye. This is a fundus photo of the right image, and it shows the media of nuclear sclerosis grade 2 with the disc of normal size and sharp margins with the cup disc ratio of 0.3-0.4 with a very healthy neuroretinal rim. The vessels shows the arterial attenuation of arterial attenuation with a ratio of 1:3. The periphery shows a tessellated fundus with the dot blood hemorrhages and the hard exudates around the macula, and the soft exudates in the inferotemporal quadrant, with the macula having a dull foveal reflex with hard exudates over the macula. The fundus image of the left eye, here it shows the media of NS grade 2, and the optic disc is having a cup disc ratio of 0.3-0.4 with sharp margins and a healthy neuroretinal rim with arterial attenuation of 1:3. The macula shows a dull foveal reflex with the hard exudates around the macula and the dot blood hemorrhages around the macula. And there are soft exudates seen in the inferotemporal, inferonasal, and the superiotemporal quadrant. Investigations were all within the normal limit, apart from the HbA1c levels, which was elevated at 7.1%. Even the lipid profile of the patient was within the normal limits. The OCT of the patient shows the accumulation of the fluid in the subretinal space, suggesting of the macular edema in right eye, as well as in the left eye it shows the accumulation of the fluid, suggesting of the macular edema. My provisional diagnosis is bilateral moderate NPDR with macular edema in type 2 diabetes mellitus with the nuclear sclerosis of grade 2. Ma'am, for the management of this patient, the patient was kept on regular oral medications by the physician side, and from the ocular side, we asked the patient to have a regular follow-up to look for the worsening of the retinopathy, and was prescribed with the NSAID drops, and patient was called for the follow-up to plan for the anti-VEGF injections, but unfortunately the patient didn't turn up. Thank you, ma'am.
Can you go back to your OCT, please? Just show me your OCT. Yeah, what sort of OCT is this?
And this is a RNFL pattern of the posterior segment of the.
Which? Okay. No, this is not RNFL, first of all. What is the type of OCT this is? Do you have many types of OCTs? No? Okay, if you don't know that, just describe where the OCT to me again. What all do you see on the OCT?
Ma'am, it shows the fluid is seen in the subretinal fluid and the detachment of the posterior pigment epithelium, suggesting of some
No. Sorry, that's the first thing that's wrong there. This is a neurosensory detachment. If the pigment epithelium detaches, it is called as a PED or a pigment epithelial detachment. That is not a finding in diabetic retinopathy. So here there is a neurosensory detachment. Okay, you should know which plane the fluid is in. Okay, so this is also subfoveal fluid, which means obviously the patient is quite symptomatic and it's a treatment requiring. It's not a small pocket of fluid, it's quite a large pocket of fluid, right? And other than the fluid, what other findings do you see?
Ma'am, apart from that, I can see the hyperfluorescence spots which are seen, suggesting of some hard exudates or detrusants.
All hyperreflexive spaces are hard exudates? What else can present?
Ma'am, it can be choroidal neovascularizations, or it could be detrusants.
No, actually you're going away from the thing. It's okay. There's also something called as hyperreflective dots of foci, which are basically a sign of inflammation. Okay. So it does not mean basically the size of the hyperreflectivity also matters. When they're very large, they go more in favor of hard X-rays. And why are these prognosticating factors? When you see hard X-rays, in what region will you say it's low prognostic? They may not improve.
Sorry, ma'am, can you just repeat the question again?
Okay, tell me the other findings. You're very distracted, Dhwani. Please tell me what are the other findings that you're seeing in the OCT. You saw subretinal fluid or a new? Yeah, tell me.
Ma'am, apart from the fluid, I can see the intraretinal some cystic findings also in the intraretinal layers.
Okay. You mentioned that this patient you have planned to give anti-VEGF. Fair enough. What are your other options and why?
Ma'am, we can go for the laser treatment, but ma'am, once the edema gets resolved, we'll wait for that, and after that we can plan for the laser for this patient.
Okay, why don't you want to do laser right away?
Ma'am, because it can just aggravate the edema, which is already patient suffering from having less vision.
Not really, because initially the only treatment option available was laser for us. The reason why you won't do laser right now, because the edema is so much. For the laser to take effect, you need higher energy. Collateral damage tends to be more. So the idea here is to bring down the edema with pharmacotherapy and then give laser, which will be more effective and less harmful. I'm asking you, what is your alternative pharmacotherapy now? Very specific question. Other than anti-VEGF, what else can you give this patient and why? If you don't know, I mean, that's it from my end.
So I have got a question. Dr. Chetra ma'am, are you done? Okay. So a question from my side to Dhwani would be that since your patient is having macular edema and the patient says, suppose the patient develops glaucoma, and definitely the patient will develop glaucoma since it is going to be an uncontrolled case if you have lost the patient to follow up. What is going to be your first drug of choice for the glaucoma, and what is the drug which you are not going to use in a case of macular edema of diabetic retinopathy? The first drug of choice which you are supposed to use, and the other drug which is totally contraindicated in this case.
Ma'am, drug of choice could be brimonidine.
Why brimonidine?
Ma'am, because it's neuroprotective.
But anyway, the ONH is not at risk here. Okay, then next, which is the drug which is contraindicated? It's PG analog, prostaglandin analog.
Beta block,
Barrier. So already the process is going on, so you don't want to increase further breakage of that barrier. So the PG analog is avoided. And since your patient is a non-hypertensive patient, am I right? Is he a non?
Yes, ma'am.
Okay. So then the first drug of choice is going to be a beta blocker, because always it causes the maximum reduction of IOP, and your ONH is not threatened here right now. Though I know that the microvasculature is compromised, but it is not to that level that the health or the vascular status of that ONH is going to get compromised. So brimonidine is not going to be the first drug of choice. And always, whenever you're writing or thinking of brimonidine in mind, there are certain other features which you need to keep in mind. So right now, the first drug of choice will be a beta blocker, and the drug which is totally contraindicated in a case of macular edema, diabetic retinopathy would be PG analog from my side. I am done. A nice presentation.
Okay, now we'll move on. Judge's permission to move on?
Yeah, sure.
Yeah, so I invite Dr. Afsha Rathod from Government Medical College, Baroda. Her mentor is Dr. Stuti Juneja, and she's going to speak of anemic retinopathy.
Am I audible, ma'am?
Yes, Dr. Afsha, start.
Myself, Dr. Afsha Rathod. I am presenting a case of anemic retinopathy. 17-year-old female residing at Vadodara with loss of low socioeconomic status presented to ophthalmology department on the 28th of January with the complaint of the gradual, painless, marked diminution of vision in both eyes since 15 days. There is no history of trauma. Past history, patient was diagnosed as a case of megaloblastic anemia 1 month back. Personal history, patient was vegetarian by diet and her menstrual cycle is normal. There is no significant family history. Treatment history, patient was admitted in the medicine ward at SSU Hospital, Vadodara on the 7th of January with the complaint of the fatigue, weakness and dizziness, for which there is a blood transfusion. 4 units of the red cell concentrate was given and the patient was discharged on 11th of January 2020. On general examination, patient is conscious, cooperative and well-oriented to time-based person. Her vitals are within normal limit. On general examination, there is pallor was present and there is no cyanosis, clubbing and lymphadenopathy. On ocular examination, vision in right eye is 6/18 and in left eye there is a 6/24. Entire segment examination are within normal limit. Her pupil reaction is round, regular and reacting to the light. Her intraocular pressure was measured by in a supine position in the morning by short stonometer. There was 17.3 mmHg. On the fundus examination, showed the clear media with the disc is normal in size and shape with mild temporal pallor when margins are well defined with the healthy neuroretinal rim with the CD ratio of 0.3:1. There is a marked dilatation of vein and the tortuosity of vessels seen. In the right eye, there is in periphery, there is a road spot temporal to the macula seen, or in the left eye, there is a intraretinal hemorrhage supratemporal to the disc seen. Over the macula, there is a large subhyaloid hemorrhage present. This is a fundus picture of the patient in which the right eye, there is a road spot temporal to the macula and the subhyaloid hemorrhage over the macula. And in the left eye, there is an intraretinal hemorrhage supratemporal to the disc and the subhyaloid hemorrhage seen over the macular area. Patient investigation, patient came with his hematogram in which on the 7th of January, her hemoglobin was 1.8 gram per deciliter. Her WBC are the 4,200 per cubic mm and her platelet was 60,000 per cubic mm. On the 10th of January, her hemoglobin level was 8.8 gram per deciliter and the WBC are the 5,200 per cubic mm and the platelet was 10,000. My provisional diagnosis is the bilateral anemic retinopathy with subhyaloid hemorrhage and the rod spot in 17-year-old female diagnosed as a case of megaloblastic anemia with history of the blood transfusion. From our side, patient was explained for the head elevation and the tablet vitamin C thrice a day given. For the anemia, the major treatment was given from the medicine side, injection optineurin tablet, multivitamin tablet, iron and folic acid given. Patient advised for the follow-up. Patient came follow-up after 1 month and her vision improved the 6/9 in the both eye. We do fundus examination, show the reduce the size in the subhyaloid hemorrhage. We counsel the patient about the fundus photograph, but patient not cough. Thank you.
Go back to your fundus findings, please. That fundus image that you put.
Yes.
Yes. So you were describing the left eye finding. Can you describe that again?
In the left eye, there is a media is clear with the disc is normal size and shape with mild temporal pallor with a healthy neuroretinal rim and the well-defined margin. In there is a intraretinal hemorrhage supratemporal to the disc and subhyaloid hemorrhage seen over the macular area.
Okay, but that one part of it may be probably intraretinal, but the whole hemorrhage that's along the superior-temporal arcade doesn't look intraretinal. The intraretinal hemorrhages are not so bright red in color. This could also be a subhyaloid or a subilent bleed. Sometimes you get in these patients. Most important, investigative tool that would have actually shown you the level of lesion is the OCT here. If you had just done the OCT scan, you would have known whether it's subhyaloid or sub-ILM. So you only manage systemically for this patient. Did you do any other treatment? So my question basically here is, if you had a large subhyaloid hemorrhage like this, what would be your treatment modality to relieve the patient, especially if there's a bilateral subhyaloid hemorrhage causing significant drop in vision, not allowing the patient to move around comfortably? What treatment modality could you have offered the patient?
Ma'am, first we put on the observation, follow-up after.
No, I'm telling you to give treatment, no observation. Patient has bilateral large subhyaloid hemorrhages. Patient is young, needs to be mobile. You have to treat that patient. How will you treat that patient?
NDA hyalodectomy should be done.
Very good. How will you do it? How will you do it? Tell me. What is the premise, or what is, even if you don't know the settings, Afsa, you should at least tell me, what is the aim of doing the treatment?
Okay, which, ma'am, prevent the further retinal damage. If
no. So the idea of doing it is to create an opening or an outlet for the fluid, so that it comes into the vitreous gel and then it gets dispersed. Okay, so you're basically displacing it. Other methods that are used when it is subretinal. Suppose it was subretinal, what would you have done? Can you do the same thing?
No, ma'am.
What if there was submacular hemorrhage below the retina? There is fluid. What would you have done? How would you have displaced it? Then you can't do YAG, right? Because you'll be hitting the retina then. Okay, maybe that's a little too advanced for you. I'm done. That's all. Thank you.
The white centers, how does the white center, form in case of a rod spot?
Rod spot is basically intraretinal hemorrhage with coagulation, fibrin coagulate in the center. Basically, when the capillary is damaged, so at the site of the platelet and fibrin are make a coagulate plaque. So it look like. Okay.
Afsar, just this thing with your, I can say a little bit similarity with your presentation. What are the findings in a dengue patient? If you think that the patient is having any kind of retinopathy, what is going to be the finding in the dengue patient? Or maybe we can just keep this question later on, because we have got a chikungunya retinopathy as well. Okay, fine.
Okay, if the judges are done with their questions, can we move on to the next speaker?
Yeah, sure.
The next speaker is Dr. Devanshi Mehta from Pramukh Swami Medical College, Karamsad. Her mentor is Dr. Devendra Saxena, and she's going to speak on CRVO with ciliary retinal artery occlusion.
Am I audible, ma'am?
Yes.
I'm sharing my screen. Just wait a second. I'm not able to share my screen. Okay.
Is it done?
Let me do once again.
I would request the other participants to keep their presentations open before their presentation. Like they should keep it on the open, as Dr. Chaitra had advised before.
Yes. Ma'am, are you able to see?
No.
Not yet?
Yeah, no.
Then maybe you can take next participant and I'll be ready.
Okay, fine. Thank you, Devanshi.
Sorry for the inconvenience.
Yes, we would call Dr. Isha Kshatriya. She's also from Pramukh Swami Medical College, Karamsad, and her mentor is Dr. Devendra Saxena. She's going to speak on scleral buckling in a patient with intravitreal lens luxation, a case report.
Good afternoon, ma'am.
Are you ready?
Yes, ma'am. Ready.
Yeah, start.
Yes. Just a second. Ma'am, is the screen visible?
No.
Ma'am, now?
Mhm.
Isha, what error are you finding? What is the problem for you to share a
Ma'am,
presentation?
it's just it's not connecting.
What is not connecting? You open the presentation, go to screen share and click on the presentation. Yeah, there it comes.
Yes, ma'am.
Any problem with
Yeah, now started. Yes. Can you put it on slide share mode, please?
Yes, ma'am. Good afternoon, everyone. Presenting a case of scleral buckling in a patient with intravitreal lens luxation. A 44-year-old Muslim male with no systemic comorbidities presented to the OPD with complaint of left eye sudden and painless dimness of vision since 3 years. He had a history of left eye blunt trauma while working in an industry 3 years ago. That was 3 years ago. Also, he had a history of right eye trauma with FIST 8 years ago, for which he had undergone multiple retinal detachment surgeries. That were 2 pastana vitrectomies 8 years ago at a tertiary care hospital. No documents were available for the surgeries, but those were unsuccessful. There was no personal or family, significant personal or family history. The clinical examination of the patient's right eye was perception of light with projection of rays faulty in all the quadrants, no hand movements. I would only highlight the relevant findings. The anterior chamber reaction was occasional in the right eye, along with a patent surgical peripheral iridectomy and grade 4 IOPD. The lens status was aphakic and the intraocular pressure was 10 in right eye. Left eye findings were projection of light present with, perception of light present with projection of rays full in all the quadrants, counting finger 2 meters, not improving further with correction. The occasional cells were present in the anterior chamber. Few patches of iris atrophy were present and sluggish pupillary reaction was present. Lens status was aphakic and intraocular pressure was 10. Fundus examination of right eye showed 0.9 glaucomatous cupping with total retinal detachment in narrow funnel configuration. Left eye also showed similar findings of 0.9 cupping with subretinal bands at 4, 6, and 7 o'clock position that were temporal to the disc, along with lattice degeneration from 8 to 10 o'clock position and atrophic hole at 12 o'clock position, and a dropped lens was seen inferiorly with inferior vitreous condensation. These were basically the peripheral vitreoretinopathy changes. So we had planned the patient to take for 360-degree scleral buckling encirclage with 42 number silicon band, along with subretinal fluid drainage and cryopexy for the retinal break. On first post-operative day, the vision was counting finger 2 meter, which was not improving further. Intraocular pressure was 40. The retina was flat with good cryo reaction, and a drop lens could be seen inferiorly with minimum movement of the lens due to the vitreous condensation. So we had put the patient on systemic and topical anti-glaucoma medications along with the routine antibiotics, lubricating and steroid eye drops, which was the routine post-op treatment, and an atropine eye ointment. On 7th post-operative day, the vision was counting finger 3 meter, but it improved to 636 with correction. The retina showed similar findings, which was flat retina with macula on. The subretinal bands could be seen good cryo reaction around the breaks and a sclerosed lens inferiorly. The steroid eye drops were tapered off and anti-glaucoma medications were continued. On 30th post-operative day, the vision was counting finger 3 meter unaided with 624 partial with correction. The fundus findings were similar and intraocular pressure was reduced to 15 mmHg. So to conclude my case, I would like to say that it was challenging to do a scleral buckling in this type of patient because he already had a history of failed two surgeries of pars plana vitrectomy. So in view of unfavorable outcome in the right eye, we decided to go for left eye scleral buckling encerclage with 42 number silicon band, which gives a good buccal indentation and height, and no added tire or sponge was used. And as the high buckling was done, it had induced a trampoline effect to keep the macula on. And as the patient was aphakic, we can examine the periphery for breaks and lattice degeneration, which were then taken care of intraoperatively. Post-operatively, the retina was well settled and a favorable visual outcome was seen. Proliferative vitreoretinopathy changes inferiorly helped to keep the lens in place, and also the lens was sclerosed, so there was no chances of phacolytic glaucoma. Air tamponade was not used at the end of the surgery as it would have caused undue traction on the vitreous leading to new breaks. So this is the fundus photograph of left eye. As it's hazy a little bit, but we can see subretinal bands at 4 o'clock and 6 o'clock and 7 o'clock position here. And this is the inferior drop lens. Thank you.
Okay, so a couple of points here. I think your title is very misleading. This is Isha, right?
Yes, ma'am.
Isha, why would you say some scleral buckling in a patient? See, this is basically you've done scleral buckling for the RD. It has nothing to do with the lens. It's okay that the lens is dislocated, but your primary management of scleral buckling is for the total RD. Okay, because you've not touched the lens in any way. It's not that the lens has helped, bring back, the buckling has helped bring back the lens into position, nothing like that. So the lens has remained like that. So your, first and foremost, your title is misleading. It's inappropriate. Second is when you do not have if you have a fundus camera, you have a fundus photo, well and good. Otherwise, it is very important that you draw your fundus photo, you draw your fundus findings, draw the chart, write where the lens is, what are your PVR changes, what is the grade. Even if you can't grade PVR because you're still, a resident, a fundus diagram is compulsory in a case sheet like this. In a case presentation, whether it's your exams, you have to learn how to draw a fundus chart. Okay, yes. Because that's very important, especially when you're doing a scleral buckling, to plan your treatment. You want to know where to do the cryo, where to place your band tie, where to do your tunnels. All those are very, very important decisions you take when you put your chart in the OT. The chart is not only important for your diagnosis and for your presentation, for your planning, surgical planning, it's important. I understand that you were not very keen on taking off the lens, but what prevented you from doing a vitrectomy, removing the lens and putting the secondary IOL? How are you going to rehabilitate this patient, especially since, he's one-eyed? Why don't you want to rehabilitate the lens, in this particular patient? I can't see you, Isha. I don't know, it's a blank screen.
Ma'am, actually, there's some issue with the network. The camera is not working. I tried, but it's not working. Sorry.
It's okay. Never mind. Answer my question, please. How are you going to rehabilitate? You're going to give this patient only spectacle correction?
Ma'am, actually, the patients, we had tried to give him the best corrected visual acuity, which was improving to 624 with spectacles. So he is able to do his routine work by with the help of glasses. So till now, we have kept him as with the help of spectacles only is carrying out his work, and also he is a bit low socioeconomically back state. So we haven't done anything other than this.
Okay. And also one other reason probably why his vision may not improve is also if you look at the disc, it's pretty bad. It looks very pale. You said the patient also has glaucoma. So my reason for asking you, and I think Dr. Shweta will agree, is when a patient with glaucoma, secondary IOLs have to be planned with a lot of caution. We have seen the glaucoma become worse after secondary IOLs. So it's okay to leave these patients aphakic. Give them spectacle correction, give them contact lens if required. No need to offer them better vision at the risk of losing whatever little bit they have. So that's okay. I just needed you to understand why we have to keep our secondary IOLs also, very well planned. We should not be offering them to every patient, given the fact that their optic nerve is pretty badly damaged. That's all from my end. Thank you.
Okay, so Ishita, I have a question that Isha, sorry, I have a question that since you said that your patient when presented had 0.9 cupping, but the pressures were 10. So how did you plan to start the intraocular like anti-glaucoma medications? What was your take for that?
Ma'am, basically we started anti-glaucoma medications just for the operated eye because the pressures had shoot up to 40 mmHg, and the other eye had also had chronically adapted to the pressure, so we haven't started any anti-glaucoma medications in that eye.
No, so before surgery, you didn't put the patient on any anti-glaucoma medication.
No, ma'am.
After
The
surgery,
patient.
so did you go back and look at what was the cause of that raised pressure? Because you later on mentioned that the pressures came down, I think, to 15, right?
Yes, ma'am. After anti-glaucoma medications were started in the operated eye, it came back down to 15.
So
But
did
the
you
patient
perform?
was no, ma'am. Any extra glaucoma evaluation was not done. The patient also didn't have any family history of glaucoma. But we lost the patient to follow up after 1 month, and we had planned once the patient settles after the surgery, glaucoma evaluation was planned. But as we lost the
What was the
patient,
vision post-operative for that case?
ma'am, it was counting finger 3 meter,
So
improving to
anyway,
624.
so anyway, if you would have planned a glaucoma investigation, you wouldn't have been able to do that because no patient can perform a perimetry with finger counting or such a low vision. So only thing which you could have done is doing a pachymetry, or maybe just you have just mentioned that 0.9 with 15 millimeters of pressure. Like, okay, once you have seen pre-operatively that the disc was having 0.9 cupping, that's an advanced cupping. So what is the one particular thing which you are going to keep in mind while putting a buckle in these kind of patients?
Just to ensure that we don't raise the pressure far in beyond that it can further lead to the optic nerve damage.
So how are you going to do it intraoperatively? What you have to adjust?
Tightness, height of the buckle and the
Yes, good. So the height of the buckle needs to be adjusted because else it will cause the undue pressure over the vortex veins. So now again, in these cases, the role of gonioscopy comes into play that you have to see. But again, these are not the cases where you have to go for a PI when you see that there is an angle closure. Because actually it is not a pupillary block. It might be a pupillary block, but majority of the times it is going to be the buccal height, or you have to put the patient as a routine post-operative treatment. You put the patient on antipleugics and steroids. And again, steroids can act as a dual sword. So you have to be careful that the patient is not, because this is a one-eyed case with so much of advanced cupping. So you need to be at a uttermost, I should say, carefulness that the patient doesn't lose the vision anymore.
Yeah, thank you, judges. We are running out of time. So can I have your permission to ask the next speaker to come on board? Yeah, thank you so much. We have Devanshi Mehta. Devanshi, are you ready now?
No, ma'am, having some issue.
Okay, so
yes,
yeah, we'll move on to
yes.
Grishma Nair, and she's from MNJ Vero, Ahmedabad. Her mentor is Dr. Sonal Shah, and she's going to speak on choroidal melanoma. And we have just 4 minutes for the speaker and 2 minutes for the discussion. Please mind the timings, please.
Smita, you can stop us, Smita. If you're discussing too much, just tell us time up. Please stop.
No, it's okay. It's okay. I'm also enjoying the discussions, actually.
Good afternoon. Hello.
Please.
Hello, good afternoon.
Yes, good afternoon.
Yeah, Grishma, go ahead.
Yeah, am I audible?
Yes.
Good afternoon. I'm Grishma Nair, and I'm presenting a case on a choroidal mass and mentored by Dr. Sonali Shah from MJ Regional Vested Institute of Ophthalmology. A 72-year-old retired male patient presented to the ophthalmology OPD with chief complaints of sudden onset of diminution of vision in right eye with pain, which was painless in nature since 1 month. The patient was apparently all right 1 month ago when he started complaining of sudden onset diminution of vision. It was not associated with watering, redness, discharge, headache, or floaters, photoma, or any distorted vision. The patient had past history of tuberculosis 35 years ago, for which he had completed AKT treatment. There was no history of any other systemic illnesses or ocular trauma, glasses, or any recent surgery. The past personal and family history was not found to be significant. On general examination, the patient was conscious, oriented to time, place, and person, and vitals were stable. The vision in right eye was counting fingers 1 meter, which did not improve on pinhole. In left eye, the vision was 6/24, which improved to 6/6 with 2 diopter sphere. On slit lamp examination, the lid and lacrimal apparatus was normal, and the anterior segment was found to be within normal limits. The IOP was 12 millimeters of mercury in right eye and 14 millimeters of mercury in left eye. On dilated fundus examination in the right eye, the disc was found to be normal with normal blood vessels and macula in the presence of a solitary, large, pigmented unilobular dome-shaped or mushroom-shaped mass nasal to the disc with overlying orangish pigmentation, and it was associated with vitreous hemorrhage. The left eye fundus was found to be normal. Disc was 0.3 CDR. Background and blood vessel was normal, and fundus reflex was dull. Foveal reflex was dull. Sorry. So, considering the above examination, I reached to my provisional diagnosis of choroidal melanoma. Keeping in mind the differential diagnosis, we performed a few more investigations. On B scan, USG revealed a 7/8 millimeter collar-shaped homogeneous choroidal mass lesion of low to medium internal reflectivity and increased vascularity. It was associated with retinal detachment and vitreous hemorrhage. To further corroborate our diagnosis, we performed an MRI with the brain with orbit, which showed a hyperintense tumor on T1 weighted images, which was limited to the right globe, with presence of retinal detachment or subretinal hemorrhage. No extrascleral extension was found. We also performed the blood investigations, which were not within normal limits. In order to rule out metastasis, we performed the MDCT abdomen, which revealed only a few simple cysts in the right kidney and in the liver. The chest radiography was normal. So I reached my final diagnosis of right eye choroidal melanoma. The patient was started on flurbiflopin eye drops and H2 ointment twice a day and tablet prednisolone. Considering the advanced age of the patient is 72 years of age and inability to keep regular follow-up, the large tumor size, we managed the patient by enucleation of the right eye. The findings were confirmed on histopathological examination, which revealed an epithelioid melanoma. The size was 1/0.8 centimeter and no extrascleral extension was found. The following slide shows an epithelioid melanoma with no tumor, tumor infiltrating lymphocytes and no tumor necrosis. Some of the other modalities of management of choroidal melanoma can be brachytherapy, radiation therapy, or charged particle irradiation. We can also do a transpupillary thermotherapy or photodynamic therapy or a surgical excision. That's it. This is concluding my presentation. Thank you very much.
That was a very nice
presentation. Thank you, Grishma. Yeah, nicely presented, I must say, for a postgraduate, the way you've done your slides and everything.
Thank you.
Well done.
Thank you.
Yeah, so now my questions to you are, first and foremost, it's again a slightly advanced case for a postgraduate. But since you've taken it up, when would you do brachytherapy versus enucleation?
Sorry, ma'am?
My second question is, how do you correlate your B scan, findings with the histopathology? Since you mentioned both these things, these are my two questions. You can answer them and go to the next step.
Okay, so the first question was, when do you do a brachytherapy and when do you do a enucleation? The brachytherapy is usually performed in small and moderate size tumor lesions, which is less than 16 mm in horizontal diameter and less than 8 millimeter in thickness. Although there are no definitive limits for when to perform brachytherapy or not, but since the radio plaque can only be applied to up to 25 millimeter of episcleral area, so that limits the brachytherapy applications to tumor sizes less than 21 millimeter in diameter. So brachytherapy can only be performed in such lesions, and enucleation is usually considered in advanced tumor with more than 25% of uveal tract involvement, and in cases of neovascular glaucoma and painful blind eye, we may proceed for enucleation. And the second question was what is the correlation between B scan and histopathology? Ma'am, can you please further elaborate on the
So
question?
how does the appearance on B scan tell you about what the histopathology is going to be once you enucleate and look at the mask? There is some correlation on the appearance in B scan versus what you can actually predict what your histopathology is going to be.
Okay,
The
yes, ma'am.
echogenicity.
Yeah. In case of choroidal melanomas, the tumor mass is homogeneous. There is a acoustic quiet zone, and there is orbital shadowing and excavation into the tissue. And there is on A scan there is a low to medium internal reflectivity, which is suggestive of choroidal melanoma. In case of choroidal metastasis and hemangiomas, there is no acoustic shadow. There is high internal reflectivity, and there is no orbital shadowing or any of the findings which are characteristic of a melanoma.
What is acoustic hollowing?
Which is behind the tumor lesion, there is a quiet area. There are no echoes in that area
And what are the pigmented lesions do you know apart from this? What are the other pigmented? What will be your differential diagnosis when you see a pigmented lesion like this?
Yeah, if it were a flat lesion, I would consider a choroidal nevus. But since it is not a flat lesion, my other differential diagnosis would be choroidal hemangioma, melanocytoma. These are some of the pigmented lesions in.
What do you expect on angiography in a choroidal melanoma in FA? Is there any typical thing that you see?
The findings are not very diagnostic, but there is early choroidal lobular filling, which is seen on angiography. With
what is double circulation? Dr. Chaitra? Do you see a double circulation? Is there any such thing?
Sorry,
I'm sorry, we stopped doing angiography completely for melanoma, so I'm not very clear about this. We just do the radio imaging and B scan.
Right.
So maybe before
this classical double circulation that you see in on angiography. Right? Yeah. So from a resident's point of view, I think this would be an important point, that what a specific thing that you see on angiography. Okay. I think I'm done with my questions.
Okay, so I have just a little addition to what Grishma has presented, a very nice presentation. Grishma, just one thing you should keep in mind, and once you're facing a case of melanoma, always just keep on, see, I'm a glaucoma person, so I will show you all the perspectives of glaucoma, how you have to deal with that, because it's a disease, it's a permanent blinding condition. Until unless you take care of the disease at the very first event, you are not going, it's very difficult for you to halt the progression. And after all these, the treatment the patient is going to undergo. So what my suggestion to you would be that always do a routine gonoscopy and see that how much angle has been invaded by your tumor. And that will help you decide that how you are going to treat that particular point of time, that what treatment you are going to offer to that patient besides treating the melanoma as well. So always do a regular, and at every visit, from the very beginning of this presentation, we have been pointing out that you draw the diagrams. Dr. Chaitra Madam has been continuously telling that draw the diagrams. That will help you decide that what needs to be done in which quadrant. Similarly, in this particular case, you draw the diagram, show the extent in which clock the melanoma is there, and that will help you to monitor that whether it's regressing with the treatment offered, it's progressing on what is happening. So that is my take from my side.
Yes, ma'am. Thank you, ma'am.
And Dr. Anita, you're correct about the double circulation. I think it's both the retinal and the choroidal circulation that's visible, and it's pathognomonic of melanoma. So as postgraduates, I think it's something important that you all should be aware of. And these are questions that are typically asked during vivas. So that's an important thing.
Excellent case and interesting discussion. Shall we move on to our next speaker, Dr. Seema Meena, who is going to present a case on chikungunya retinopathy. She is from MNJ Institute, Ahmedabad, and her mentor is Dr. Jignesh Gosai. Over to you, Dr. Seema.
Please switch on the slide share, Seema.
And your video on, please.
Seema, please start.
Seema, click on the outside of the slide and then go onto the slideshow mode.
Can I start, ma'am?
Please start.
A very good afternoon to everyone. I'm Dr. Seema, second year resident from MNJ Regional Institute of Ophthalmology, and my mentor is Dr. Jignesh Gosai. I'm presenting a case history of a 16-year-old male patient residing at Kalol, Ahmedabad, who presented to our OPD with a chief complaint of diminution of vision in left eye, which was sudden, painless, and progressive from 15 days. Patient was relatively asymptomatic 15 days back. Then he developed a sudden painless progressive diminution of vision in the left eye. Patient had no associated history of pain, redness, watering, or photophobia, or he had no other ocular complaint. Patient gave a positive history of fever 1 month back, which was associated with joint pain. No history of systemic illness like hypertension, diabetes, TB, or past history of ocular surgery, trauma, or foreign body was available. The best corrected visual acuity in right eye was 6.6 and in left eye was counting finger 0.5 meter. Anterior segment examination was within normal limits with the iris pupil round in shape, a normal size and reacting to light, and eye movements full with normal cornea and conjunctiva. Intraocular pressure with Goldman's applanation tonometer was also within normal limit, which was 15 mm of Hg in right eye and 16 mm of Hg in the left eye. Then posterior fundus examination was done, and in the right eye, the fundus was quite within normal limits with the disc of 0.3 cup disc ratio with normal margins and healthy implant. Left eye fundus examination showed inferior exudative RD with subhyaloid hemorrhages, macular star, perivasculitis with retinal edema, and choroiditic patch. The disc was within normal limits with 0.3 cup disc ratio with a healthy neuroretinal rim. So based on the clinical history and the clinical picture, the following differential diagnoses were made, which included hypertensive retinopathy, viral retinitis, or occlusive vascular diseases, choroiditis, and blood investigations were ordered accordingly to conclude to a diagnosis. One of our investigation was the antibody test for chikungunya, and the patient tested positive for IgG antibodies. Other tests which were carried out were this, and the patient was negative for almost all the investigations, which included HIV, HBsAg, herpes zoster, toxoplasmosis. Patient was also negative for COVID-19 RT-PCR. Rheumatoid factor was negative. Patient had a slightly raised ESR, and patient was even negative for NS1 antigen. So based on the history and a serological positive data, made a diagnosis of chikungunya retinopathy, and accordingly the treatment was started. Patient was started on tablet prednisolone 20 milligram BD with 3 days tapering and bromphenic eye drops 1% thrice a day. Patient was given a follow-up after 1 week, and after 1 week patient showed improved vision with 636 in left eye, and the follow-up fundus picture was this. The RD was inferior exudative RD was regressed with regressed subhyaloid hemorrhages. Even the perivasculitis was regressed. So a patient was continued on the same treatment and was given follow-up after 15 days. So to conclude my slide, I would like to mention that chikungunya retinopathy usually presents with a wide range of signs, which range from panuveitis to retinal detachment. And I'm presenting this case because exudative retinal detachment is not that common,
to present in a chikungunya retinopathy, and it should be considered in differential diagnosis if you have a specific history of fever and joint pain. So here I conclude my case. Thank you.
Thank you, Seema. Nice case. A couple of questions. What would be the causes for decreased vision in this patient?
Ma'am, it was because of a patient was having choroiditis and vasculitis with retinal edema. So anterior segment was
Those are
normal.
the findings. You're talking about the findings. You tell me a choroiditis somewhere away will not cause any decrease in vision. Okay. A peripheral vasculitis will not cause any decrease in vision. You tell me in this particular patient, what are the reasons for decreased visual acuity? There was significant decreased visual acuity.
Patient had a macular star, central macular edema, which caused diminution of vision to the patient.
Fair enough. Do you have the OCT for the patient?
Ma'am, actually, the patient was not affording, and no, ma'am, we could not go for OCT.
Okay. So now patients with macular edema, normally we treat them with anti-VEGF agents or with steroids. So what is special about this particular case that you didn't treat the patient, or it's not required?
No, ma'am. We had somewhere in mind that it could be diabetic or hypertensive, but patient, we were slightly inclined to viral pathologies because it had a history of fever and joint pain, and also other investigations were normal. So.
So the thing with epidemic retinitis and patients with post-fever retinitis is that just with systemic management, just with steroids, even the macular edema resolves because the inflammation comes down so drastically. You don't need to locally treat the macular edema. You don't need to actually give them anti-VEGF injections or steroids. We so many times within a week of starting treatment, we see that the macular edema starts coming down. Now, in chikungunya retinopathy or in chikungunya affecting the eye, other than retinitis or choroiditis, as you showed me, what other findings can you get? What other parts of the eye can be involved in chikungunya?
Ma'am, it can involve the anterior segment as well. It can present as anterior uveitis. It can also cause vitritis.
It can also affect the optic nerve.
Yeah,
so
exactly.
That's
the
also very
macular
important.
scar is there, which could, I think.
You should mention that because you said the optic nerve was normal. It can also get affected. Okay, I'm done. Next,
Because of the macular star, I think you should also think in terms of the neuroretinitis. Am I right, Dr. Chaitra? Because of that could probably give a hint, as to the neuroretinitis part of it. And the steroid will help there.
Yes, which itself is a cause also for decreased vision. Other than the macular edema, that itself can also cause vision can be affected because of that.
Maybe the pupillary reaction could have helped in clinching this part.
But the optic nerve looked pretty okay, so we should also keep all that in mind. But like she mentioned, there can also be anterior uveitis. Anterior uveitis itself can also bring down the vision to some extent. There can be episcleritis. Multiple involvement is there because. Pardon?
Sorry, ma'am. You can continue, ma'am. Sorry.
No, so you can, like Madam was mentioning, there are simple tests like pupillary reaction. You can check the color vision. No, these are all things that will give an indication.
To my side, from my side, it would be just a simple thing that since you have said that the anterior segment of the eye is also going to be involved, so it's not only restricted to the anterior uveitis, it could be in the form of corneal involvement, maybe in the form of simple dendritic pattern of the corneal involvement, like any other viral involvement, or it could be either in the form of simple conjunctivitis. So the minute you see and you reveal the history that the patient has suffered from chikungunya, definitely you need to keep the patient on a close follow-up so that to monitor the involvement of the retina as well as the anterior segment as well. And at the same time, again, coming back to my only favorite thing, that's intraocular pressure. I just can't keep away from myself from my talking about intraocular pressures. So definitely this anterior uveitis and leading to trabeculitis is going to cause a rise in the intraocular pressure. So you have to keep a check on that also.
Yes.
All right, we'll complete this case over here and we'll move on to our last presenter. Dr. Devanshi, are you ready?
Ma'am, actually, I am ready, but I am unable to share my screen. I don't know what settings to be done. I have.
Use the blue.
I am
Can you see
using
the
Mac.
green button, Devanshi?
Yes,
Devanshi,
I
look
have
for
done
the
share
third
screen.
button. Okay.
Yes.
Try doing it now.
I am
shared now.
no, I'm not able to share it. It is
Click on the button. What does
share,
it say?
then open system preferences, and then I have done I have unlocked all settings, but I'm not able to share my screen. I don't know what is happening.
What happens when you click on the button share screen?
Yes,
We have
I
a
have
colleague
already
around.
done.
Do you have a colleague around from whose device you can join? Somebody else was also there from your college, no? So if that person is around, you can try from their device.
Ma'am, she's not around me.
Maybe, ma'am, we can take the help of the IT people by any desk. They can take over her laptop screen and they can just play for her and she can just keep on talking. If IT people are around, we can do that. Any desk can help her.
Devanshi, you can send me your presentation. I'll be sharing the screen and you will be speaking. That can be done.
Yeah, that's
okay, ma'am. Thank you so much. Where should I send?
To me, Dr. Gunjan. I'm sending you a message.
Yes.
Meanwhile, shall we continue with the other talk?
All the talks.
I think we need to review the judges from this, from the evaluation, because they need to submit their scores also. So we can just wait for a couple of seconds.
Okay.
And meanwhile, the rest of the compiling and all that scoring, if it is completed, because just one will remain, so you can just collate your scores till then.
Yeah.
I'm just sending it to you, Purvi. I'm done. I'll just send you this, whatever I finished.
Let her share first.
Does your presentation have a lot of images, Devanshi? Meanwhile, the three judges can just collate and keep it ready. So only one will then need to be added. Meanwhile, Gunjan, you can at least introduce the upcoming speaker.
Yes.
Introduction part,
Yes. Our next speaker, meanwhile, she has not sent. Yes, our next speaker is Dr. Pooja Khamar. She will speak about inspiration in ophthalmology.
I should wait for Devanshi to finish, or right?
I'm just introducing you, Pooja. Then we'll wait for Devanshi.
Thank you.
Pooja has done MS, FRCS, and PhD. She is working as consultant cataract and refractive surgery. She is clinical and translational scientist at Narayan Nethralaya, India. She is currently employed as consultant and lead trainer in cataract and refractive services at NNI Institute. She is actively involved in translational research as a clinician and translational scientist at GROW and IBMS Lab. She has done her PhD on wound healing and refractive surgeries from Maastricht University, the Netherlands. She has pursued her fellowship in cataract, cornea, and refractive services from Narayan Nethralaya. She is also on the editorial board of Journal of Refractive Surgery and Journal of Refractive Surgery case reports. Her areas of work include wound healing in refractive surgery, customized laser for refractive surgery and keratoconus, EI in refractive surgery, gene therapy for corneal ectasia and keratoconus, newer therapeutics in corneal scar management, and immune profiling in keratoconus. We welcome you, Pooja. I'll just wait for a few. She has sent me the PPT. Just wait for a few seconds. I'll be presenting it.
Thank you once again. And
Pooja, and sorry for
no
inconvenience.
problem, no problem. I'll wait for some, no problem. Thank you so much, ma'am, for your support.
Is it visible? Is it
Yes.
visible now?
Yes, yes.
Just let me know next, okay?
Yes, ma'am. Can I start?
Yes, please.
Good afternoon, one and all listening. Presenting a case of an abnormal origin of cilioretinal artery presenting as attitudinal field defect in case of central retinal vein occlusion with cilioretinal artery occlusion. My mentor is Dr. Devendra Saxena, vitreoretinal surgeon at Pramukh Swami Medical College. 40-year-old female presented with a chief complaint of right eye, sudden onset painless dimness of vision for near and distance both since 2 days, which was associated with decrease in inferior visual field. She had no known comorbidities or any significant history. On examination, visual acuity of left eye and ocular examination was within normal limit. Of right eye distant visual acuity recorded on Snellen's chart was 6/9, and the best corrected visual near vision acuity recorded on Roman's chart was an 8 with strain. Rest ocular examination was normal. Pupil was central, reacting to light with no relative afferent pupillary defect. Pachymetry corrected applanation tension recorded on Goldman's applanation tonometer was 19.9 mm of Hg. This is the fundus photo. Fundus examination in right eye. Here you can see right eye showed superficial hemorrhages present at disc. Deep hemorrhages present supranasal to the disc, adjacent to the disc, and cloudy white edematous area of retinal infarct of 4.5 disc diameter present superior to fovea, 1 disc diameter away from disc, and dot and blot hemorrhages were present in all 4 quadrants. Here you can see the abnormal origin of cilioretinal artery from superior part of disc instead of the central part of the disc. In left eye, disc and macula were normal. Octopus perimetry macular program was done, and right eye showed inferior attitudinal field defect. OCT was done, and right eye showed hyperrefractivity of inner retinal layer suggestive of thickening due to edema. Based on above findings, diagnosis of right eye non-ischemic CRVO with cilioretinal artery occlusion was made. And going to the plan of management, patient was started on right eye topically, a non-steroid inflammatory agent, napafenib eye drops 3 times a day, both eye topically, dorzolamide 2% eye drops for intraocular pressure control. Serum homocysteine was done, which was 13.07 micromole per liter. As it was on higher side of normal range, patient was started on tablet meganeuron OD plus once a day orally. Patient was referred to physician for management of hypertension as recorded blood pressure was 150 by 100 millimeter of mercury. Patient was followed up after a month, and visual acuity in right eye improved to 6/6 and macular edema was resolved. Concluding, as presence of cilioretinal artery is a blessing in case of central retinal artery occlusion, preserving the central vision of the patient. Here, its occlusion in CRVO could result in loss in central vision. However, in this case, abnormal origin of cilioretinal artery from superior part of optic disc has resulted only in attitudinal defect and preserving the central vision. Thank you.
Why was the field done first and foremost in this patient?
Sorry?
What was the indication? What was the indication to do visual field?
Ma'am, we wanted to know there is a visual field effect or not, like the retinal infarct area was seen, same visual field was recorded on the perimetry.
But it's a clinical diagnosis is pretty obvious, right? There's a CRVO with the cilioretinal artery occlusion, which is also shown on your OCT, the whitening shows. And Dr. Shilpi, do we routinely do fields in CRVO with cilioretinal?
No, we don't.
We don't do routinely, but only for documentation we did.
No, but actually the investigating modality that is required is an angiography. I mean, even if you want to show that it's cilioretinal combined, and it's actually a common combination of presentation that we see. Combined cilioretinal artery occlusion with CRVO is pretty common. So, I mean, I don't know if you're trying to show anything different by doing the field, because it's not a routine thing and it's not unusual finding.
Yes, but normally the cilioretinal artery arises from the central part of disc, and the patient's vision could be lost if it would have arisen from central part. Here, the superior, it is arising from the superior part. So she was having preserved central vision.
But there's a known anatomical variation to the cilioretinal artery. Many times, if the cilioretinal artery doesn't even supply the fovea, even with an occlusion, the patient will have 6/6 vision. So if you actually want to see the distribution of the cilioretinal artery, the investigation of choice is an angiography, because you want to see which part of it is not perfused, right? And if the patient has 6/6 vision, there's a good chance that the fovea was not involved in the circulation at all. So I think you should be very careful about which investigation you choose for what. I understand that you're showing a field effect, which you probably don't describe, because clinically, it's not very, very relevant for these patients, because irrespective of whatever the field effect is, our management does not change, right? Yeah, any other judges? I'm done. Thank you very much, everybody.
Thank you, ma'am.
So again, when you're talking about a central retinal vein occlusion, you should be able to identify what is the most common, we say that 100-day glaucoma. Let me make it very simple for you. What is 100-day glaucoma?
Within 3 months, the non-ischemic CRVO can be converted to ischemic CRVO, and it can lead to neovascularization and lead to glaucoma. That is 100-day glaucoma.
So, okay, when we talk about glaucomas in these particular cases, you have to be careful from 2 weeks to 2 years. It's not that it is going to occur only after a period of 3 months, as it is said. But yes, the most common, I should say, the time period for the occurrence of this glaucoma would be and even after the treatment has been done, the lasers have been done and everything, even sometimes the synachial closure, they eventually lead to further progression of the angle closure. So regular gonioscopies are needed in all these cases.
The regular monitoring of the ocular pressure.
Yes,
I am also done. Nice presentation.
Thank you, ma'am.
Thank you so much. I'll now send it over to Dr. Gunjan so that Dr. Pooja can start her talk. You're running a little late. Over to you, Dr. Pooja.
Thank you, ma'am. It's always good to be talking when you're talking for Gujarat Ophthalmic Society, because it's a lot of nostalgia out there, because of course it's been my home state. I do work right now in Bangalore, but of course I come from Gujarat, and you all have been my teachers. So it's always good to be here. And thank you, Purvi ma'am. Thank you, WAS Ophthalmic Society, and everyone out there for giving me this opportunity to speak. I've been given this topic to talk on inspiration in ophthalmology. I am too young to talk about inspiration, but as there are a lot of postgraduates here, I would like to talk a little bit about my journey and challenges, what I faced in this journey, and how you can overcome it to reach wherever all our teachers are. Of course, it's not going to be easy, but it's definitely important. So first, when we do MBBS, after MBBS, there's always a dilemma, and a lot of people tell us that, you are women, so always go ahead and do a non-surgical branch, choose a non-surgical specialty, because you have to take care of home, you have to take care of family, kids, a lot of other responsibilities you have. But all of us here have chosen a surgical specialty because for our passion for work. They say that, it's the same distance and you have to win at the end. But, everyone doesn't know about the challenges we all face. For example, to begin to start with only. And now it's changing, the dimensions are changing for both the men and women. But of course, when few years back, it was different for women because we had a lot of responsibilities along with work, and now as well, when you want to do when you're professional, it's the same distance, but we have other challenges in life. So I chose to do a cataract and refractive surgery fellowship in Narayan Netra in 2016, and I just came here to brush up on my surgical skills. But all of us, my colleague also spoke about how she was posted in lab, and we do a lot of research along with our surgical posting. I was also given an opportunity for the same. But then during that time, I was asked that, would you be interested in doing a PhD and become a clinician translational scientist? I said yes. I didn't know why I said yes, but that point of time, I was just, very much excited, like, how to become a PhD and work in my area of interest. And I just took the plunge, went into it and started. But when I started, this is how my life was. Everything was messed up when it started. And a lot of us, when we take the plunge into our career, we choose a area of our interest, a subspecialty. This is how everyone's life looks like. And it's not easy, and it's a very difficult thing to maintain a balance between the personal and professional life. You don't know, sometimes you might have to give importance to your personal life, keeping back the professional life. Sometimes you have to give importance to professional life, and your personal life sets back. So life is all about keeping a balance between the personal and professional life. But it is at the end, and we know it looks a mess, but I'll show you how it becomes easy and straight as you move forward. And over the years, I finished my PhD under my mentor, Dr. Rohit Shetty sir, in Maastricht University. And also, while I was doing my PhD and my training in my clinical PhD program, I did get an opportunity to win a lot of awards with hard work and proper mentorship. And Dr. Mohita also spoke about how a mentor is very important in life. So of course, I also could get the opportunity, and nothing was more fulfilling than to see my parents, parents when I got the India Hero Award, and when I got my PhD, my entire family was besides me. So nothing can be more fulfilling than to see these moments in life. So of course, it is all messed up when you begin, but keep hard work and passion towards your work, interest in your work will may lead to this opportunity as well. So a lot of people said, okay, you're doing on the research, and then you're in NN, you'll only do research. So my question was to you guys, did I do only research? My question was no. I did cataract surgeries, I did refractive surgeries there. I went on to doing SMILE, I did scleral fixated IOLs. Being a cataract and refractive surgeon, I do independent SF IOLs, and I did ICL surgeries as well. So I just didn't do research. I did a lot of other things as well during my training and my career as well, now as I'm a consultant now. So life did become different. I think my screen is just 1 minute. Just a second, I think my and then when I became a consultant, I went ahead and started training postgraduates and fellows as well. So it didn't just stop there. I was also fortunate to work with our team in some of the most important research work, which applies to genetics, a Pathfinder kit, a Biome Pathfinder kit, which my colleague Dr. Savitri spoke in the morning, and AI related stuff as well. And we call it our Vision Research and Center for Unknown. So it was also a part of my journey. So though it did become a lot of people know me out there, it did look like a messed up journey when I started, and a lot of people told me that, you know, you don't know what I'm doing. But at the end, everything started falling in place. Including my personal and professional life both. So yes, when you start a career, when you start a job, when you choose something in life, everything will look jumbled up, but at the end, everything will fall in place. But you just need to have patience and faith, as Dr. Rohit sir spoke in the morning. So if you have both of those things, then yes, everything will be easy. And this is not the first example. There have been a lot of failures in life, and very well-known ones, which I have mentioned here. And if they did not fail in the first or second attempt, they wouldn't have become the people whom we know today. So failures and glitches are a part of your career when you do it, when you are a surgeon especially. But if you don't give up, if you keep up the hard work, if you keep your focus on your faith in your work and yourself, you will definitely reach somewhere where you know where you want to be, and your dreams will do come true. So all great changes are preceded by chaos. Don't forget about it. Failure is not the opposite of success, but it is a part of success. So keep working hard as you are. Everything will fall into place. You just got to be patient and trust the process in what you've taken the plunge into. And don't, as again morning my mentor said, that, you know, don't compare yourself with others, because others' journey is not the same as yours is. But you compare yourself with do the comparison with yourself, what you were yesterday, and have you become a little bit better today? Because every day you have an opportunity to grow yourself, to become better, work hard, train harder, and make each day count. Don't try to see what you are today, see the entire puzzle of your life on the last day. And as I said, keep getting better every day, and keep doing better every day, and you will become an excellent surgeon. And I was always told this, and I have just tried to keep this myself in mind, that always think for your soul. If you have passion in what you're doing, you'll always reach somewhere where you want to be. And always keep in mind that always think for your soul, and always keep inspiring yourself and others around you. You will reach there. So that is what I wanted to say. Of course, nothing is nothing is complete without your family. So always be grateful for what you have, because family support is extremely important in your life. So be grateful for wherever you are and whatever you have. And it's always important to work with the right team and build the right team. You might start, it's like a tree. You might start with one person, you might start as a single man, but you need you need a good support system. You need a good team in your life to grow where you want to be. So always try to be with like-minded people, gel up with right-minded people, and you will reach where you want to be. And I'm thankful for everyone in my life, and gratitude. Don't never forget to be grateful for whatever you have. And if you are grateful for whatever you have, you'll attract more better things in life. Thank you.
Thank you, Pooja. I think many of students and also faculties are also inspired by you. Before going to next speaker, I would like to thank judges of the last session, Anita ma'am, Chaitra ma'am, and Shweta ma'am, for providing their time and giving wonderful comments. I'm very much thankful to Dr. Shilpi and Dr. Smita for moderating the session well. Now, next and our last speaker is Dr. Sheetal Movakar. She will be speaking about what, as we know, we all are addicted now to smartphones and laptops because of the quarantine. So she will be speaking about quarantine dry eye, a pandemic repercussion. She is presently working as a senior consultant, cataract, cornea, and refractive services at Retina Foundation, Ahmedabad. She is highly motivated professional eye specialist with good academic background, skilled and experienced in comprehensive ophthalmology with specialization in cataract, cornea, and refractive surgeries. After finishing PG and fellowship in phacoemulsification, She worked as a consultant in entry segment for 3 years at Bombay City Eye Institute and Research Center. She did a cornea and ocular fellowship at esteemed institute like LVPI, Hyderabad, and bespoke fellowship at Narayan Nethralaya, Bangalore for refractive surgeries. She has a special interest of complex cataract surgery, secondary IOLs, complex ocular surface surgeries like SLED, lead MMG, keratoprosthesis, etc. She has presented various papers and presented various talks in various national and international conferences, conducted 2 successful CMEs in Ahmedabad. She has won many surgical video competitions and papers and posters. And I'll invite Dr. Sheetal ma'am to start her lecture.
Thank you, Gunjan, for those kind words. Is my screen visible?
Yes, ma'am.
Yeah, okay. Thank you. Good evening to everyone. And seems like I'm the last warrior, and I know all of us are tired, so I'll try to make it a little quick. So what I'm going to talk today is about the quarantine dry eye and how this whole pandemic has kind of made the difference in our dry eye and what we see in our clinic. So what we are going to talk about is what's the impact of this pandemic on dry eye, on quality of our life, what are the changing trends, and what are the reasons why are we seeing so much of dry eye during pandemic and post-pandemic. So we all know that DEWS 2 has classified dry eye in a different way. We know that it's a multifactorial ocular surface disease, which is characterized by loss of homeostasis of tear film. This tear film instability, hyperosmolarity, there is a lot of ocular surface inflammation, and that eventually leads to damage. And additionally, what they have included in DEWS 2 definition is the neurosensory abnormalities. Now, when we don't treat this dry eye, it can cause a chronic ocular surface damage. So how does it affect our quality of life and vision? So basically what happens is whenever there is a dry eye, it affects, and most of the times when it is moderate to severe, it kind of starts affecting our daily tasks. It reduces the vision. It can decrease contrast sensitivity. It can increase higher order aberrations that will give you a lot of asthenopic symptoms, that will give you a lot of glare and all. And sometimes in a severe dry eye or people who had already a moderate dry eye, I have seen patients who are coming up with punctate epithelial erosions, and sometimes the chronic ones which are not treated properly can lead to haze and vascularization in the periphery of the cornea. These symptoms eventually start giving a lot of ocular pain, and that leads to headaches. And all these problems can give psychological issues like anxiety and depression. Besides all these things which are there, which happen in the body physically as well as mentally, it causes a kind of financial burden on the person as well as the society, because there is a productivity loss. You're missing out on days. You're taking more time to do the task what you used to do it earlier. So the prevalence of dry eye, as we know right now, is also pretty high. And according to different studies, the range is pretty wide. It is somewhere from 18 to around 55. But what is more alarming is what is going to happen in next decade, which India is at the threshold of dry eye disease by 2030. So what are the changing trends, and why is this happening during the lockdown? So we all know that with COVID-19 and there was so much of panic, we all started wearing a lot of masks because of obviously so the infection should not be spread. Again, the work because of the during the what do you say, during those in between first and second wave, then when there were strict regulations and the work was more from the home, the schools were off and all, the people were working from home. The most of the times they were through the online work, online schools, everything was online. Second, online, it was not only work, but it is the personal thing also. You have more time, so you need more entertainment, and there was no other way to entertain ourselves but to watch something on the screen. Of course, again, the use of sanitizers also kind of led to the whole thing, and reduced sun exposure and outdoor activities. And the biggest problem, what I just spoke, is the children, the online school, and the children's screen timing. So these symptoms have increased. So what you see out here in the black bars is something which was before lockdown, and the gray bars are post lockdown or during lockdown. So you can see that everything which is related to dry eye, like watering, itching of the eyes, pain of the eyes, and dry eye per se, is so much more during lockdown than what it was before lockdown. And even if you see the last column where the headaches have increased post lockdown or during lockdown, is also related to dry eye symptoms as well as the increased screen usage. Again, there are various papers who have kind of tried to come out with this, that what are the reasons for this increase in prevalence and worsening of these symptoms during the lockdown. So the number one was increased screen time. There was high stress level. The stress level could be because of anything, because of no work, because of financial burdens, and anytime whenever there is more stress in the body, the more inflammation automatically happens. Again, lack of sleep, disrupted sleep again causes the lacrimal activities, it decreases, so that will kind of reduce the tear secretion as well. I wouldn't say the allergy season, even though some papers have mentioned that that is particular or peculiar to lockdown. It is there throughout our life. But there are some initial 3 or 4 things were little more responsible because of the pandemic per se, or because of the lockdown per se, and also the increased alcohol intake. In fact, WHO had kind of given a warning for this alcohol intake in between. So these are the some of the reasons of why we have more of this dry eyes. One is, as we discussed, these 3 4 things, and we will go through it. So digital eye strain. So what some papers have mentioned and shown and proved that if they compare before lockdown, which is your green bar, and the post lockdown is your uh, uh, blue bars, if you see the number of hours which were used on screen were much less earlier before lockdown, but as we see, as the number of hours increases, so much is more during the lockdown and post lockdown. And it's the same, that unfortunately this is as the more number of hours have increased, even the younger age group, that is 22 plus minus 5 years, is more into longer hours of digital screen usage. So that is actually pretty alarming, because dry eye is generally not so common in young age, but now we are seeing a lot of children and younger people with dry eye because of this particular thing. Also, there are a lot of digital activities which are there. So people are doing not only work, but there are other things which are digital activities which have increased, and digital devices also, not only computers, but there is digital devices like mobile is there. There are some other video games and TV. So there are a lot of things. Our life has become full of kind of around these digital screen devices, which have led to these things. Because what happens when we are when we are on digital screen is, first of all, we tend to blink little less. There's a blue light thing, and evaporation increases because our blinking is less, and whatever blinking we do, that is also many a times inadequate blinking. Mask associated dry eye, this is something which is new. What we have come to know during this lockdown is, what happens when we wear masks. The masks are many a times not very tight, so sometimes when they are not tight, they are kind of the whatever air which we are exhaling, that kind of releases from the upper side, and that causes more evaporation of the tear film. And there are some people who kind of, to make the mask very nice and tightly snug fitting, they put the sticking on the mask, and what that causes is that sometimes pull your lower lid, and that can cause a little bit of artificial leg ophthalmos, and that will again cause more evaporation of the tear film, and thus the mask related dry eye started coming into the picture. In fact, I had this little peas in my one of my eyes because of the constant mask usage. So these are again the graph where it has been shown that worsening of symptoms has been there because of the mask much more in patients who already had some amount of dry eye disease, and all these things in pandemic has increased so much more compared to people who did not have dry eye disease earlier. It's the same thing again. More the hours of mask usage has caused more worsening of the symptoms, as it is shown by these dark gray bars. Sanitizer induced dry eye. Now, how does sanitizers induces this? Because whenever we spray the sanitizer, first of all, it releases a lot of aerosol, so that causes a kind of pollution which will lead to your dry eye, and it causes more evaporation of the tears. So how do you prevent this? Try to kind of, first of all, unnecessary. We were in that panic mode, used to kind of had become obsessed with using sanitizer, that we need to kind of take care of. Use it whenever it is required. Second, try to keep the eye closed when you are kind of pushing the nozzle. It should be below your eye level. Try to have a good ventilation instead of the closed rooms and things like that, which we need to kind of make people aware from all these things, because these are the small things, and together they can cause a difference in the thing. Again, vitamin D deficiency, which causes dry eye. Now it is very well proven the inflammatory role anti-inflammatory role rather, and the and the effect of vitamin D on immunity. It has been proven pretty well now, and we all know that a lot of times the vitamin D deficiency causes a lot of pain in the eye. It's more of like, more than the signs, patients will have more symptoms. So it is very, very important to see vitamin D levels in patients where we do not see a proper cause for the dry eye, but patients do complain of a lot of pain. Now again, this has become quite a lot, because especially more in the children, because the outdoor activities have reduced so much during this pandemic that vitamin D deficiency related dry eye has also increased. So impact on patient, as we have discussed earlier, that it causes a lot of negative impact in terms of physical symptoms, in terms of emotional symptoms and financial symptoms. So it has a big negative impact on our quality of life. Patients have become, as we have seen in this chart, there are a lot of things which are emotionally, we can see that this dry eye disease has affected people during this pandemic. Also, the another thing what we spoke about was the sleep disorder, because of all this anxiety and the uncertainties which this COVID-19 pandemic has caused in our life. The sleep disturbances we've seen more, and that leads to disrupts the lacrimal system, which adds to our cause of dryness. All these things, whatever we spoke, digitalized strain or the mask related things or sanitizers or vitamin D deficiency or sleep disturbances, they have all the mechanisms which would lead to either higher tear evaporation, or there is some kind of an inflammation in the tear film, or there is less tear secretion, and that all will lead to tear hyperosmolarity. Now what happens when the tear hyperosmolarity increases? There are a lot of increase in the increase in the inflammatory cells in the tear, which will cause tear film instability. And once your tear film is unstable, it causes a lot of apoptosis of the cells related to inflammation also. So if you do not treat it, it will cause the permanent or a chronic ocular surface damage. But if you treat it, they will restore, the cell volumes will restore, and you can prevent the further damage of the ocular surface. So the patient, the approach towards the patient should be, yes, we need to first of all make patients aware that the screen usage should be less. There should be frequent breaks during the screen. The screen should be at the lower level of the eyes, because if it is at the level of your eye, your palpebral aperture is wide and there will be more evaporation of the tears. So it's a good idea to keep the screen at a lower level. Then again, the mask related thing, we need to kind of, not that much can be done about it, because if you have to wear it, you have to wear it. But what is more important is to keep lubricating your eyes. Again, the other effect which was happened during the pandemic is in the strict lockdown, people could not approach doctors. They could not get the drops, and they could not get the help, medical help. That also led to a lot of dry eye, which worsened over a period of time. But we need to make people aware, and with time, things will get under control. At the same time, I think there should be some kind of a holistic approach towards it by with the help of counseling and all, and also the importance of vitamin D, which we need to kind of which we need to kind of consider and treat the patients accordingly. Thank you so much.
Thank you, ma'am. Now I'll be summarizing till the results are ready. So the few tips to the residents given by judges. So the first was that your diagram is very important. Whenever you see any findings like any corneal pathology, or you see disc or any retinal pathology, you just try to draw. Whenever you try to draw, then you will be able to see the things clearly. You will be able to see things very particularly. So drawing is very important. Whenever you see any findings, you just try to draw, and your clinical skills will improve with that. The another thing is in all your presentation, there are some ethical consideration. Like if you are taking photograph of any patients, you have to take consent of that patient, and you have to mention that in your presentation that you have taken proper consent of that patient. The third thing is given by last judges, that you should always correlate clinically well. Whenever you see any patient, it is not patient, you have to correlate your findings with investigation. So whatever investigation you are doing, it should be in coordination with the examination findings. It is not like that you will do all sort of investigation for all patients. So investigation should be justified based on the findings. And I'm very much thankful to Mohita ma'am, Purvi madam, was for providing and for giving me trust in me, keeping trust in me. And thank you, Purvi ma'am. And I hope the sessions are all the students have presented very nicely, and a little bit running out of time is okay. And now ma'am is ready with the results. Hand over to you, ma'am.
Yeah, thank you, Dr. Gunjan. And again, before declaring the results, I would just like to say wonderful from everybody and very and the provided judges evaluate, but very learning alternative. They could act one and face kind of discuss from
Ma'am,
the
your
experts.
voice is breaking up.
I think it will be fine. So I'll share the results, the more weighted, and hope all from o'clock AL 4 all those that are here now. So as I said, everybody is a winner. Everybody has presented excellently and very confidently. And again, thanks to WAS for providing all the Gujarat residents this opportunity. So don't get disheartened if you are not in the next slide. It doesn't matter as long as you're here and you're presented on the podium. Coming in slide, declaration of results, and had clear and they'll be winners, and who is also member, that resident will be going on for the further interstate level competition. So fasten your seat belts and await the next slide. And thank all the mentors. Without their support, I do not think residents performed as they have now. So I love round of applause all the mentors, faculty. So these are the results as per the scores provided by. With 118 marks is Dr. Diksha Thorat from Drashti Netralay Dahod. Everybody can just put and I think it should serve as a good encouragement for them. And she is a WAS member, so she pleads for the interesting competition level round. The third is Dr. Shalakapati from both her Dr. Sapre and the on versus secondary election. She is not WAS member. And third, the tie with Dr. Patel, Dr. Kinjal Patel, is from NJ Western Institute, Kinjal from CA Hospital. These members were my and Dr. Dinesh Kinjal's have been Dr. and Dr. Tusha. Hardi presented kinase the radi and had presented on primary open angle glaucoma. Hardi is a WAS member, but Kinjal is not. But since only the first ranking one will go to the higher. Isha, are you around?
Yes, ma'am.
Yeah. So congratulations and get set to move on further.
Yes, ma'am. Thank you, ma'am. Thank you so much.
So once again, congratulations to all the winners and best of luck to those who are proceeding further. And of course, the others who have been in student disheartened has been an opportunity. What matters is learning pearls. Competitions will keep coming and going in life. Don't worry. And all the best. And you can learn from what you have done wrong or you have not performed properly. And this, we also come to the conclusion of this entire program. And before we disperse, I would like to thank everybody. Each and everybody, firstly, of course, beginning from Dr. Mohit and was the team of this program series as well. This initial concept and the opportunities that WAS has laid down for all the youngsters. Thanks, of course, to all the students. It was marathon day with 5-2. And all in all, in spite of all the technical glitches and everything, everybody did very well. So all the students, thank you so much for taking the step forward and participating. Presentations. Thanks, of course, to the 9 judges for sparing their valuable time and not only assessing for the valuable inputs they gave to the students all throughout. Thanks to all the invited experts and faculties for sharing their pearls of wisdom and knowledge. Thanks again is a very small word to express my gratitude to my own core team at the forefront, Dr. Gunjan and Dr. Kamini Prajapati, who have helped to manage all the I look forward to working with them in all my I've also helped in the background with the logistics and for the smooth conduction of the event today in the forefront. Thank you also, Dr. Tejas Shah, who has been with WAS, as we heard in the beginning, WAS Gujarat and all its activities since the time of its inception. And I cannot forget Team Largan for sponsoring this entire series of events, and especially Mr. Mahesh from Largan from Gujarat for all the coordination. And thanks to Bageshwar from WAS for accept and membership support and everything. He is constant on the WhatsApp with me since today morning. And thanks to all the viewers and for the comments that you are sharing. I hope it has been a great learning opportunity for everybody. Thank you again. Congratulations to all the winners and wish everyone a very happy Sunday evening. Thank you. And congratulations again to Diksha.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Bye, everybody.